let me know. ठीक है, I think I'm live, and if there are any issues, you can connect on the AnyDesk at any point of time. Okay, thank you. Take care. Bye bye. Hi guys, very good afternoon to everybody. So let's get started for today. That would be day two of the Resolve Medicine classes. The topic that we were studying yesterday was cardiomyopathies, for which most of you were able to give answers, except for one or two mistakes, which are like the critical ones, in fact. And that is what the examiner usually tries to focus on. So I hope it's clear to everybody that hypertrophy of the myocytes is not a feature of hypertrophic cardiomyopathy, and I will be teaching you the clinical details also. So I want you to continue from page number 32 onwards. We'll be discussing the clinical details of various types of cardiomyopathies. I will also be waiting for another couple of seconds just in case, like if the people are still in a lag or if there's any delay in people joining. And yep, another beautiful day, and we have a lot of challenges on a daily basis to face. So we say that, okay, man, bring it on, and uh, it's like a go-getter attitude that we doctors usually tend to have whenever you walk into a hospital, intensive care unit, whether it's taking a class, whether it's walking into an intensive care unit, you will always be having that goosebumps, and you'll always be feeling that anxiety about what is gonna happen. As a student, you are gonna be like, कि पता नहीं यार मुझे आता होगा. As a teacher, you are like, maybe will I be able to communicate? Will I not be able to communicate? So it's always like, in our field, it's always like we are always on the edge. But yeah, we need to keep our cool and keep doing our job on a daily basis. So that is the primary objective. So with these words, I think the audio and the visual part is perfectly fine, and we can get started. I can see a lot of people there. I missed a couple of names there, like Ajaj and a couple of others. Hi, Raman. Good to hear from you. I'm far from the video. No, I am deliberately kept myself a little smaller so that I can write more of data. So if I come closer, it will not serve any surface because I'm at the extreme right hand side. नहीं यार, वो I need to write today. There's a lot of data that I have to write. Otherwise, this data छुप जाता है. So if I make myself bigger in the video, then that part gets cut off. So this is deliberate. Kal I was a little bigger because I had to write little lesser, but like a lot of technical information has to come. ये बाद में adjust करवा दूंगा. Like what I'll do is, मुझे खुद की आवाज आ रही है. So what I'll do is subsequently, like I'll make myself bigger. When I have to just do the talking and I have to interact with you, I am gonna be the main person taking the slide. But आज थोड़ा लिखने वाला component है ना यार, otherwise that words tend to get a little missed out. So that is the reason. Chalo ji, fine. Let's get started, guys. Somebody said left ventricle failure. Yes, बच्चे, can you tell me a blood test for diagnosis of left ventricular failure or right ventricular failure? Yes, guys. Can you tell me a blood test for diagnosis of left ventricle as well as right ventricle failure? And left ventricle failure would always be like, the lungs would be getting involved. Arey, मैं भूत बन गया यार आज today. Yeah, I will be teaching mostly in English. Sometimes things go wrong. This is called as Murphy's Law. Murphy's Law is Murphy's Law is when you expect things will go right, something is gonna go wrong. So I am a little, I would say I am literally like a bhoot at the moment. That is what you say, a ghost. But the power setup will come back, thankfully. It has come. I said, you walk into something with that goosebumps, and then things go wrong at the last moment. But anyway, let's focus on the core things. So left ventricle failure is a condition where L for lungs would be involved, and the lung involvement would result in development of pulmonary edema in a patient. And the manifestations of pulmonary edema that I described to you yesterday were in the form of obviously shortness of breath, and then there would be orthopnea in the patient, and the person is gonna be like, all sweating, and he's saying, I'm not getting sufficient breath. There would be a drop in oxygen saturation. But at the same time, if it is right ventricle failure, then the rest of the body will get involved. Whenever you read the word right ventricle failure, it is the rest of the body that will get involved. And what are the manifestations of right ventricle failure? This would be pooling of blood in the peripheral extremities. So pooling of blood in the peripheral extremities will cause pedal edema. It will result in like a pitting pedal edema right up to the ankle, sometimes up to the knee joint in the patient. Very good, very good. then there could be possibly an ascites, and कल से भाई हार्ट फेलियर तो पढ़ा है, जो कह रहा है सर हार्ट फेलियर पढ़ा दो, भाई कल हार्ट फेलियर तो पढ़ाया है. Elevated JVP would be present in a patient, that is the prominent neck veins, but it will always be pulsatile. I hope everybody remembers that the only scenario where you get a non pulsatile elevated JVP is the topic of cardiac tamponade. So what we can see at the moment is there is a left ventricle failure, there is a right ventricle failure in a patient, and the blood test that would be present and would be used in the patient is pro-NT, that is N-terminal B-type natriureteric peptide. That is pro-NT BNP is the blood test that is used for identification of congestive heart failure in a patient. What is the leading cause of development of heart failure? Then it is, ये भी तो कल बताया था, like for those who are saying sir heart failure, भाई कल करके रहे थे, that is what we've been studying. Hypertensive crisis is the trigger in majority of Indian patients. Hypertensive crisis, if you go into intensive care unit, 40% of cardio and neuro patients are hypertensive. If you walk into a cardio or a neuro emergency, then you will notice that 40% patients are hypertensive. So it's a hypertensive crisis, and therefore pro-NT BNP, that is N-terminal BNP levels would be elevated. In fact, he can also talk about the shortness of breath in this patient so bad that patient is having breathing difficulty on minimal activity. When I say minimal activity, like in your exam, he said patient is having breathing difficulty on going to the washroom or breathing difficulty on change of clothes. What is minimal activity is like nowadays people in India have a attached bathroom. Like earlier in India, no, people used to have bathrooms which were like literally in the periphery of the house because we used to think that it is impure. Now it's like attached bathrooms to every room. So five steps to the washroom, 5 steps back, and in that the person is breathing very, very bad. So if he says person is having breathing difficulty on minimal activity, then we call it NYHA grade 3. देखो grade 4 तो he will not be asking, because if a person is having breathing difficulty at rest, then it is grade 4. But if it is going to be on climbing stairs, it is grade 2, so that you will be able to solve. So he gave this scenario and the question said that there is a patient who's having minimal activity. No, Karthik, you're wrong. Prazosin was not used in management of heart failure. You were totally wrong in that query. That was a question of chronic kidney disease that we'll be discussing subsequently, where there was a hypertension in a patient and alpha blockers were used. So this is not a PYQ which you are like, it is a CKD patient with hypertension where prazosin is being used. Okay, so when time comes, I will be discussing it. At the moment, whatever is being asked is the points to be focused on. So the investigation that we'll be doing in this patient is pro-NT-BNP, when we'll run an X-ray on the findings also. And the भाई इसके स्लाइड के नीचे लिखना है ये वाला फाइंडिंग्स, वेयर एल्स है ना, एडिशनल नोट्स पेज, या यू कैन राइट अस, you can note in additional page. I think there is so much of space, man, in the, if you're noting in an iPad, you can note here at the end of the page. I mean, I don't have to tell you, yeah, come on guys, you're not a school children that I need to tell you where is to be written, right? Okay. एक्यूट हार्ट फेलियर में बीटा ब्लॉकर नहीं देते हैं. हाँ, बीटा ब्लॉकर्स आर कॉन्ट्रा इंडिकेटेड इन पेशेंट्स ऑफ एक्यूट हार्ट फेलियर ना. दे आर यूज्ड इन क्रॉनिक हार्ट फेलियर. द रीजन इज टैकीकार्डिया. Tachycardia causes clearance of the pulmonary edema component. When the heart will beat very, very fast, it will clear the pulmonary edema component. This is fundamental pharmacology that beta blockers are not, this most doctors are not even aware of this, that beta blockers are not given. So good query. That is a very good question. Okay, I'll write it subsequently. Let me complete. The X-ray will be showing presence of bat-wing pulmonary edema. The X-ray will be showing is presence of a bat-wing pulmonary edema. The X-rays will be like totally white in a person. So we have left ventricle failure, we have a right ventricle failure, and the backup is the investigations that we'll be doing. Now, the point to be remembered is if we ever will say the word पेरिकार्डियल एफ्यूजन में लाउड S1 होता है. क्यों भाई, कैसे हो जाएगा? हार्ट के आसपास पानी है तो सॉफ्ट S1 हो जाएगा ना. इट वुड बी अ सॉफ्ट, नॉट अ लाउड S1. इट विल बी डिस्टेंट हार्ट साउंड दैट वुड बी प्रेजेंट. So if a person is having acute heart failure, we don't use digoxin. It is LMNOP that will be used. And in acute heart failure, what is going to save the patient? What is going to save the patient is fast beating of the heart will clear the pulmonary edema. Fast beating of the heart will clear the pulmonary edema. If I will block this tachycardia, then in those circumstances, if I will block the tachycardia, then in those circumstances, the person will actually die. So beta blockers are not going to be used, because what is going to save the patient is tachycardia causing clearance of the pulmonary edema. And if by mistake I give beta blocker, I am literally preventing I'm reducing the chances of survival. So beta blockers are not gonna be given. Abhi beta blockers are given for chronic heart failure in a patient. So that is the major mortality reducing. Yeah, ACE inhibitors are, तो भी अपडेट बता दिया ना आपको. ARNI is the number one drug, that is the 2026 guidelines ना. ARNI is the mainstay of treatment for patients of abhi, like the update has come that ARNI, so you need to first answer ARNI and then answer ACE inhibitors followed by beta blockers in the patient. So at this moment we are sorted for like what is congestive heart failure, and now we will look at what are we gonna do for this patient. So in the clinical details in a patient, when it comes to hypertrophic cardiomyopathy, the line diagram was discussed yesterday also, but it was a specimen. Now I'm hand drawing this before you. You can notice the asymmetrical septal hypertrophy. Asymmetrical septal hypertrophy. Along with asymmetrical septal hypertrophy, you will also notice that there is a lot of useless muscle in the free wall of the heart. So as a result of the combination of the two, the problem is lying. If I zoom into the diagram, you will notice that the problem is lying at the below the level of the aortic valve. Like this is lot of useless muscle that is present here. This is lot of useless muscle which is present here. So if we are going to be having hypertrophy of the septum, we will be having hypertrophy of the free wall of the heart. Then this is obviously a banana shape. But I want you to focus on something else, and that something else is that there is a lot of useless muscle in the free wall, which is literally like a speed breaker. When the blood will go over the speed breaker, it will cause a decrease in the velocity, and obviously because of the momentum of the blood, I'll say like this: if your car is going over the speed breaker, there will be like jhatka sa lagta hai na, that is the jerky pulse I was saying, a pulses variance. But today what I'm saying is that there would be a slight decrease in the momentum of the exit of blood out of the heart of the patient. This dotted is representing, which I was saying yesterday, that is subvalvular, below the level of the aortic valve, aortic stenosis. I'm not saying that there is a physical narrowing of the aortic valve. I'm not saying that aortic valve is narrow, but the speed breaker which is present below the aortic valve, is responsible for, in this condition, causing a drop in the momentum. So banana shaped cavity is sorted. This is subvalvular aortic stenosis. And then you need to remember a echocardiography finding. This is especially if you're a NEET PG student, because आप वो तो बता ही दोगे ऊपर वाले दोनों. So he will ask you SAM. Now SAM is not some surface to air missile today. It is a systolic anterior movement of the anterior leaflet of the mitral valve. Like he might write anterior wall, or he might just write the word anterior leaflet of the mitral valve. So you just need to remember this word, echocardiographic finding of SAM, that can be seen in 3 dimension in a patient, because this is the 2-dimensional diagram, but the turbulence in the heart will cause displacement of the valve leaflet, so SAM can also be present. Somebody commented very rightly, इसका जो left ventricle है, that is smaller than the left ventricle cavity of a normal person. So end diastolic volume is lesser, and therefore less blood be going out of the heart of this person, which explains the fact that most of the time in these patients the complaint will be, because see, if end diastolic volume is less, cardiac output will also be less. If cardiac output of the person is less, then the blood supply to the heart itself will also be less. Now the coronary blood flow of this person is lesser than what it normally should be. And if your coronary blood flow is less, if you will do exercise, it will result in development of chest pain. So always the question will begin by describing like a person 20 to 40 years of age. You will note here 20 to 40-year-old guy comes to the doctor with complaints of chest pain, and he says, my friends make fun of me कि यार इतनी छोटी उम्र में chest pain चालू हो गया. Normally chest pain on any kind of exertion will be occurring when person is in 50s or 60s. Here he says that my friends make fun of me, like he was dancing at in college festival. Like this is a student in IIT Delhi, and recently Jasmine Sandler had come to do a concert in IIT Delhi, so everybody was dancing in chilling, and this guy, he was also dancing. He started having chest pain, so he told his friend, and his friend हंस रहा है, अरे तेरे को इतनी young age में, अरे तू कमजोर है, right? They're literally making fun of him. So he is not able, he's like a low confidence guy. When he will come to the OPD, you will notice this is like a low confidence guy, and he says that, sir, my friends make fun of me, I don't feel well. And then he says, I have chest pain on exertion, and sometimes it has also hampered that he became unconscious. Like in the college fest, there was a basketball tournament going on. So it is like MAMC Delhi, Maulana Azad Medical College New Delhi versus IIT Delhi guys. Right? Everybody is like, I am the best guy. Everybody is putting his best effort. And today, like though he has had syncopal attacks earlier, but today this guy's team was less on one guy. So his friends told that today is your lucky day, you get to be on the team. So he's all pumped up, right? He went into the basketball match. He asked his friend also, he asked his girlfriend also, make a video of me today, while I'm playing basketball and I'm gonna score a three-pointer. I'm gonna do that dunk, jump and then throw the ball in the net. I mean, this guy is trying to do what his body is not designed for. So there is, unfortunately, like when he was trying to play, basketball, like, it requires a bit of stamina. So when this guy was trying to, do that physical exercise, unfortunately, during that basketball match, he collapsed on the pitch. So everybody thought that, somebody has fallen accidentally. It can happen, no? Like you are running, and if you're not using proper kind of shoes on the basketball pitch, like, if your foot slips, you can slip and trip also. So everybody thought that it's just a malfunction, like the guy fell down. He did not get up. So the guy closest to him, he called out, "Hey, buddy, come on, get up." He's not getting up. So when he rushed to him, like 2 steps, and turned him, he was lying face down. So when turned him, the lips were all blue. The guy was gone. So most of the time, whether he says sudden cardiac death in a basketball match, sudden cardiac death in a cricket match, it really doesn't matter. I mean, these are the usual scenarios that would be given to you in the paper. And I think even before I said it, you guys anyway know that this is gonna be hypertrophic cardiomyopathy. Can you tell me the cause of death? No, TMT will never be normal. But उसने कभी कराया ही नहीं ना यार. He never went for a medical checkup. Most people at young age, if they have chest pain, they'll think it is gastritis, or his friends will say you are imagining you are having chest pain. I think you need psychiatric treatment. So yeah, it is a ventricular fibrillation, because ischemia, na, that is what we've been discussing yesterday. Ischemia causes ventricular fibrillation in this patient. So the bad news is this guy has died, and now his younger brother has today come to the OPD. He told me all this story. Sir, my brother was at IIT Delhi. He unfortunately died. And his brother is asking you, sir, can this happen to me also? So I will be explaining. Yes, ARVD will also be having the same thing. So now in those circumstances, when you are doing a medical checkup of any young guy, forget about this history. Forget about this history. If you are planning to give medical certificate of fitness to ever to any young guy, if you're planning to give medical certificate of fitness to any young guy, for like now summer vacations are starting, so lots of time in colleges, like they'll give coaching for like basketball, swimming, etc. So you always need a doctor's certificate of fitness. You need a doctor's certificate of fitness. So you must always check the pulse of a patient. Without checking the pulse of the patient, never write on the file fit for athletic activity, because tomorrow if he dies, it's on you. This happened in Delhi, in Gurgaon. Like, this mother, she came to the doctor, her family physician, and said, my son is very busy. He's in the school, in the classes. Can you just give a medical certificate of fitness? They're taking these boys for rock climbing in Aravalis. Like, you go from Gurgaon to Manesar, you have these rock formations present. So a couple of people, like on the weekend, go for this rock climbing thing. Now for the rock climbing, again, the problem is like you need a bit of physical stamina, no, to be able to do that rock climbing. And this guy died. And that was like, then the family turned against the doctors only. Oh, how did you give a medical certificate? So if patient is not present, never give medical certificate. It's a crime, guys. Never give medical certificate in the absence of a patient. The pulse you will encounter in the young guy would be pulsus bisvarians. As you are commenting genetics, I will write subsequently, this is a genetic disorder. Pattern of inheritance is autosomal dominant. What they've asked, however, in NEET PG, till now it was like typical NEET PG combination, FMG, MCQ. In NEET PG, they've asked about the murmur speciality of this condition. To write down the murmur of this condition, first I would like to once again visit the mnemonic pass. Yesterday I taught you pulmonic stenosis and aortic stenosis results in ejection systolic murmur. Here the problem is not at the aortic valve, just below the aortic valve, So the murmur in this condition will still remain the same. That would be a ejection systolic murmur, but now comes a critical difference. For the critical difference, I want you to note down that normally all murmurs in the heart will decrease with Valsalva, standing, and amyl nitrate. All murmurs will decrease with Valsalva and on standing and on amyl nitrate inhalation. The logic is that when you will stand, then less blood will go to the heart now, because there is a peripheral pooling of blood. The common thing between Valsalva, standing, and amyl nitrate is that in all three of them, less blood will be going to the heart, so the murmur will become lesser. I repeat that again. If you stand, there would be blood pooling towards your feet. So less blood is going to heart. Less blood means less noise. So normally all murmurs become lesser in intensity with Valsava, standing, and amyl nitrate, except the topic of interest, that is the current topic that is being discussed, hypertrophic cardiomyopathy, because it is abnormal hemodynamics in the heart. You are having septal hypertrophy, you are having that banana cavity, you are having subvalvular aortic stenosis. So because the hemodynamics are different, except for hypertrophic cardiomyopathy, the word except is obviously will not be written in the MCQ. The word written in the question would be ejection systolic murmur becomes louder. Normally all murmurs will become less by default, guys. By default, the rule is all murmurs will become lesser with Valsava, standing, amyl nitrate, but in this case the murmurs will become louder. The reason why it is louder is different hemodynamics, so I'm writing it once again, though I could have avoided writing it. Valsava, standing, and amyl nitrate would result in murmur becoming louder. This was a pickup point in a NEET PG MCQ that I have currently discussed with you. Like, he did not write the word pulsus visvarians, he did not give that classical history of sudden death in the elder brother. He just said a young guy has come to the doctor and like he's having usual episodes of syncope. And then he said the doctor auscultated a murmur which is becoming louder with Valsava. Like, the classical history was not given. If he wrote basketball, cricket and stuff like that, unconscious syncopal attack, so it would have been easy. So he deliberately tried to, reduce the information which is given in the question. And then, like, you had to basically work out that the ejection systolic murmur in this condition will be louder with Valsava, standing, and amyl nitrate. So just remember that chota sa aberration. And now you guys can start hitting the comment button once again. What is the treatment or choice for this person from the perspective, like, this person, unfortunately we lost him. How do we prevent sudden death in his younger brother? How do we prevent sudden death in the younger brother? Yeah, by default, all murmurs will decrease. All causes, pulmonic, aortic stenosis, all murmurs by default, MS, MR, all murmurs, systolic murmur, diastolic murmur, जितने भी murmur कल पढ़ाए थे, सभी less हो जाते हैं Valsava standing पे, except for HOC. Yeah. The main treatment for this patient is implantable cardioverter defibrillator, that is ICD. That is the main treatment in this patient. Then, no, in your prep version notes, opposite is written from the perspective that you have to read the data carefully, that this is a normal data, that all murmurs will decrease Valsava with standing and amyl nitrate. This is normal information first. And then what will happen in hypertrophic cardiomyopathy is ulta, that the murmur will become louder with Valsava standing. That is the reverse finding that is given. That is where the color change has been done also. So implantable cardioverter defibrillator is the best way for management. Additional strategy which we can use in this patient is alcohol-based septal ablation. This is the first and the last time that I'm saying that alcohol will be used. Alcohol will be used for management in the patient. So alcohol-based septal ablation will be used to destroy the useless muscle, and therefore the prognosis of the patient can be improved. But a lot of people may not be having money to 3.5 4 lakhs for an implantable cardioverter defibrillator. So it is going to be propranolol, a beta blocker, that will be used in this patient along with disopyramide. So if he says what are the drugs that are used in this condition, disopyramide is an antiarrhythmic drug. So when you give antiarrhythmic drug to somebody daily, then the objective is to reduce the chances of arrhythmia in a person. So if he says medical management, if he specifies the word medical management, then it is drugs. But considering that I said the treatment of choice for this condition is, then it is implantable cardioverter defibrillator. Alcohol based septal ablation means that we will be injecting alcohol here. We will be giving alcohol injections into the interventricular septum. Look at the tech we are having. We are injecting alcohol into the septum, and when you inject alcohol into the septum, alcohol causes necrosis. So you will reduce the obstruction in the left ventricle. This speed breaker will be destroyed, not immediately, after a couple of weeks. Like, if you give the injection at the moment, so you will be like, this, if you inject alcohol today, so after 6 weeks from today, this useless muscle is gone. If you inject alcohol in this particular patient, then after 6 weeks, you will notice that the useless muscle will be gone. So you will notice the cavity of the ventricle will become slightly bigger. If the cavity will become bigger, more blood will come in the heart, more will go out. So coronary blood flow in the patient will also be used. So alcohol-based septal ablation, this is the only time when alcohol will be useful. I said we injected alcohol today in the septum, and 6 weeks from today, This is the situation. Now the cavity will become bigger than what it was originally, and if the cavity size will be relatively bigger, then yup, what you will find is the cavity is relatively bigger. So I mean the cardiac output of the patient will improve. So I'll go back to the original diagram. This is how it is. After alcohol-based septal ablation, the situation changes. So this is the data that you need to remember for hypertrophic cardiomyopathy. And in pathology, they've already told you this, but I'll still write it for the sake of completion. Optional if you want to note down, because this is all covered in pathology. That is what is the pattern of inheritance of this condition. So you know it is autosomal dominant condition. Family history will be there. The defective gene in this patient would be MYH7 gene. This MYH7 gene will be coding for a protein by the name of beta myosin. That beta myosin is the major protein in the cardiac muscle. And in this condition, that beta myosin gene is basically causing a defective expression of beta myosin protein, because every gene will be expressing a protein. So genetics, I don't think so will be too, important from the medicine perspective, because that is covered in pathology. So I had to speak about it. So मैंने add कर दिया chromosome 14, MYH7 gene, beta myosin, etc. But then mostly in the clinical domain question, he will ask you regarding these words like bispherians, ejection systolic murmur, the SAM findings that I've currently highlighted at the moment before you. So this is an autosomal dominant condition. And now we will compare this condition with dilated cardiomyopathy. Dilated cardiomyopathy, when you look at it, it is a patla heart. So in patla heart, the reasons can be manifold. The number one reason why like dilated cardiomyopathy can occur in a person happens to be alcohol. That is long-term alcohol intake. Second can be a connective tissue disorder, which is like by the name of sarcoidosis. And the third can be Duchenne's muscular dystrophy, जिसको हम neurology में पढ़ेंगे, where you read about Gower sign. But yeah, I mean patients of Duchenne's muscular dystrophy, they can die because of congestive heart failure. COVID is unlikely. I mean, luckily, like COVID में myocarditis हुआ, but like the dilated, it can occur. I mean, COVID can cause a dilated cardiomyopathy. So I will now focus on the right hand side for the dilated cardiomyopathy, like what are the words that will be written in the question. So it is obviously a thinned out muscle. I mean, it will say thinned out myocardium. The total on the left hand side, I said a mota heart, like the heart is having more muscle. Here the muscle will be less thinned out myocardium, destruction which is happening. And overall there is a change in the shape of the heart. I mean the heart in this case would be like a globular heart. It's like a enlarged, it's more like a oval shaped heart. It's like an enlarged globular heart. So most of the time in the MCQ, the hint, what is the key word in the question will be, the keyword in the question would be global hypokinesia, because if you lose cardiac muscle, then it will lose the takat or ability to contract. If the thickness of the heart wall is lesser, then you lose the ability to contract, and therefore in these patients there would be a, guys, we have already discussed cause of death is ischemic ventricular fibrillation. Now we have discussed that yesterday also. Global Divya, the answer is ischemic ventricular fibrillation. Global hypokinesia is where the total contractility of the heart will be relatively lesser. That is like damaged heart, the myocardium is having less power, and therefore two words from the pathophysiology perspective is thinned out myocardium and global hypokinesia. What will also happen in this condition is that because of the dilatation of the heart, the tricuspid valve annulus and mitral valve annulus will also dilate. The tricuspid valve annulus and the mitral valve annulus will also dilate. This will cause lack of approximation between the mitral and the tricuspid valve leaflets, because we have a ring around which the valve leaflets are present. Now, because the tricuspid valve annulus will dilate and the mitral valve annulus will dilate, it will result in blood to leak from the left ventricle and right ventricle into the left atria and the right atria. And therefore, in these patients, mitral regurgitation would be occurring. Like in this particular case, I'm saying blood is leaking from RV to RA. The reason for this blood leaking from RV and RA is not because I never said problem is in the valves. I said जहाँ पे valve का peripheral attachment होता है, the peripheral attachment of the valve is the problem in this patient. So the question in this particular case for the question of dilated cardiomyopathy will begin by describing a patient who's having heart failure findings. And what will be written in the question, that will tell you that this is a question not of routine heart failure, but heart failure with due to cardiomyopathy is the word dicrotic pulse. The question will mention dicrotic pulse. The remaining things in the question would be like he will say patient is having swelling in the feet. He will say patient is having breathing difficulty. There is a pulmonary edema that is present, which is causing shortness of breath in a patient. So if you read a question on pedal edema and pulmonary edema given together, it means it is heart failure. But then how do you know in a question that it is heart failure caused by dilated cardiomyopathy is the word dicrotic pulse? And additional to this, there would be also the mention of the word functional, like the murmur in this condition. I'm saying functional. I'm calling it functional because there is no disease of the mitral valve. There is no disease of the tricuspid valve. What is happening is the mitral annulus is dilated. The tricuspid annulus is dilated. So that's why the word used is functional. There would be a mitral regurgitation and tricuspid regurgitation occurring in a patient. I have already explained to you that the murmur that is present in mitral and tricuspid regurgitation is called as a pan-systolic murmur. So the main feature that is seen in these patients would be pan-systolic murmur is the main manifestation for cases of dilated cardiomyopathy. You can easily solve the question on the basis of dicrotic pulse, but this word will usually be hidden. Like he will try to hide the information between the breathing difficulty, pedal edema. He will deliberately give vitals also, decreasing oxygen saturation. So it is one word that you're hunting for in the entire 3-liner 4-liner question that will tell you that you're dealing with dilated cardiomyopathy. It can have genetic basis also, it can be familial basis also, agreed, but it does not follow Mendel's law from autosomal dominant inheritance. Unlike hypertrophic cardiomyopathy, where it's a guarantee that it will express in every generation. Dominant word tells you that it will be expressed in every generation. Dilated cardiomyopathy may not be expressed in every generation. And now it comes to what will be used for the treatment of this condition. So you guys, global hypokinesemia, no. No, global hypokinesia is a word for global ka matlab all 4 chambers are dilated. Global matlab sab jagah na. So in hypertrophic cardiomyopathy are all 4 chambers involved? Nahi na. Hypertrophic cardiomyopathy is a disease affecting exclusively the left ventricle of the patient. It does not affect the right ventricle. It does not affect the right atria of the patient. So global word nahi aayega na. Global hypokinesia is the key word in echocardiography. Just like Sam bata raha tha, वैसे ही the global word is present. Yeah, obviously we will plan to do a cardiac transplantation in a patient, but वो तो ideal situation हो गया ना. I mean the point is that cardiac transplantation is something that may not be possible always because we will require a brain dead donor for it. So can I have practical answers for management of this condition? Yes guys, hit the comment button please. Yup. One of the main approaches that we will be using in this patient, no यार inotropes रेउस थोड़ी ना देंगे, ideally थोड़ी ना उसको NORAD का infusion चलेगा. So what we will use in this patient is first cardiac resynchronization therapy. कल मैंने बताया था कि in refractory heart failure, this is the patient of refractory heart failure. दवाइयों से heart failure नहीं ठीक होगा इसका. So we will go for cardio. Yeah, we might be using it only like if it's a new drug which is available, no? But it is not a routine treatment that is given. So in your exam, if he says treatment of choice, then you will not answer any new drug. It is the implantable cardioverter. Only in medical management that the new drugs can be used. So cardiac transplantation is the ideal thing. For management of this patient, it is CRT, that is cardiac resynchronization therapy. CRT is the main treatment that will be used. That is because left and right ventricle is not contracting together. And nowadays we have technology where we can combine the two, CRT with implantable cardioverter defibrillator. तो दोनों लगा देंगे. Cardiac resynchronization therapy से क्या होगा? That both left and right ventricle will contract together. And ICD simultaneously will put that will deliver a DC shock and will terminate the arrhythmia. So CRTD, that is what I was describing yesterday for refractory heart failure, cardiac resynchronization therapy in these patients with implantable cardioverter defibrillator will be one of the main approaches that we'll be using. Apart from this, because these patients can develop clots in the left atria, so that is supportive treatment कि भाई पता है कि clots बन जाएंगे, तो we will be using warfarin in this patient. We might be using diuretics in these patients. That could be like spironolactone because I want to reduce the pedal edema in a patient. In fact, in some cases, we might even be using digoxin, but he will not ask you regarding the drugs for this condition. He will ask you what is the major mortality reducing intervention that would be done, and cardiac transplantation is not in the options. Then the main treatment that will be doing is CRTD, that is cardiac resynchronization therapy with implantable cardioverter defibrillator will be used for management of these patients. So a lot of data today, and that is why my size is chota, because there was a big table that I had to discuss here, very classical hypertrophic and dilated cardiomyopathy comparison. And now we will talk about RCM, restrictive cardiomyopathy. Restrictive cardiomyopathy is the rarest type of cardiomyopathy. This rarest type of cardiomyopathy will have lots of causes. Therefore, let's also practice the causes for this cardiomyopathy. That is, one is obviously amyloidosis. This is one. But after amyloidosis, the second cause can be, he can give a situation like this lady had breast cancer and it was a recurrence of a breast cancer. All of you are aware that when you have recurrence of breast cancer, then you don't do, like you can't you will not do surgery again. She's already undergone a MRM. So we will do radiation to the chest. And if you give radiation, then the fibrosis in the heart can occur. So amyloidosis, radiation are two important reasons that I want you to remember. Sarcoidosis can be contributing to both of them. Sarcoidosis is unlikely to be asked because there are so many other things in sarcoidosis that they will ask you, which we will discuss in the later part of our discussion. But non-caseating granulomas can contribute to damage to any part of the heart. So you could be having any of the two, but amyloidosis and radiations are the important one. Overall, the most common cause of radius cardiomyopathy happens to be amyloidosis. From the histology perspective in this condition, as I explained to you, they will give you a specimen. And in the specimen, what will happen is कि अगर वो आपको फोटो देता है जिसमें all four chambers of the heart are bigger, global, then it is dilated cardiomyopathy. But if the atrial size is bigger than the ventricular size, then you will say that I'm dealing with, this is the gross finding that will be seen, that is atrial size more than the ventricular size. But on a microscopy, what will you be noticing in this patient? Then on a microscopic examination, the main finding of restrictive cardiomyopathy on the microscopic examination, the main finding in this patient will be that you will have to put on a special stain, no? That would be like that blue stain that they show in pathology for fibrosis, that is collagen deposition, that is Mason trichome. So Mason trichome will be showing extreme blue positivity in the myocardium, that normally the myocardium should all be pink, hematoxylin eosin stain, but when you use that Mason trichome, there would be excessive blue in the myocardium because there is a fibrosis which is causing stiff ventricles in a patient, The highlight of this particular condition is that amyloid तो routine pink ही दिखाई देगा ना, but if you are using a special stain, तो special stain कौन सा लगा है? वो तो Mason trichome है. Mason trichome is a special stain for collagen that you are using. This is basically a stain for collagen that you are using. Otherwise जो routine hematoxylin and eosin होगा उसमें तो pink ही दिखाई देता है. Amyloid will be either pale pink or it would be Congo red stain, the apple green birefringence. But if you want to demonstrate the collagen component, then the collagen in the patient will be blue in color. So pink is if it's routine hematoxylin eosin, like I showed you a slide that was pink only, that is hematoxylin eosin stain. But usi pink mein there could be like, if they want to demonstrate the fibrosis, it is Mason trichome. The highlight is this condition will be having patthar ka heart. What I mean by patthar ka heart is stiff ventricle, and therefore the differential diagnosis of this condition is constrictive pericarditis. The differential diagnosis of this condition is constrictive pericarditis. In constrictive pericarditis, the problem is outside the myocardium. Here, the problem is in the myocardium. Yeah, with amyloidosis also fibrosis will be present. Now, amyloid is a protein that is irritating. So along with that, fibrosis will also be present, but fibrosis will not be seen on hematoxylin eosin ना. तभी तो बोला उसके लिए Mason trichome stain लगाना पड़ेगा. Why amyloidosis is causing? Why is there? I mean, restrictive cardiomyopathy. Amyloid protein is an abnormal misfolded protein. That abnormal misfolded protein will cause fibrosis. That is why I said इसमें पत्थर का heart will be present. So our objective will be now to differentiate how is it to be picked up in a question, whether it is constrictive pericarditis or restrictive cardiomyopathy. Let's look at the data. The pulse in this condition of restrictive cardiomyopathy, इसमें भी हो सकता है that the less blood is coming in the heart, less is going out of the heart. So pulsus paradoxus can be present in this condition also. I've written plus minus to say pulsus paradoxus can be present in restrictive cardiomyopathy also. I told you yesterday, useless term. It actually does not help in interpretation or any diagnosis. So pulsus paradoxus is totally out of the discussion. Now, like what will be the JVP finding in this condition? The JVP finding in this condition is by the name of Kussmaul sign. Yesterday we did the mnemonic COPS restrict right heart. So when I was saying the word restrict, that would mean Kussmaul sign that would be coming up. So when you will read the question, he will give you pulsus paradoxus with Kussmaul sign. उसके साथ में क्या क्या दिया होगा? Additional features will be traditional heart failure findings in a question because the heart is stiff. So compliance of the right ventricle will become lesser. What will happen is, because the heart is patthar ka, so the compliance of the right ventricle will be less. Less blood will come to right ventricle, so there will be a pedal edema developing in a patient. If less blood will go to the right side, there can be pooling of blood in the peritoneal cavity that will cause ascites in a patient. He may not write the word ascites, he may write the word abdominal distension, तो वो आपका time waste करेगा. This is time wasting tactic of the examiner. What I'm writing in blue is the time wasting tactic of the examiner to increase the length of the question. He will give you findings of decrease right ventricular compliance. He will give you findings of decrease left ventricular compliance. So he will say shortness of breath. He will say orthopnea. He will say effort intolerance, because if less blood will come in the heart, less will be going out now. If less blood will come in the heart, less will be going out also. So that would be effort intolerance. So the message here is that the examiner will try to eat away into the precious seconds that you have to solve the question by giving you the data in blue. But what will you pick up in a question would be what I say subsequently. Like pulsus paradoxus is okay, उससे भी diagnosis नहीं बनेगा. वो small sign, उससे भी diagnosis नहीं बनेगा. तो आपने पकड़ना है क्या इस question में? He will say workup of the patient was done. And when the workup of the patient will be done, then either of the two investigations will be given in this question. Either it will say cardiac MRI or it will say endomyocardial biopsy, because this is something which is very, very peculiar to the heart. Restrictive cardiomyopathy diagnosis cannot be made easily. One of the former Pakistani generals, this guy was responsible for Kargil war. His name was General Parvez Musharraf. He invited the Prime Minister of India, Atal Bihari Vajpayee sir, the guy who gave us the nuclear bomb. The guy who gave us the nuclear bomb, Atal Bihari Vajpayee sir, he called him to Lahore. He said, sir, we'll do a bus ride, and the bus ride from was Punjab to Lahore. And like sir went to Lahore as a gesture of goodwill. And the moment he came back to India, they sent in bombs flying. है ना, पीठ में खंजर मारना बोलते हैं ना. So on a, like imagine like the Indian Prime Minister goes to Pakistan, to Lahore, and it's all hugs and smiles and flowers and everything and dawat and biryani and everything, and you come back to India and the next day there are bombs flying in, and then they shot down a MiG-21. They captured a pilot, और उस pilot को capture करके they cut his genitals, they took out his eyes. I was a medical student at that point of time. They took, you read about it, they took out his eyes, they cut out his hands, nails वगैरह करके टॉर्चर वर्चर करके बॉडी भेज दिया हमारे पास में, गिफ्ट फ्रॉम पाकिस्तान. General Parvez Musharraf was suffering from restrictive cardiomyopathy. He was that, beaming general, tall Pakistani Pathani guy with the big medals. And he was not diagnosed with restrictive cardiomyopathy by Pakistani doctors. He was diagnosed in Dubai by Indian doctors. Indian doctors in Dubai diagnosed Pakistani general. He died in 22-23. Just Google General Parvez Musharraf, restrictive cardiomyopathy. You'll see a picture of him. One picture, that, tall Pakistani Pathani guy with that big medals, and then you see him lying on a deathbed, right? So, I mean, the point is karma catches back in the same generation. You break somebody's trust. God says, okay, I'm going to punish you here only. So anyway, coming back to the aspect at this particular point of time. Yep. Let's focus at this particular point of time the data which is to be remembered. Small sign, yeah, there was search party that went in. They were also captured. So there are two different episodes that are to be remembered. One is the search party guy was captured, the pilot was captured. Anyway, coming back to the agenda, let's not get into that. What I want to tell you is what will be given in the question. You can see very non-specific data. That is why the Pakistani doctors were missing, and maybe the American doctors were also missing. So one Indian doctor working in Dubai, when he showed to him, he realized that something is wrong there. And what he ordered was a simple cardiac MRI in that particular case. And when the cardiac MRI was done, that revealed evidence of fibrosis. So that is the main thing, guys, which I this is optional. I mean, don't draw this at the moment. Just follow my words there, because I have already explained this to you. You can imagine this to be the cardiac muscle fibers. This is cardiac muscle fiber. This is cardiac muscle fibers that I have currently shown before you at the moment. Now, what I want you to understand is that in constrictive pericarditis, there is a calcification outside the heart. So, जो मैंने काले में बनाया, what I made in black is the fibrosis outside the heart that we discussed yesterday. If it is constrictive pericarditis, then what is the word? You don't need to note down, otherwise you will get confused later. What will be the word written in the question? If it was a question on constrictive pericarditis, was pericardial shudder. If pericardial shudder is given in the question because the blood is bouncing off this area and there's a turbulence that is coming up, so I know that this is going to be a finding that is very, very characteristic of constrictive pericarditis. But in this condition, guys, what is happening is, look at the white color that I will be doing. That is going to be fibrosis. Then it is going to be fibrosis in the cardiac muscle. It is fibrosis in the cardiac muscle. So I wanted to have a mental image of this. Restrictive cardiomyopathy and constrictive pericarditis are examples of patthar ka heart. but stony heart. But then in stony heart, one is fibrosis in the muscle, second is gonna be the fibrosis, second is calcification outside the heart, that is shown in black. Calcification is shown in black, fibrosis is shown in white. And how can you differentiate? You cannot differentiate clinically. It is just like any other heart failure. It is cardiac MRI which is the main imaging modality of choice for this condition. So if you read a question that says cardiac MRI was done in a guy with heart failure findings, or if you read endomyocardial biopsy was done and it is showing fibrosis in the heart, that means that this question is dealing with restrictive cardiomyopathy in this particular case. So the most important thing is cardiac MRI and endomyocardial biopsy are two main investigations. If he will ask you what is the gold standard investigation, obviously a biopsy. But then you can understand biopsy is invasive. Biopsy is invasive and cardiac MRI is a non-invasive point. So I want you to realize the fact that suppose they give you a question heart failure कुछ समझ नहीं आ रहा है, but it says cardiac MRI shows evidence of myocardial damage. Quick answer would be that this is fibrosis in the heart due to restrictive cardiomyopathy. To help you, sometimes he might give you a cardiac catheterization finding in this condition. This is again not very specific, but I'm still gonna write it that this will be assisting you. This is called as square root wave sign. So if you are encountering square root wave sign, if given in a question, okay, still I'm not saying it is very accurate. The main thing that I want you to appreciate from this particular discussion is the statement that I said, that if you ever come across a question that is boasting about cardiac MRI being done or endomyocardial biopsy being done, you know, in a heart failure patient it is restrictive cardiomyopathy. This is the most difficult cardiomyopathy to pick up for any doctor. All others are pretty straightforward because there would be either a family history or there would be like some kind of murmurs that would be described in a question. So it is still like, relatively easier for you to comprehend. But when it comes to RCM, that's why rarest cardiomyopathy, obviously, like it's rare and rare diagnoses are difficult to make from the patient. So you can understand we are having a tall order when it comes to identifying this particular condition. And now I will be teaching you regarding what everybody loves to talk about, broken heart syndrome. But broken heart syndrome, the peculiarity that I'm going to teach you, the JVP findings of this particular patient, को small sign, no? That would be that rise of JVP. No? That rise will be because of the non-compliance of the heart that we discussed yesterday. So you can go back to yesterday's discussion for the JVP findings that we had for this one. That is, को small sign is rise. Normally तो हमारा heart जो होता है dilate हो जाता है, relax हो जाता है, compliance, hair पत्थर का heart. So the blood cannot go in the heart, it will pool in the neck veins. That is what is called as को small sign. Yup, exactly, Pranav. That is why I was saying, na, plus minus, that means it is never identifiable. The treatment of this condition, yup, it is cardiac transplantation. How do you manage a patthar ka heart? The only way to manage the patient is cardiac transplantation. So another point I can say is cardiac transplantation will not be done for hypertrophic cardiomyopathy. Supportive treatment that would be done in this patient. Square root wave sign sirf naam yaad karna hai, square root wave. That's again because of blood bouncing against the heart. Na? The blood comes in aise and then bounces off in this non-compliant heart also. So it looks like a maths ka sign. Na? So just have to remember the square root wave sign is a cardiac catheterization finding in this particular case as well. Supportive treatment will be traditional. Diuretics will be given, spironolactone will be given, warfarin may be required in case there is clots in the heart of this patient. So supportive need. The main treatment of this condition is also for all, by default for all transplantations, it is cardiac transplantation except for hypertrophic cardiomyopathy and Takotsubo. Treatment is cardiac transplantation for all cardiomyopathies by default except for one, Takotsubo cardiomyopathy, and second, we will not be going ahead with cardiac transplant. Hypertrophic वहाँ तो already muscle है. So now we will study regarding acute onset cardiomyopathy, that is Takotsubo cardiomyopathy. The broken heart syndrome presentation will mimic MI presentation. Most of the time, like I can say, Japan is one country that is ravaged by earthquakes, and this particular guy went on a tourist visa to Japan for a holiday. Now, unfortunately, like the earthquake, unfortunately for this guy, the earthquake happened when he was in the elevator of the hotel. He was staying at, let me say, a 7-star hotel in this guy, a young doctor on a holiday with his wife. Or like maybe alone, right? Backpacking alone. Young guys like nowadays don't want to marry and they say, I want to see the whole world. Fir baad mein karenge, right? All marriage. So this young doctor, he is like, let me say this young doctor, he cleared FMG exam or NEET PG exam and he said, I'm going to roam the world. And he went to Japan for a holiday. Now, backpacking trip. Now, this particular guy, unfortunately, like he got trapped in an elevator because when the earthquake will happen, then most of the time we are not supposed to take the elevator and we should use the stairs. But unfortunately, like he went into the elevator, उसी time पे earthquake आया, बत्ती भी चला गया, electricity went off. So the whole elevator is shaking. Like he's at the 10th floor, 20th floor. Like in Japan, like the buildings are earthquake proof, but it's like, you know, a very scary situation. If you are trapped in an elevator, वैसे ही लाइट चला जाए तो यार थोड़ा सा डर लगता है. You know, even if you are staying in your society in your lift, you are trapped in an elevator, light goes away, you tend to feel a little scary. But like for this guy, it's like 20th floor, 30th floor, the whole elevator is shaking because earthquake is also happening. So trapped in an elevator during an earthquake, I can say this is gonna be literally like a near death experience for a patient. This is gonna be literally like a near death experience for a patient. And since I'm saying near death experience, there would be surge of catecholamines. टाकोटसुबो कार्डियोमायोपैथी. टाकोटसुबो कार्डियोमायोपैथी क्यों होता है? वाई डू यू गेट टाकोटसुबो कार्डियोमायोपैथी? यू गेट दिस कंडीशन बिकॉज द पर्सन विल बी एंडिंग अप विद डेवलपमेंट ऑफ एक्सेसिव कैटेकोलामिन्स इन द बॉडी. आप बोलोगे सर कैटेकोलामिन्स तो नॉर्मल बॉडी में भी रिलीज होते हैं, व्हाट इज द प्रॉब्लम? It is the surge which is responsible here. What I mean by the surge here is that if there is gonna be like, you know, very excessive amount of catecholamines, they're gonna cause structural damage to the heart. Just look at the heart of this patient. अभी तो मुझे पता भी नहीं, this is Takotsubo cardiomyopathy, but the myocardium is damaged. The myocardium is damaged by too much of anything is bad. The catecholamines are damaging the myocardium, and this ventricle is not taking the shape. The cavity of the left ventricle is not taking the shape of a normal left ventricle. It is taking the shape of like a pot that is used in Japan to trap an octopus. Like, you know, the octopus has tentacles, and it's a delicacy, seafood delicacy. So especially seafood lovers. I mean, normally in India we eat prawns only, no? I mean, nobody eats octopus, but like Japanese love octopus. So that's like a jar that is used to trap the octopus. The head of the octopus goes inside, फिर वो निकल नहीं पाता, so they're able to trap the octopus and then eat it as a delicacy. And the point is, Takotsubo cardiomyopathy was first reported in Japan because, as I said, Japan is a country ravaged by earthquakes. You know, near death experience, Richter scale 7.0, Richter 7 8.0, something like that. So excess of catecholamines will contribute to structural damage in the heart of a patient, and that will result in the following manifestations. So this will mimic MI presentation. This guy, luckily earthquake ended. The earthquake ended और बिल्डिंग collapse नहीं करी. इंडिया में तो बिल्डिंग collapse कर गई होती, बंदा खत्म हो गया होता. In this particular patient, luckily he was saved. But when the emergency crew reached him, he was all shivering. Like this young medical student is all shivering, pasine pasine. Because see, you put it on yourself, sir. You are trapped in an elevator, no electricity, the whole building is shaking. 1 minute the earthquake is going on. Anybody is gonna be shaken apart. So this guy, he's a young person. He told the medical crew, sir, I'm having chest pain. Can I please see a doctor? They said, okay, not a problem. We will let you see a doctor, because the guy was having chest pain at rest when he came to the hospital. You were the physician on duty and you got an ECG done, and there was a ST segment elevation. Again, Japan is open to doctors again, right? You need to learn Japanese for it. It's a little difficult, but yep, I mean, that's again a career that people are taking up. Okay. I also did a blood test in this patient. The blood test that I did was troponin I. All of you know that the biomarker, the biomarker that we use for diagnosis of myocardial infarction is troponin I. So troponin I in this patient was elevated. So this is the story that will be given in the question to you. Like I wrote it simple, mimics MI presentation, पर वो पूरा कहानी सुनाएगा. He will give you an entire story like this. That patient was trapped in an elevator during earthquake, catecholamine surge, presentation like MI, and now we will take the patient into the cath lab for coronary angiography. When you will do coronary angiography of the patient, you expect that this guy will be having blockage in the coronary artery, but the report will be very, very shocking, guys. This is what you need to identify. So I'm doing an ink change at the moment. Coronary angiography report will be saying that the angiography report is normal. Yes, Japan has an aging population. They need doctors, they need medical staff, they need nurses, and mostly the vacancies are being filled by Indians at the moment. It's become saturated. It will become saturated in 1 year, right? It's like that only. Like, you know, suddenly everybody went to Australia, saturated. Suddenly everybody went to Dubai, saturated. So, like, you know, you have to pick up the opportunity, especially if you are that global person kind and you say, I want to look for international opportunities, then yeah, I mean, you do check out regarding whether you, like some people say, nahi sir, apne desh rehna hai. So, but I just wanted to tell you that having that global thing is always advisable. Okay. N2 is the language course होता होगा, that is thing है ना. I think Kunal said N2 ना. I think that's trop I and trop T same man. Troponin I and troponin T बच्चे, they are proteins which are present in the myocardium ना. When the necrosis in the heart will occur, then the necrosis in the heart will cause troponin I and troponin T to be elevated. The most important thing which I expect everybody to appreciate at this point of time is how do you pick up Takotasubo cardiomyopathy in a question. The main word will be, don't bother about all these minor aberrations that are happening. The point is, whenever you read the word Takotasubo cardiomyopathy, the coronary angiography in the patient, the report will be perfectly normal, because there is no necrosis in the myocardium. In this particular condition, it is like the troponin I is elevated because there can be minimal necrosis in the myocardium, but there is no blockage of the coronary artery. I hope it is clear, guys. Takotasubo cardiomyopathy, coronary angiography is normal because this is not a myocardial infarction. It is structural damage to the heart caused by catecholamines, and therefore the person will be present. Yes, troponin T, troponin I, all will be elevated. I will also be elevated, T will also be elevated. If you do CPK-MB, then CPK-MB will also be elevated. All cardiac biomarkers will be elevated. Any one of these that you will be doing will be elevated. So what will happen in this patient would be a development of cardiogenic shock. Due to change in the shape of the heart will not be able to pump blood effectively. And if the heart is not able to pump the blood effectively, then in those circumstances, how would you be managing this patient? So your answer will be that you will be treating this patient with IABP, that is called as intra-aortic balloon pump. The treatment that is used for management of this patient is IABP, that is intra-aortic balloon pumping. That is like a device that will take over the contractility because the heart is not working properly. So the first message that I want to say after coming back to like summary of this topic is that if they ever give you a question where there is findings just like MI but angiography is normal, it is Takotasubo cardiomyopathy. Now there I can give a different explanation for it, the way it was asked in INICET exam. So if you're an INICET aspirant, the description was not the Japan thing that I was saying. In INICET exam, the description was like the husband died in the morning. Like this couple, they've been married for 50-60 years and the husband today is like 75-80, he had stage 4 prostate cancer, he died in the morning. So after coming back from the cremation, the wife also said, I'm having chest pain. So his son, he was like, okay, I'm going to take you to the doctor. And before they could take her to the doctor, she also died. Husband and wife died on the same day because of intense emotional trauma. So the bottom line is catecholamine surge can occur due to like death of a loved one also. So it is not always going to be an earthquake. It is not always going to be an earthquake. It can be something like a close person's death as well. So I would just like to write the word here for broken heart syndrome and additional terminology that is like that is death of a loved one. The statement is that is death of a loved one can also be a clinical situation that is given for Takotasubo cardiomyopathy in a patient. So it's not obviously that 1 month relationship or 2 month relationship. It was like decades altogether, and the death of the loved one would be contributing. Yeah, management is already on the slide. Big fight with family members is like a little unlikely, but yeah, I mean, if you are emotionally attached to somebody, they can still be chest pain, but usually tends to go away. Anyway, coming back to the agenda, what is the management of this condition? It is IABP, it is intra-aortic balloon pump. Don't answer dobutamine here, do not answer NORAD here. Dobutamine nahi denge. Why? Because in this particular condition, catecholamines are already elevated. Don't answer norepinephrine because catecholamines are already elevated in a patient. These drugs are not recommended for management of this patient. This is the only scenario. Yeah, maybe fight with daughter. Okay, fine. Death of a loved one is a more appropriate one. Yeah, the only main treatment is IABP, and this is the only cardiomyopathy that will show a recovery. No other cardiomyopathy recovery is possible, but here recovery is possible probably only after diagnosis is made. The diagnosis of this condition cannot be made in routine casualty or emergency situation. It will always be in the cath lab that the diagnosis of this particular patient would be made. The main aspect is cath lab diagnosis. That's the key word for this question. What is the treatment for this condition? Again, there is no requirement In this condition for cardiac transplantation, there is no need for implantable cardioverter defibrillator. Just take over the function of the heart using a balloon pump that will take over the function of the left ventricle, or dhire dhire the myocardium will come back to normal. What does intra-aortic balloon pump do? The word is English only. In the aorta, there is a pump, right? So it will take over, it will improve the coronary blood flow. Na? The intra-aortic balloon counterpulsation, what it basically does is the counterpulsation will improve the coronary blood flow. If you improve the coronary blood flow, the heart will basically be working relatively better. So this is the only acute onset cardiomyopathy that is to be remembered, where like recovery is possible. And I repeat once again, apart from the routine chit chat that is going on, the only way to identify this condition is cath lab report showing that coronary angiography is normal. That is what you're supposed to pick up in the question. If these words are missed, then this will become a case of myocardial infarction only. I'll just highlight this statement again. How is this condition diagnosed? This diagnosis is missed in the routine emergency. We start wrong treatment of these patients as ST elevation MI, and the person dies in spite of our treatment, and we are thinking, oh, maybe it was a bada heart attack. Now that bada heart attack is extensive interval MI, the person died, but the main thing is the coronary angiography. So moving ahead, guys, this was broken heart syndrome. Death of a loved one can be a response presentation there. And since like myocardial infarction is the next topic that we'll be covering, so I just want to at this moment summarize that these are the critical cardiomyopathies which are to be remembered, and ARVD will come up subsequently when I go up in the slide at the moment. There is no LVOT, then we will use IABP in the patient. Left ventricular outflow tract obstruction. Yeah. Cardiogenic shock, the treatment is, what is the medical treatment for cardiogenic shock? It is intra-aortic balloon pump. What is the medical treatment? The medical treatment for any patient, medical treatment for cardiogenic shock is device treatment is intra-aortic balloon pump. Yeah, the emergency treatment is IABP only. Okay. So next what I'll be describing before you is myocardial infarction. For myocardial infarction, the problem in the patient will be that this is a atherosclerotic plaque in the coronary artery of the patient. You can see a big atherosclerotic plaque. This is the fat deposition in any one of the coronary arteries. Over this area, there will be a fibrous cap. Atherosclerosis क्या होता है? तो atherosclerosis is two layers in the blood vessel. Atherosclerosis is two layers in the blood vessel. The layer on the top will always be fibrosis, and the layer at the bottom will be the fat that is deposited in the tunica intima. This that I've currently shown before you, in pathology they will use the word foam cells are deposited in tunica intima. These are modified macrophages that are filled with the bad cholesterol. I mean, what is a foam cell? In the yellow area, that is fat, that is the symbolic representation of fat. There would be foam cells, and these macrophages are filled with the bad cholesterol, that is oxidized LDL. So this is the starting point for atherosclerosis, and most Indians have these fatty streaks. In patho, the word that will always be written will be like this is fatty streaks that are present. The fatty streaks would mean that there would be like lot of fat deposition in the tunica intima of the blood vessel, and then there is like a fibrous cap that is present on the top. So this is like the traditional atherosclerotic plaque that I've shown before you. And now what will happen is when MI will occur, there will be a development of a tear. All eyes on the board, please stop noting and listen to the words that I say. What will happen in atherosclerosis is, ये ऊपर वाला layer जो है, this is the fibrous cap, and the yellow is the fat that is present. In an atherosclerotic plaque, like this guy is having breakfast in the morning, there will be a tear. The white thing that I've shown is the tear. It's literally like a tear present horizontally in the atherosclerotic plaque, and the movement, like there will be a tear in the atherosclerotic plaque, there would be presence of like the movement, there is a tear present in the atherosclerotic plaque, collagen in the blood vessel will be exposed. And if the collagen in the blood vessel will be exposed, तो platelets इसके ऊपर आके चिपक जाती हैं. So what is happening at the moment is that the platelets are coming and sticking on top of it, and these platelets, when they unite with each other, they will cause platelet aggregation, and a thrombus formation will occur. While I'm describing, in the next 1 minute, this guy will collapse right in front of you, because when collagen is exposed, collagen is like a magnet attracting the platelets. Let me just describe the core events that I said here before you. The core events that I said was, first, there is a plaque fissure. In myocardial infarction, what is the first event? The first event is a plaque fissure. That means there is a tear in the wall of the atherosclerotic plaque. Due to this plaque fissure, collagen in the blood vessel wall is exposed. If there is a collagen exposure, I said collagen is like a magnet. It will attract the platelets. So first there will be a platelet aggregation. That is why antiplatelet drugs would be given in this patient. And after platelet aggregation, the next thing that will happen is that there would be thrombus formation in the coronary artery of this patient. This thrombus will occlude the coronary artery, and that is why hypoxia will occur. That is why arrhythmias will occur in a patient. What I basically wanted to explain to you is myocardial infarction. Please comment in the chat box. What is the most common cause of death in India? Options are like MI, road traffic accident, cancer, or infections. What is the most common cause of death in India? We'll come to the walls. FMG exam question. What is the most common cause of death in India? Road traffic accident. Okay. The most common cause of death in India is myocardial infarction, that is ischemic heart. It is not road traffic accident. Come on, guys. This is an FMG exam question. It was a very simple one. The question said overall, what is the most common cause of death? What is the most common cause of death overall in India and America? Then overall the number one cause is IHD, that is ischemic heart disease. What do you mean by the word ischemic heart disease? It is myocardial infarction. 20% of deaths in India. Rainy days RTA. नहीं वीकेंड्स पे RTA ना, RTA is on the weekends ना. गुड़गांव में देखो ना, है ना, थार चलाते हैं और फिर बाइक वाले को उड़ा देते हैं. Coming back to the agenda, ischemic heart disease or myocardial infarction is the biggest cause of death. The problem is that there would be a tear in the atherosclerotic plaque, and that will result in platelets जो आके चिपक जाएंगी. Then there would be a thrombus formation. This thrombus will occlude the coronary artery. If I show the blood vessel longitudinally, अभी तो मैंने cross sectional दिखाया था ना. If I show the blood vessel longitudinally, what is happening is that there is a huge clot, and this clot, whichever surface of the heart it will block, that particular area will undergo necrosis. This is a huge clot. It will occlude the blood vessel. The cause of tear is structural stress. Na? Atherosclerotic. This is not normal. Na? Fibrous cap is a hard area in the blood vessel. That hard area in the blood vessel will contribute to development of tear in the atherosclerotic plaque, and then you would be causing a development of a thrombus. And due to this thrombus, then zero blood supply, and that will cause necrosis. So most of the time in these patients, the cause of tear, stress, no, structural stress. Blood vessels, whenever they become hard, now old age में जाके blood vessels hard हो जाती है, compliance becomes lesser, and when the compliance is lesser, there can be a tear. I'll say that again. Why doesn't MI occur in young blood vessels? Because your blood vessel is elastic. Your blood vessel is elastic. It can dilate. When blood vessel will become harder in compliance or will become reduced in compliance due to stretching of the blood vessel, this atherosclerotic plaque will tear. So it is a mechanical stress in non-compliant blood vessels. In old age, there is a calcification of blood vessels. There is a non-compliant blood vessel due to which the tear will occur. Coming back to the agenda, there would be necrosis that is occurring. How do you identify the necrosis in this particular question? The necrosis will be affecting various surfaces of the heart. It could be anterior wall or it could be the inferior wall. So at this moment, the most important thing to be remembered is if the ischemia occurs in the anterior wall of the heart. To study the anterior wall of the heart, the ECG changes are seen in lead number V2, V3 and V4. Anterior walls is left ventricle. The part of a heart that is facing the sternum is the anterior wall, and this would be read in V2, V3, V4. Right ventricle right में नहीं होता. Right ventricle is not on the right. Right ventricle is not on the right. The right ventricle is niche. It is the part of a heart that is facing the diaphragm. That is niche. That is what the part of a heart that is facing the heart is, the inferior wall. So the findings in lead number for the findings for inferior wall MI, you need to check out lead number 2, lead number 3 and AVF. I will talk about others only, but for FMG exam, you need to remember only these two, anterior wall and inferior wall. There would be a thrombus. Thrombus in which blood vessel? LAD, left anterior descending artery thrombus. You get damage to the wall of the left ventricle. Which blood vessel will get thrombosed in inferior wall MI? Right coronary artery. So the minimum expectation that is from you at this moment is that if the anterior surface of the heart, LAD, will get blocked, where will you get the ECG changes? V2, V3, V4. If the damage will occur in right coronary artery thrombus, then there would be changes in lead number 2, 3 AVF. 2, 3 AVF is never to be forgotten, because if you check out the questions of FMG exam, they have always been on 2, 3 AVF only. In NEET PG, they will ask you posterior wall MI, that I'll discuss subsequently, but traditional questions are, and obviously NEET PG, they can ask you this also, that is anterior wall versus the right coronary artery in a patient. Question for everybody, tell me the most common blood vessel overall in the body affected by atherosclerosis. What you can see here is everything that I've shown is atherosclerotic narrowing of the blood vessel only. Na? Atherosclerotic plaque has been shown. The blue is the fibrous cap, the purple is the foam cells that I've shown. That is atherosclerosis. What is the most common blood vessel of the body involved by atherosclerosis? Yes, guys, a very easy question. Most common blood vessel. Yep, it is abdominal aorta. Most common blood vessel involved in atherosclerosis overall in the body is the abdominal aorta, and abdominal aorta में क्लॉट वहाँ पे देर इज नो नैरोइंग, वहाँ पे एनोरिज्म बन जाता है. सो आई वांटेड टू अप्रिशिएट दैट ओवरऑल द मोस्ट कॉमन ब्लड वेसल इन्वॉल्व इन एथरोस्क्लेरोसिस इज abdominal aorta. When abdominal aorta is involved, then you will not be having narrowing, then you will be having is a development of abdominal aorta aneurysm. But atherosclerosis, when it will be involving the coronary arteries of the patient, then you will have a narrowing and the tear of the atherosclerotic plaque, because compliance heart की कम हो गई है, elasticity of the heart less हो गई है, that is gonna result in tear of the plaque. The platelets will jump in, the clot formation will occur, and you will be able to pick up the findings in the following areas. The question will begin by standard only. Chest pain occurring in a patient. He will say the word excruciating chest pain. Moving ahead in the next slide, the question will always begin by saying the word excruciating chest pain in a 50-60-year-old man with atherosclerotic risk factors that might be given. The risk factors can be like smoking, diabetes, hypertension. So I don't need to write it, but he will say excruciating chest pain experienced by a patient, and then we'll talk about the radiation of pain. You will say radiation of pain, and radiation of pain will occur to which areas. Hit the comment button quickly. In myocardial infarction, pain कहाँ पे जाता है? So the pain can go to the left arm of the patient. The pain can go to the left arm. The pain can go to the left shoulder of the patient. The pain of myocardial infarction is very severe to the level person may become unconscious, vasovagal syncope. Most of the time the pain goes to the left arm. It can go to the left shoulder. It can go to the jaw. And in some MCQs, like a NEET PG, he will not say like the pain went to the left arm, etc. He will say pain went to the epigastrium. That is the only difference. Like standard atherosclerotic risk factor, it is the left arm, left shoulder, jaw. NEET PG में उसने लिखा pain goes to the epigastrium. And आपको लगेगा यार थोड़ा gastritis, gastritis का बात कर रहा है. The point is, if somebody is having chest pain that is showing a radiation like this, and atherosclerotic risk factors are given or not, even if it does not say non-diabetic, non-hypertensive patient, even then MI can occur. Even if it is a non-diabetic, non-hypertensive patient, even then MI can occur in a patient. Yeah, if he uses the word Levine sign, classical, patient is keep putting his hand on the chest, then it is like super easy for me. But like usually most MCQs, he doesn't use the word Levine sign, क्योंकि उससे फिर तो मतलब वो बता ही दिया ना myocardial infarction है. तो he'll try to stretch your imagination a bit कि यार pericarditis तो नहीं है. Right, but then the point is pericarditis will have a pericardial friction rub. There would be like some kind of URTI history given, TB history given, lung cancer history given, as I was teaching you yesterday. Hit the comment button, everybody. I want, irrespective of whichever exam you're sitting on, please tell me what is the earliest ECG finding in myocardial infarction. I'm waiting for your comments, guys. Earliest ECG finding in patients of myocardial infarction. You want me to give options? Come on, I don't need to say them. Hyperacute T waves, T wave inversion, tall T waves, very good. ST elevation, ST depression. Yes, guys, I want more comments there. Tall tented T waves, hyperacute T waves, T wave inversion, ST elevation, ST depression. What is the earliest ECG finding in myocardial infarction? Okay. Only few people have got this right. I think yes, Priyesh, you got it right. Shashwat, you got it right. Couple of other people. Anjali, now you're saying right. Hyperacute T waves, guys. It is not ST elevation. This is a very simple question that has been asked in the exam. What is the earliest ECG finding in myocardial infarction? It is increase in the vertical height of the T wave. You can draw like this. This is P, this is QRS, this is T. This is Q, this is R, this is T. The vertical height of the T wave in you and me, the vertical height of T wave in you and me will always be less than 5 millimeter. The vertical height of the T wave will always be less than 5 millimeter in you and me, but in myocardial infarction, you have an increase in the vertical height of the T wave. If you have an increase in the vertical height of the T wave, we will call it a hyperacute T wave. We will not call it tall tented T wave. But tall word will not be there. That tall word would be answered for hyperkalemia. That tall word will be answered for hyperkalemia. That is again a question of your exam that I'll be discussing subsequently. That what is going to be the ECG finding that is seen. It would be a tall tented T wave. That is a feature of hyperkalemia. In myocardial infarction, your answer would be given as that the person is... Yeah, I agree. There would be a hyperacute T wave that would be present in this particular patient. So this is the earliest ECG finding that you'll be getting. Then he will say what is the ECG finding that will be persisting for whole life of the patient. Because when you will treat the patient, then ST elevation, ST depression will tend to go back to normal. But when it comes to like one finding that you will answer before me, the finding will persist for whole life of the patient. Like if somebody suffered from MI in 2021, if he comes even today in 2026, that ECG finding would be present. Exactly. The word to be remembered would be, you can also modify in the line diagram that there would be increase in the depth of the Q wave. So ECG finding that will persist for whole life of the patient is deep Q wave. So two questions are sorted. Which is the earliest ECG finding in MI? Hyperacute T wave. What finding will persist for whole life of the patient? It would be deep Q wave in a patient. And yes guys, ST elevation is not the earliest finding. It is one of the findings. So I'll modify the diagram now to say that in 50% cases of myocardial infarction, you might be getting a ST elevation with a T wave inversion. In 50% cases of myocardial infarction, you might be getting is a ST elevation की जगह पे ST depression you might be getting is a ST depression like this with a T wave inversion. So it is not a guarantee that all cases of MI will be having a STEMI. Some patients can be having a ST elevation MI and some patients can be having a non-ST elevation MI. And when you will treat the patient, तो आप देखोगे कि ST elevation back to normal आ जाएगा. When you will treat the patient, you will notice that this ST depression will come back to normal. So 50% cases can be having STEMI and 50% cases can be having a non-ST elevation myocardial infarction. ST elevation myocardial infarction is a full thickness infarction जो हार्ट का पूरा मोटाई है, the entire thickness of the cardiac muscle, the entire thickness of the cardiac muscle in this particular case will be destroyed. But in non-ST elevation MI, it is a partial thickness involvement. I would like to draw parallel here. जैसे आपको पता है कि Crohn's disease जो होता है उसमें full thickness of the intestine is involved and in ulcerative colitis partial thickness is involved. I'll give a parallel example. Obviously like ulcerative colitis and Crohn's is GI condition, but just from the pathology perspective, you are all aware that Crohn's में the whole motai, the entire thickness is involved, full thickness. You call it transmural. In ulcerative colitis, it is a partial thickness. In the same spirit, I'm saying from the pathology domain that in ST elevation MI, it is like a full thickness infarction, full motai is gone, and non-ST elevation MI is partial thickness. The impression in this particular patient, yes, the findings will be present in specific leads. यशोवर्धन अभी तो बताया था ST elevation MI की finding अगर V2, V3, V4 में होती है तो उसको बोलते हैं anterior wall ST elevation MI. अगर ST depression present होता है V2, V3, V4 में तो उसको बोलते हैं anterior wall non ST elevation MI. अगर यही finding 2, 3 AVF में है ST elevation MI of the inferior wall, अभी देखेंगे ना ECG में, और अगर यही finding ST depression की 2, 3 AVF में तो बोलेंगे inferior wall MI. सारे लीड में नहीं होगी, ओवरलाइंग लीड्स ना, दैट इज व्हाट आई सेड. ओवरलाइंग लीड्स मतलब जो एंटीरियर सरफेस को रीड करने वाले लीड्स हैं, V2, V3, V4 है. इफ यू गेट ST elevation in V2, V3, V4, you say anterior wall ST elevation MI. If suppose ST elevation is present in 2, 3 AVF, you will say inferior wall ST elevation myocardial infarction. So leads will tell you which surface is involved. And the ST elevation and ST depression is like depending upon wherever the findings would be present. 50% cases can be having is a non-ST elevation MI, which is a partial thickness involvement where there would be a downward deflection that is happening. So either of the two changes can be occur and no doctor can predict whether it will be a ST elevation MI or whether this will be a non-ST elevation MI in a patient. But yeah, you can see additional finding coming up for your pointer there. The additional finding that is always coming up is that the person would be having T wave inversion, which is usually neglected, but is again not one of the early findings. It is indicative of myocardial ischemia. Because I've not written it, that does not mean it is not significant. It is a significant finding. It is a T wave inversion. First, when necrosis occurs, T wave ऊपर चली जाती है. And when death will occur, then negativity will occur. Negativity will cause negative waves. Negativity will cause negative waves to become more deeper. That is why deep Q wave. And negativity will cause the T waves to turn negative in the patient. So the bottom line is either of the two types of MI can be present. You just need to hand draw them. Either it's a STEMI or it can be a non-ST elevation MI. दोनों में ही convexity present होगा. Draw that convexity in your own handwriting to understand. It can either be full thickness or partial thickness. Now comes the core aspect. In ST elevation MI, it is a fibrin rich clot. ये हमने क्लिनिकल स्टडीज में देखा कि पैथो से तो ठीक है कि इट्स अ फुल थिकनेस, इट इज अ पार्शियल थिकनेस, ज्यादा नेक्रोसिस, पार्शियल थिकनेस, सो इट्स डिफरेंट फाइंडिंग्स दैट आर कमिंग. बट the core difference between the two is that in ST elevation MI, it is a fibrin rich clot. Because it is a fibrin rich clot, we will be doing fibrinolysis. But in non-ST elevation MI, it is not a fibrin rich clot, it is a it is a platelet rich clot, so the treatment of the two conditions is different. Most students इस बात से परेशान हो जाते हैं कि सर ST elevation MI है, नॉन ST elevation MI है, तो मतलब इसकी इंपॉर्टेंस क्या है? तो इंपॉर्टेंस अभी आपके सामने है. द इंपॉर्टेंस इज दैट इफ इट इज a ST elevation MI, you will do thrombolysis, you will destroy the fibrin. But if it is a non-ST elevation MI, then you will not use thrombolysis in the patient because the nature of the clot is different. So what will you use in non-ST elevation MI? You will be using antiplatelet drugs. I repeat my statement. ST elevation MI full thickness, non-ST elevation MI partial thickness. तो लगता है यार एक में ज्यादा डैमेज एक में कम डैमेज है. No, damage is damage, man. It will both cause ventricular fibrillation. Don't be under impression that ST elevation MI is more dangerous than non-ST elevation MI. No, whether it is pura motai damage, whether it is thoda sa damage, both will cause arrhythmias. Both will cause ventricular fibrillation. So this is a pathological difference which does not improve survival. What improves the survival is that what is the nature of clot. आज से 20-30 years पहले all cases of MI used to be given streptokinase. Some used to live, some used to die. तो हमने कहा यार ये क्या हो रहा है? Some are living, some are dying. हम देखे तो सही, वाई आर समबडी डाइंग, क्योंकि हम गलत ट्रीटमेंट कर रहे थे. हम सबको थ्रोम्बोलाइज करते थे. देयर वाज नो नीड ऑफ थ्रोम्बोलाइसिस इन अ पर्सन हु इज हैविंग अ प्लेटलेट रिच क्लॉट बिकॉज स्ट्रेप्टोकाइनेस डज नॉट वर्क ऑन अ प्लेटलेट रिच क्लॉट. दैट इज व्हाई नाउ इन पेशेंट्स व्हेन दे कम टू अस, हम ईसीजी करके पहले पता लगाते हैं कि विल थ्रोम्बोलाइसिस बी सक्सेसफुल or will it be not successful. If it is a fibrin rich clot, guys, we will be doing thrombolysis, which is also called as fibrolysis. So streptokinase or L-teplase, ये जितनी भी दवाइयां हम पढ़ते हैं, they are successful in patients who are having ST elevation MI. I would like everybody to participate and let me know, will you give thrombolysis in non-ST elevation MI? Obviously a no. Tell me intravenous drug. Yes, Nadeem, you are perfectly spot on. When you are gonna talk about non-ST elevation MI, वहां पे thrombolysis नहीं करते हैं क्योंकि फायदा ही नहीं होगा. You see, you use intervention when it will give you some benefit. When there is no benefit, you don't do the procedure. Tell me from your knowledge of pharmacology, intravenous antiplatelet drugs. Tell me from your knowledge, intravenous antiplatelet drugs. Aspirin is oral. Ticagrelor is oral. Okay. Tell me intravenous antiplatelet drugs. Heparin is not an antiplatelet drug. Unfractionated heparin is not an antiplatelet drug. You guys have not read pharmacology. I'm still waiting. Aspirin, clopidogrel, bachche, those are all oral antiplatelet drugs. This is an emergency. Patient is very, very critically sick. I will obviously give aspirin or admission to the hospital, but I am expecting from you intravenous antiplatelet drugs. What are the medicines that you will be using? Prasuzel is oral again. Yes, keep thinking. I'm making you think another 15 seconds. Yes. Nitroglycerin तो बेटा vasodilator होता है ना. Rivaroxaban is a DOAC. Okay, apixaban. करते रहो. Keep on thinking. Keep on hitting. Yes, Tabraj was the first one to hit the nail on the head. Guys, ST and non-ST से परेशान नहीं होना है कि कैसा दिख रहा है. वो आपसे क्या बोलेगा? नॉन ST elevation MI में व्हाट इज द मेडिसिन दैट यू विल बी यूजिंग? योर आंसर विल बी आई विल बी यूजिंग इंट्रावेनस मेडिसिन. द इंट्रावेनस मेडिसिन दैट यू विल बी यूजिंग इज tirofiban. The intravenous antiplatelet drug that you will use is tirofiban, or instead of tirofiban, see I had to write a lot, so that's why I'm having to move the slide. It is tirofiban. Very good. Then the second medicine that I can be using in this patient, obviously we will not use all of them, but we might have to use some of them. So tirofiban then is eptifibatide. So please read your pharmacology again. Intravenous antiplatelet drugs should never ever go wrong. Oral antiplatelet drugs तो यार वो तो एक नॉन मेडिको भी मुझे बता देगा कि एस्पिरिन देते हैं, टिकाग्रेलर देते हैं. आप तो डॉक्टर लोग हो यार. सी अ नॉन मेडिको पर्सन विद अ लिटिल बिट ऑफ एक्सपीरियंस, इफ समबडी के घर में हार्ट पेशेंट है ना, तो बता देगा कि सर वो एस्पिरिन देते हैं ना, वो प्रासुजल देते हैं ना सर, वो तो ओरल मेडिसिन होती है. आप तो डॉक्टर लोग हो यार. तो आपने मुझे बताना है कि सर जी व्हाट वी विल यूज इन दिस पेशेंट इज वी विल बी गिविंग इंट्रावेनस एंटीप्लेटलेट ड्रग्स. द नेम्स आर, आपने याद करना है मेरे साथ यहाँ पे, राइट नाउ राइट हेयर, tirofiban, eptifibatide, cangrelor. They are called as group 2B 3A platelet inhibitors. The technical name to be noted for them are All of these medicines are group 2B, 3A platelet inhibitors. They will inhibit platelet aggregation. हाँ एप्सिक्सिमैब बेटा आजकल विड्रॉ कर लिया. नदीम, you have a very good point. तेजस बच्चे, एप्सिक्सिमैब has been withdrawn recently ना because of excessive bleeding का complication हो जाता है उसमें. तो but your point is right. एप्सिक्सिमैब is like a good drug जो older versions में मैंने बताया हुआ है, but एप्सिक्सिमैब आजकल यूज नहीं करते. So what are the medicines to be removed? कम से कम एक याद करनी है. What must be known to you is tirofiban is a anti-platelet drug that is given intravenously and would be given in which variety of MI? It would be given in patients of specifically sir ticagrelor hota hai na, that is P2Y12. This variety, the cangrelor variety, can be given intravenously. The top two drugs, yes, you point. These two drugs are the ones which are group 2B, 3A platelet inhibitors, and cangrelor is a cousin of ticagrelor, so P2Y12. But the point to be remembered is the main drug that I want you to remember for this particular patient is हाँ तो भैया मैं देखो फार्मा वाले तो सारी दवाइयाँ बताते हैं ना, यूज कौन सी करनी है, हथियार कौन सा चलाना है वो तो हम बताएंगे ना. फार्मा वाले आपको बताएंगे ये वाला हथियार, दिस इज अ मिसाइल, दिस इज अ ड्रोन, दिस इज अ बॉम्ब, दिस इज अ हैंड ग्रेनेड. वी विल टेल यू व्हेन टू फायर अ मिसाइल, when to fire a hand grenade, when to fire a mortar, right? So they tell you the हथियार्स, they tell you the mechanism of action. ड्रोन ऐसे चलता है, मिसाइल ऐसे चलती है, हम आपको बताएंगे कि कौन से वाले वेपन को किस टाइम पे यूज करना है, राइट? सो बोथ आर टू बी स्टडीड. लो मॉलिक्यूलर वेट हेपरिन इज नॉट अ एंटी प्लेटलेट ड्रग बच्चे. वी विल बी यूजिंग सेवा बलन, you have a point, we will give heparin. So when I will teach you the total treatment of MI, I will talk about heparin also. But here the question was very specific, hit the nail on the head. What is that antiplatelet? That's an anti-clotting drug. You know, anti-clotting, it acts on the clotting factors. But what is triggering the clot? Platelets, na? What is the first thing that I said when I started teaching MI? The first thing I said was this dot platelets. प्लेटलेट प्लग विल फॉर्म, इनहिबिट दिस प्लेटलेट प्लग. एस्पिरिन तो देंगे यार, वो तो ठीक है, वो तो एडमिशन पे दे देंगे ना, बट द मेन ट्रीटमेंट इज it is going to be hitting the nail on the head, which is that like you have to give antiplatelet drugs. So a must know fact at the moment that we have to remember the aspects which are highlighted at the moment. Minimum points क्या क्या आने चाहिए. चलो बहुत सारा हो गया तो summarize करते हैं. What is to be remembered, right? First I will say for FMG exam, then I'll add 2 points for NEET PG. First FMG exam. First ECG of finding of MI, hyperacuity wave. ECG finding that will persist for whole life, deep Q wave in a patient. Third point, don't mix up tall tented T wave, that is a feature of hyperkalemia. Khatam. For NEET PG, specifically you need to remember, fibrinolysis is contraindicated नहीं पूछेगा. Fibrinolysis is contraindicated in non-ST elevation MI, तो आपको पता है, वो तो फार्मा वालों ने बता दिया. For NEET PG, he will ask you, what is the medicine that you will give for management of non-ST elevation MI? That is tirofiban, eptifibatide or cangrelor are the medicines that will be used here. I'll repeat my fact again. ST elevation MI, fibrinolysis, cool man. Non-ST elevation MI, we don't do thrombolysis. Till that the pharma chap has also said. What I am telling you is, what are you going to do? What's the hathiyar? What's the weapon that you're going to use when you get a non-ST elevation MI? That is tirofiban is the main medicine that we'll be using in a patient. Okay. Now, everybody, irrespective of whichever exam you're setting for, hit the comment button. What is the first cardiac biomarker to rise in myocardial infarction? First cardiac biomarker to rise in myocardial infarction. I will write the answer for last to rise in MI. Last to rise in MI is LDH. LL, that is last to rise in MI is LDH. Yes, troponin I. Very good, very good. Troponin I will rise after 3 hours. Na? In a city like Delhi, patient might come to the hospital early also. Patient might come to the hospital early also. Yeah. First cardio biomarker to rise, and this has been asked even in FMG exam, is IMA, ischemia modified albumin. This was last summer, last July. First to rise in MI is ischemia modified albumin. This will rise in the first hour. I'll write this once again. Somebody have typed the word short form IMA. I think you meant that same only. The first cardiac biomarker to rise in myocardial infarction is IMA, that is ischemia modified albumin. This is a test that will be done in the patient in the very first hour of onset of myocardial infarction. Myoglobin is a very good answer from pathology perspective, but beta देखो problem क्या है तब raise. The problem with myoglobin is present in the skeletal muscle also. So suppose the patient after MI had requirement of DC shock. And DC shock current will damage the skeletal muscle. When the current will go to skeletal muscle, therefore the myoglobin will become elevated. So because myoglobin is present even in the skeletal muscle, it is a good answer from the pathology perspective. Like if suppose ischemia modified albumin is not given in the option, and in pathology they teach you that first cardiac biomarker to rise is myoglobin, perfect. The problem with myoglobin is that it also has a skeletal muscle source. It also has a skeletal muscle source. भाई लाविश देख, हमारा एज अ डॉक्टर काम ये नहीं है कि क्यों क्यों अलग अलग होता है ना, उसके लिए तो रिसर्च करनी है, पीएचडी। हमारा एज अ काम जो फिजिशियन होता है ना, वो होता है कि व्हाट इज द नेचर ऑफ क्लॉट, ट्रीटमेंट क्या करना है, राइट। So if you want to get into why there is a difference in the nature of the clot, why is something which researchers will do. As a clinician, I will not worry about why is there a fibrin-rich clot, why is there a platelet-rich clot. Our job is to find what is the treatment to be done in a patient, right? In academic class, मैं तो आपको ये सब कुछ बता रहा हूँ. When you talk to a cardiologist, वो हंसेगा, कहेगा सर इतना दिमाग कौन लगाता है? हमारा काम तो ट्रीट करना है. We do a balloon angioplasty in a patient, game over. We have to save a life. No, this is academic class. I'm trying to tell you the difference. The nature of the clot is different. That let the researchers find out what is the cause of fibrin rich, what is the cause of platelet rich. Our job is gonna be what are we gonna do for it. As we have a problem, right? You tell me, sir, I have a problem. I have to find a solution for that, man. I will not get to क्यों, कैसे, कब हुआ, right? Let those PhD people do it. Let those research people do that. So don't worry about it. Good question, but I'm not criticizing you, beta. What I'm trying to explain to you is that there are some things in medical field where you have to say, okay, man, like this is a problem that I have to solve. If you get into what is the cause of that problem, we'll never be able to find a solution. Okay, let's go forward. The first biomarker to rise is ischemia modified albumin. It rises in the very first hour of onset of myocardial infarction. Then he has changed the question. He said, if the patient is coming between 1 to 3 hours, what is the biomarker that you will be using? Then your answer will be heart fatty acid binding protein. It is HFABP. It is heart fatty acid binding protein. This biomarker, heart fatty acid binding protein, it becomes elevated between 1 to 3 hour of onset of myocardial infarction in a patient. And your answer of troponin I is not wrong if I had specifically asked you that doctor, patient has come between 3 to 6 hours. If I specifically asked you that doctor, the patient has come between 3 to 6 hours of onset of MI, what is the biomarker that would be done? By looking at the ECG, we have to decide what is to be done. Exactly, that's the objective. Coming back to the agenda, if patient comes super early, ischemia modified albumin. Patient comes between 1 to 3 hours, heart fatty acid binding protein. 3 to 6 hours, troponin I, troponin T. If nothing is given in the question, answer is troponin I, troponin T. Best test. Listen to my words. I did not say first. If he says the word first, let me remove this. If he says first, then answer is ischemia modified albumin. But if I change the question and I say what is the best biomarker for diagnosis of myocardial infarction, then the best biomarker is the one which is normally routinely available, because most patients will take some time to come to the hospital. No, if somebody is having chest pain, he will take some antacid gel, he will take some Ayurvedic homeopathic medicine, then he will go to the nearby doctor, then he will go to, like, transportation in India also takes time. So in clinical practice, what is the best biomarker that we use? It is troponin I and troponin T. But if he says the word earliest, then it is gonna be better. यहाँ पे the guidelines you need to follow is जो मैंने बताया, right? So pathology वाला जो है, that is like if you say patho का specimen, right? इसमें बड़े सारे student को sir pathologist told this. भाई जहाँ पे clinical domain आएगा वहाँ पे you need to follow. If I ask you, if I suppose I tell you finding of a slide, this is how Titan star looks like, and it doesn't look like a Titan star. So you have to follow the pathologist, right? Our slide, when patient will die, pathologists see. They don't see when patients come to the hospital, na? Patient dies, we send the dead body to the mortuary. हमारे का और कोई काम नहीं. In the mortuary, if family members say that we want to find the cause, post-mortem is done. In that post-mortem, the specimen goes to pathologist. 1 week के बाद में pathology वाला report देते हैं. All pathology people are rich people, right? उनके पास में they have that YSL का बैग एंड बर्बरी का बैग एंड एवरीथिंग, क्योंकि वो तो डेड पेशेंट का आराम से रिपोर्ट देनी है ना 1 वीक के बाद में. हमारे को तो मरीज अभी बोलता है अभी बताओ अभी क्या हो गया, एंड दे आर नॉट रेडी टू पे एट दैट पॉइंट ऑफ टाइम. पैथोलॉजी की रिपोर्ट के लिए दे आर रेडी टू वेट, राइट, फॉर 7 days, एंड दे आर रेडी टू पे एनी अमाउंट ऑफ मनी बिकॉज वी वांट टू फाइंड आउट व्हाई आवर ग्रैंडफादर डाइड, right? But in the critical part, it is like we are to find the cause right now. Okay, coming back to the agenda. Ischemia modified albumin and troponin I and troponin T में, it is the time frames which are to be remembered. Yes, CPK-MB. सीपी के एमबी कब आंसर करना है? आज की डेट में, जब मैं आपकी उम्र पे स्टूडेंट था, when I was a medical student 20 years ago, when my consultant asked me कि बेटा MI patient has come, what is the test you will be doing? I said CPKMB. He said okay बेटा तू पास हो गया. I was super happy. But that is not the case at the moment. So as of now, what are we gonna be doing? When would you be answering CPKMB is if the question says, listen to the words very carefully. If he says what is the best cardiac biomarker of reinfarction, तो होता क्या कि CPKMB rises and then it comes back to normal by 72 hours. It comes back to normal by 72 hours. So if somebody has a heart attack on the 4th day or 5th day, we can do CPK-MB in the patient. So if he specifically says what is the cardiac biomarker, the language of the question is what is the cardiac biomarker of reinfarction after 72 hours, that is when you will say that I will be using CPK-MB for evaluation. Now I'm changing the question. If he just does not mention the word 72 hours, it is not the guarantee. There is no guarantee that reinfarction will occur after 72 hours. It can occur after 72 minutes also, na? Is there a guarantee that heart attack will occur again after 3 days only? It can occur after 72 minutes also. It can occur after 72 seconds also. It can occur after 1 day also, 2 day also. So if the duration is not given in the question, then you will say, okay, this is troponin I elevation, which is to be answered. The rise of troponin I will be more than 20% elevation over the baseline. More than 20% elevation over the admission baseline. Like suppose when the patient came at the moment, whatever was the mathematical value, if you add 20% to that mathematical value, then this could be a reinfarction developing in a patient. The message is, यहाँ पे I would like to clear, troponin I and troponin T, both of them kits are available in government hospitals. 1 month you will get a kit of trop I, other month you will get the kit of troponin T. So don't bother about I versus T. Both of them are basically surrogate markers of each other. The point to be understood is if he specifies the word, भाई क्यों पिटवाओगे मुझे? And but patho people are rich people anyway. Why there's nothing wrong about bragging about the brand of YSL that they're carrying. Okay, so reinfarction is after 72 hours CPK-MB, and if after 72 hours nahi hai, then it is troponin I which is to be added in this particular case. And the data to be understood is treatment of choice for ST elevation MI in a patient. Treatment of choice for ST elevation MI in a patient, then the correct answer in this particular case, if he says what is the treatment of choice, the answer is not drugs at all. We will take up the patient in the cath lab and we will destroy the clot in the coronary artery in the patient. Then it is primary percutaneous coronary intervention. It is a primary PCI, guys. For ST elevation MI, it is a primary percutaneous coronary intervention that would be used in a patient. Keep the focus on, guys. Let's not focus on the brands. You will have lots of money later. When you become a big doctor, you can buy Hermes, you can buy YSL, you can buy all the latest brands. All of you have traveled internationally, locally. आजकल हर स्टोर पे सब कुछ मिलता है इंडिया में भी. So then आप डिसाइड करोगे कौन से वाला बैग खरीदना है. लेकिन आज आपको पढ़ना पड़ेगा to be able to buy that Hermes. Today you have to learn this, right? Boys, रोलेक्स खरीदनी है तो फिर मेरे पास रोलेक्स नहीं है यार, रोलेक्स नहीं दिखा रहा, राइट? सिंपल वॉच है. रोलेक्स खरीदनी है तो you have to learn all these facts today. Okay. Okay, treatment of choice for ST elevation MI is primary percutaneous coronary intervention. That is the main approach that we use. We take up the patient in the cath lab. We do a primary percutaneous coronary intervention. Hit the comment button, guys. What is the treatment of choice for non-ST elevation MI? Yeah. Ashutosh, I love that business spirit in the current generation also. We'll talk about that also, man. We'll talk about the investment part and everything. हर्पीज नहीं, हर्मीज. छोड़ यार, लेट्स नॉट टॉक अबाउट ब्रांड्स. गुड, अच्छा है आपको ब्रांड नहीं पता, ठीक है. आई वांट यू टू स्टडी. यस गाइस, नॉन एस्ट एलिवेशन एम आई. ओके ओके, हाँ हाँ, ठीक है ठीक है. Yeah, we will go for percutaneous coronary intervention. The primary word will go from there. The word primary will not be there, but aajkal the main treatment of the patient is balloon angioplasty, and we might be putting stents in the coronary artery. Please appreciate the fact. Jokes apart, guys, jokes apart. I hope everybody is following the word. If primary word is given in the question, then it is always to be answered as ST elevation MI. And if the primary word is not given, then it is a percutaneous coronary intervention that we can be doing in a person. But the primary word, if written in a question, it always implies that the examiner is trying to talk about ST elevation myocardial infarction. Now, suppose I'm practicing outside Delhi, outside Gurgaon, outside Manesar. Let's go to periphery. Let's move into Rajasthan, something like Alwar. Let's go into Haryana, somewhere in the periphery where we don't have a PCI facility. In those circumstances, if we don't have a PCI facility, then we have to do thrombolysis. I want everybody to hit the comment button. Yes, बच्चे, we will do coronary angiography in all patients. अभी मैं algorithm बताऊंगा. We are solving these questions that come. What is the window period for thrombolysis? Within how much time of symptom onset? Within how much hours of symptom onset would we be starting thrombolysis in a patient? Okay, I'll give you options. Bache, you are, please look at where I have done the marking. I have left one line deliberately. You guys are like imagining answers now. What is the window period for thrombolysis? Options are 30 minutes, 90 minutes. मैं लिख देता हूँ चलो, because everybody is getting distracted with the routine chit chat that is going on. तो वो ठीक है, bit of chit chat is fine. It is 30 minute, 90 minute, 6 hours, 12 hours. What is the window period in which the treatment of the patient should be done? I'll wait for another 15 seconds. I will wait for few 15 seconds. Some guys have given answer. Vaishnavi, you were spot on. Then names came up very fast. Tejas, you are right. Shiva Balan, you are right. Names went up too fast. Tejas, you're right. Tejas, sorry. I think I missed your name initially. Yes. Nadeem, also, you're right. Fine, guys. Great. Sir, window period is not to be confused with how much time will you treat the patient when he comes into the premises of the hospital. Window period is calculated from symptom onset. Suppose somebody had MI at 8 o'clock in the morning. If you will come at 7 p.m. in the evening, you will still thrombolyze the patient because cardiac tissue can be treated up to 12 hours. All of you are fixated on that word 30 minutes, 90 minutes. That is for first medical contact to balloon time, first medical contact to needle time. The question that I asked you, I mean, jokes apart, you have to focus at the studies part also. Window period word written. Window period कहाँ से calculate करते हैं? It is not from arrival to the hospital. Window period is not calculated from entry into the hospital. Window period is from the onset of symptoms. Suppose किसी को heart attack हुआ सुबह 8 बजे, वो शाम को 5 बजे आया because he's coming from a periphery. The poor fellow, he had to hire some vehicle. He did not have money for it. So by the time everything was arranged, took an awfully long time. NH48, trucks are gonna be jamming it half the time, and there's so much of rush that people come to us late. Sadly, in India with very bad state cardiogenic shock. The window period for treatment is a huge 12 hours. Sir, we would like to extend the benefit. This is a very common mistake the students do. Why? Because they start mixing up the information. So now you need to listen to the aspects that I'm highlighting at the moment. If he says the word first medical contact to balloon time, like the patient came right now. Right now the time is let's say 1:30 by my watch. Within how much time will I do a balloon angioplasty and destroy the clot? That is 90 minutes. That is 90 minutes. First medical contact to balloon time. Suppose I don't have this facility and I have to give medicines, then is the door to needle time. That door to needle time should be kept under 30 minutes. What you guys were doing initially was that you got carried away by the chit chat and you started answering the 30 minutes, 90 minutes. Bache, the question is on window period. Window period is calculated from the symptom onset in a patient. So whatever I'm writing in bold, or wherever I do a ink change, that is the mistakes that people do. By default, guys, you will notice I'm writing in one color. Wherever I'm writing in bold, wherever I'm doing an ink change, I always try to highlight the mistakes that the people are doing. And this is one of the commonest mistake that is absolutely. One is with respect to symptom onset. One is with respect to medical contact. Abhi mujhe chest pain hua, I may not reach the hospital immediately. Na? It might take a very long time. Right? So that's the fundamental difference. So I hope the concept is clear, guys. Hit the comment, okay, forget it. Don't hit the like button. I think I've been able to communicate, but if somebody has doubt, let me know. बेटा प्राइमरी पीसीआई वर्ड ना उन्होंने जानबूझ के रखा है, प्राइमरी वर्ड रखा है कि ये मेन ट्रीटमेंट है। नॉन स्टिलेशन एमआई में ना पहले दवाइयों से मैनेज करते हैं, इंप्रूवमेंट हो गया तो ठीक है, नहीं तो पीसीआई कर लेंगे। वाई द प्राइमरी वर्ड, बेटा आपका क्वेश्चन बिल्कुल सही है, वाई द वर्ड प्राइमरी, बिकॉज एस्टिलेशन एमआई में डिफॉल्ट पीसीआई करना ही करना है। all cases you have to do a default PCI in ST elevation MI, which is the one that I've highlighted. In non-ST elevation MI says if you give IV plated drugs, if he improves ठीक है, नहीं है तो कर लेंगे PCI. So that's the basic difference in this particular. Optimal window period is no बच्चे, it is nothing like an optimal window period. आप मुझसे optimal window पूछोगे ना, it should be first hour. आपने अब क्योंकि पॉइंट बोला है तो मैं हाईलाइट करता हूँ. If he says the word golden period for MI, because most arrhythmia strike in the first hour. Golden period for myocardial infarction is 1 to 3 hours of symptom onset. This is optional if you want to note down, क्योंकि आजकल गोल्डन पीरियड का कंसेप्ट नहीं है, पुराने जमाने की बातें हैं। हम तो कहते हैं भाई जल्दी आओ ना पेशेंट को लेकर और जल्दी से हम ट्रीटमेंट कर लेंगे। सो हिंदी विद एग्जांपल, ओके, क्विक आंसर्स। सपोज किसी को एसटी एलिवेशन में मई हुआ तो बाय डिफॉल्ट उसको कैथला में लेके जाना है और बैलून एंजियोप्लास्टी करनी है। डिप्लॉय द बैलून, डिस्ट्रॉय द क्लॉट, स्टेंट भी डाल देंगे। नॉन एस्टिलेशन एमआई में हम पहले दवाई से मैनेज करके देखेंगे, दवाई से ठीक हो गया तो अच्छी बात है, नहीं हुआ तो फिर पीसीआई कर लेंगे। दैट्स द डिफरेंस बिटवीन प्राइमरी एंड जस्ट द वर्ड पीसीआई। सेकेंड, अगर किसी को अभी चेस्ट पेन हुआ और वो अभी अभी आ गया हॉस्पिटल, सुबह 8 बजे चेस्ट पेन हुआ, अभी आया हॉस्पिटल में, नाउ इट इज सपोज इट इज 1:45 बाय माय वॉच, पेशेंट हैड चेस्ट पेन एट 8 AM, अगर वो अभी आता है तो अराइवल के 90 मिनट्स के अंदर अंदर में मुझे बैलून एंजियोप्लास्टी करानी है। तो मेरे लिए डॉक्टर के लिए पूछ रहे हैं विद इन हाउ मच टाइम, इफ पेशेंट केम एट 1:45, बाय हाउ मच टाइम विल यू ट्रीट द पेशेंट? आई विल से बिफोर 3 o'clock टुडे आई विल डू बैलून एंजियोप्लास्टी। But patient can come late also, na? It may not be only afternoon, he can come late also. The question is window period for thrombolysis. Like suppose उसको सुबह 8 बजे हार्ट अटैक हुआ तो रात को 8 बजे तक हम थ्रोम्बोलाइसिस करेंगे। 8 बजे आएगा तो 8:30 बजे तक आपको ट्रीटमेंट करना है। 7 o'clock पाए तो आपको डॉक्टरों को कितने टाइम में ट्रीटमेंट करना है? 30 मिनट्स। दैट वाज द हिंदी एक्सप्लेनेशन दैट इज रिक्वायर्ड। पीसीआई डन आफ्टर दिस, पीसीआई रिक्वायर्ड नीडेड? नो बच्चे, इफ पीसीआई इज डन देन we'll be able to manage the patient. TIMI score is thrombolysis and myocardial infarction score that helps us to decide the treatment algorithm in a patient. I'll not get into into the TIMI score at the moment. Like we need to focus on the core things that they're asking. Now comes a question on failure of thrombolysis. This is an FMG exam question, that is rescue PCI. The question was simple. Rescue PCI is done in, तो रेस्क्यू कब करेंगे? जब दवाई से सक्सेसफुल ट्रीटमेंट नहीं हुआ है। द क्वेश्चन वाज व्हाट इज रेस्क्यू पीसीआई? देन रेस्क्यू पीसीआई इज फेलियर ऑफ थ्रोम्बोलाइसिस, दैट इज यू हैव गिवन मेडिसिन, दैट इज व्हाई पीसीआई इज बीइंग डन नाउडेज ना, बिकॉज थ्रोम्बोलाइसिस मे नॉट वर्क ऑलवेज। What is the rescue PCI? Failure of thrombolysis. Normally, when you will treat the patient, the ST elevation will start coming down. No? Like suppose this is the ST elevation MI of 3 millimeter, 4 millimeter. When you will treat the patient, the ST elevation कम हो जाएगा. When you will treat the patient, the ST elevation will come back to normal, in the patient. So what I have shown here is normally when you treat the patient, if ST elevation starts reducing, it reduces 3 millimeter, 4 millimeter, then from 4 millimeter to 2 millimeter, then to 1 millimeter. This is ST elevation MI resolution that I have shown before you, that when you will treat the patient, the ST elevation height will keep on becoming lesser. If in those circumstances, if it will not reduce by 50% or lesser, they did not ask the definition, that's just for reference sake. If it does not decrease by 50% over the 60 to 90 minute period, that means that the thrombolysis dawaiyan are failing and we need to go for a rescue coronary intervention. Pranav says, do 12 hours of window period includes the 30 minutes of door to needle time? Yes. In that 12-hour period, whenever he comes, in that 12-hour period, let me explain this once again to you. Suppose somebody had MI at 8 AM, you can treat him up to 8 PM by medicines like streptokinase. You can treat him till 8 PM by streptokinase. For PCI, there is no limit. He comes after 24 also, we do a PCI, but for thrombolysis, we can treat usually up to 12 hours. Now, suppose patient entered at 4 PM in the evening. So you should be starting the thrombolysis by how much time? 4:30 PM. Suppose the patient came at 7 PM in the evening, you should be starting the treatment by how much time? 7:30 PM. There are two different concepts. One is when the patient has come into the hospital, within how much time the doctor should start the treatment? That is 30 minutes. That is door to needle time. Patient entered the door of the hospital at 4 p.m. You should be starting the treatment within 30 minutes of arrival. Patient came at 7 p.m. You should be starting within 30 minutes of arrival. This is the concept of door to needle time. जब patient hospital आया, उसके 30 मिनट के अंदर में इलाज कर दो. That is it. But then what I have tried to explain to you, 8 p.m. We will treat up to 8 बोला ना मैंने, up to 8 बोला तो 8:30. अगर 8 बजे आया 8:30, but suppose he comes at 8:30, I will say no. ईशान is saying, सर कुछ तो करो प्लीज सर. 8:30 पे मना कर दिया मैंने. I said no. He came at 8:30. I said no. We will not do thrombolysis. Your dad at MI at 8 a.m. 12 hours have passed by. सर जी कुछ तो करो. PCI कर देंगे ना. We can do a percutaneous coronary intervention in a patient. Yes, Rajesh, I have answered your query. Patient came after 8. I will not do thrombolysis. बाकी मेडिसिन तो दोगे भाई. Morphine, oxygen, aspirin, nitrates, heparin, statin, beta blocker. All of them will be given. ना बाकी ट्रीटमेंट तो दोगे. सिर्फ thrombolysis थोड़ी ना. Do a PCI in the patient. Nobody is stopping you. We can do PCI up to 24 hours of onset of myocardial infarction. Yes, Kuldeep, you're right. ST elevation, concavity. Kuldeep, you are spot on for that. I thought that yesterday. I hope it is clear, guys. I hope it's clear. 12 plus 30 minutes for door to needle. Within 12. बेटा 12 प्लस नहीं होगा ना. Within the 12. आप बोलो less than 12 के अंदर within 30 minutes ट्रीटमेंट करना है. It is not plus 12. It is within 12. 30 minutes में ट्रीटमेंट को स्टार्ट करना है. So that is the concept which I mentioned. Q wave develops within 1 hour, बेटा. Hassan, you said Q wave develops within. Answer is 1 hour. But we will not rely on ECG alone ना. Biomarker करेंगे ना. Biomarkers will help us identify. Okay. Fine, guys. I think a good discussion that we had. Core aspects, hardcore cardiology aspects have been discussed here, and I'm really happy that you guys would be. Would that make the window by 12.5 hours if we are doing thrombolysis? तो प्रणव अगर मान ले तेरे को लग रहा है 5 मिनट देर से आया तो PCI कर लेना. You will earn more money. मत करो ना thrombolysis प्रणव. Thrombolysis में पैसे कम मिलेंगे ना. PCI कर लेना आप. Nobody will stop you. There's always a gray area. Na? The doctor can always say, yeah, he came at the border time period. So I decided to do a PCI. You can charge more money. दो स्टेंट भी लगा दोगे ना, उसके charges भी हो जाएंगे. Door to needle is for thrombolysis. Yes, Yashika, you are perfectly right. Door to needle is for thrombolysis only. Exactly. This is all for medicine, bache. This is STK that I'm describing at the moment. Absolutely. Yes, thrombolysis done with medicines. That is like STK, streptokinase. Okay. Now we will study regarding some complications that will be occurring. Then I'll teach you a mnemonic, how to remember it. Complications of myocardial infarction. The most common complication of myocardial infarction in the first few hours. The most common complication of myocardial infarction in the first few hours will be a development of arrhythmia. Most of the time, the arrhythmia that will develop will be either a ventricular fibrillation or a VTAC that is occurring. But if patient comes after 24 hours, okay, Charan Tej, you have a very good question. I will answer you also. Give me like 3-4 minutes. I will answer you. I've noted down AIVR for you, Charan Tej. Okay. What is the most common cause of death? Chalo. What is the most common cause of death after 24 hours? Treatment has been done. Successful treatment has been done. In spite of that, the patient has died because it was a full thickness infarction. What are you gonna do? What is the cause of death? You will say that I will be starting the patient on norepinephrine. I will be using dobutamine because person is going into cardiogenic shock. So after 24 hours, it is cardiogenic shock. Patient died on the 3rd day. Yes, very good. Cardiogenic shock is sorted. We discussed that earlier also. Great. Good answers. Now I have changed my question. Patient of myocardial infarction was successfully treated, but he died on the 3rd day because he was having extensive antereval MI. A person will be having an extensive antereval myocardial infarction. There can be extensive necrosis also. Very good. Gaurav was the first one to pick it up. If somebody dies on the 3rd to 5th day, if you will read Preeti ma'am's notes, she has said the word cardiac rupture. We as medicine people don't use the word cardiac rupture. We use the word electromechanical dissociation, which means the same. The heart will burst because there is necrosis in the heart. The necrosis is so extensive that the infarct area, the necrosis area will give away and the heart will burst like a balloon. So the answer after 3 to 5 days would be electromechanical dissociation. If you check out your pathology notes, this is written as rupture of the heart. The rupture of the heart is common on the 3rd to the 5th day cardiac rupture. Obviously, it will not occur in all cases. It is only when there is a delayed treatment. Patient came very late. He had extensive antereval MI. वही 12 घंटे वाला patient. विलेज से आ रहा है, अलवर से आ रहा है, राजस्थान से, ट्रैफिक जैम था, बाय द टाइम पहुंचा उसका कार्डियक टिश्यू बहुत वीक हो गया था, तो दिस एक्सटेंसिव नेक्रोसिस, so patient can die the third to the fifth day, that is cardiac rupture, electromechanical dissociation. Good answers. What is, yeah, rupture of the heart, Vikrant, you perfectly right for this one. Morbid 2 नहीं बेटा, वो तो bradyarrhythmia होगा ना, that's a bradyarrhythmia. Is it preventable or predictable? Preventable by patient, we will ask the patient to come on time and we will manage medically, but you can't guarantee, you said preventable, no doctor can prevent what is to happen, we can just reduce the chances, right? You can't prevent everything, you can say I can reduce the chances by 50%, 20%, like that. Okay, commonest valvular lesion in myocardial infarction, Yashika was the first one to comment. By default, whenever heart is involved, by default, whenever the heart is involved, it will always be mitral regurgitation that is occurring in a patient. Then is Dressler syndrome, which has already been discussed. Dressler syndrome is a post-MI pericarditis. It is the autoimmune pericarditis. And for this, he has always asked, like, what is the treatment that would be done in this case? So obviously, we will not answer steroids. We will be answering it as aspirin for management. And now I address what was a query that a doctor had asked. Sorry, doctor, I forgot your name because suddenly the name had gone up. But this arrhythmia that can occur is called as AIVR, that is accelerated. किसके लिए बेटा? After surgery, patient died. हाँ, cardiac. Yeah, after PCI, cardiac rupture can happen. Yeah, if patient comes late. Yes. When it comes to AIVR, the name is accelerated idioventricular rhythm. It is a benign arrhythmia. We call it slow ventricular tachycardia. Hanji, Charan, thank you, Charan. AIVR, accelerated idioventricular rhythm, is a slow ventricular tachycardia. Charan Tej, your query was AIVR kya hota hai? So I'm addressing that. Accelerated idioventricular rhythm, that is a slow ventricular tachycardia. दिस इज अ इंडिकेटर ऑफ, ये आज के ज़माने में यूजली देखने को नहीं मिलता है. दिस इज यूजली सीन इन दोज टाइम्स जब हम स्ट्रेप्टोकाइनेस को यूज़ करते थे. आजकल तो सबका ही हम पीसीआई कर देते हैं, बट दिस इज अ रीपरफ्यूजन एरिथमिया. इट इज़ अ बिनाइन एरिथमिया, डज नॉट कॉज डेथ ऑफ द पेशेंट, रेदर इट इज़ गुड न्यूज़. इनडायरेक्टली इट इज टेलिंग मी कॉर्नरी आर्टरी ओपन हो गई है. What is this telling me? Like suppose person was having a clot like this, big clot. So I gave a medicine by the name of streptokinase and I have destroyed the clot. When I will destroy the clot, the coronary artery will open up. Now the clot is destroyed and you can see the blood supply has once again restarted. So that indication of reperfusion, that indicator of reperfusion, जो पैथो में मैम ने बोला ना कि कैल्शियम विल कम एंड दैट विल कॉज reperfusion डैमेज इन द हार्ट, दैट reperfusion इज ऑब्वियसली अ बैड थिंग बिकॉज फ्री रेडिकल्स भी होते हैं, कैल्शियम भी होता है, वो डैमेज करता है. बट टुडे व्हाट आई एम टेलिंग यू इज अ क्लिनिकल डोमेन ऑफ हिस्टोरिकल इंपॉर्टेंस कि जब स्ट्रेप्टोकाइनेस देते थे तो इनडायरेक्टली हमें कैसे पता चलता था कॉर्नरी आर्टरी खुल गया. हमें कोई दिव्य दृष्टि तो है नहीं. आई एम नॉट गोना हैव विजन लाइक सम गॉड पर्सन दैट आई कैन सी इनसाइड and I can know coronary artery is opened. So arrhythmia used to develop, that used to look like a ventricular tachycardia, that is a reperfusion arrhythmia. And Pranav, you said why will not reperfusion injury occur? Man, it occurs every time. In medical science, it is all about benefit versus loss. The loss is the reperfusion injury, the benefit is cardiac tissue you are surviving. When you fight, when you go for a war, आप किसी को मुक्का मारोगे, वो भी तो आपको मुक्का मारेगा सर. You go for a fight, if you hit two punches to somebody, the guy will also hit you back, man. Medical science is all about benefit versus loss. The benefit is I'm saving cardiac muscle. The loss is reperfusion injury. I know, man, some collateral damage will occur. India-Pakistan war happened. They fired missiles. We also got hit. Nah, our air bases were also hit. We were lucky that our boys were more. We used that Navik satellite guidance. That was more accurate. So we were able to hit the critical areas of their airbase functioning. They did not have that Navik critical mapping. So their missiles landed in the periphery of our air bases, right? So it's all about benefit versus loss. When you go for a war, there's collateral damage. I hope, Pranav, that answers your query. The point is AIVR, Charan Tej, is a reperfusion arrhythmia. But क्योंकि आपने पूछा था, इसलिए I thought I should mention it at the moment. So the mnemonic for all of this is called as CALL-MD. CALL-MD would mean cardiogenic shock, arrhythmias, LV aneurysm, mitral regurgitation, and Dressler. LV aneurysm, I did not speak earlier, so I'm just going to draw a line diagram here. Structural damage can cause an aneurysm formation. This is a LV aneurysm due to necrosis in the heart. The bad news is this aneurysm is a post-MI complication and this cardiac muscle is damaged, so it's bulging out. This particular heart is the weakened It is the weakened muscle, it is the damaged muscle, and it will not be able to contract properly, so there would be stasis. Due to stasis, there would be no, I'm giving war के examples because अभी recent war चल रहा है यार. मुझे war पसंद नहीं है भाई, मुझे कोई war पसंद नहीं है. War चल रहा है तो मैं recent example दे रहा हूँ. Otherwise, I would have gone for conventional examples. Okay. So weakened muscle. So there is a stasis, and because of the stasis component, there would be clots, and these clots would be going out into the circulation, and that would result in stroke in a patient. So the bad news is that after MI, person can have stroke also, because weakened muscle will cause stasis and clots, and therefore what will we do in this patient? No, it will occur with PCI also. It will occur with PCI also. Even with the, okay, why not with PCI? The injury will be lesser. इंजरी विल बी लेसर बिकॉज धीरे धीरे क्लॉट खुलता है ना. उस पर पीसीआई में तो यू फोर्स अपन द क्लॉट वेरी फास्ट, सो सडनली वो जितने भी फ्री रेडिकल्स होते हैं वॉश ऑफ हो जाते हैं. योर क्वेरी इज व्हाई इट इज नॉट अकरिंग विद पीसीआई. मैंने बोला दोनों में होती है. विद थ्रोम्बोलाइसिस बिकॉज द आर्टरी विल ओपन धीरे 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 धीरे, सो द फ्री रेडिकल्स विल बी गेटिंग टाइम टू कॉज डैमेज. Whenever you are doing a balloon angioplasty, you're doing a fast opening of the blood vessels, so जो collaterals हैं they'll be able to pass off. या यूक्रेन वॉर देख के आया, I can understand man. वो इसका अंदर मिसाइल जब फटती है तो भाई रूह काम जाती है अंदर की. रूह is the core of your body, right? As they say. Okay, coming back to the agenda. ना चलो अब I'll not talk about Iskander. I'm not going to talk about missiles, and I'm going to focus on the work. Okay, stroke is a bad complication that can occur after myocardial infarction in a patient, and this is because the person is having structural damage to the heart. I'm not going to allow this to happen. How will I prevent it from happening? I can be using warfarin for management of this patient. Let us now look at what is the treatment that we will be using for management of patients of MI. The mnemonic for this is Bestmone. The mnemonic for the management of the patient is Bestmone. What I imply by the word Bestmone is that I'll be using beta blockers. The mnemonic is Bestmone. In Bestmone, we have to use beta blockers. We have to use enoxaparin. That is a low molecular weight heparin. That again, some doctor had put, sir, will we use heparin? Yes, man. You have to give statins to the patient. Alphabet T will come 2 times. Alphabet T will come 2 times. If I am in a periphery and I don't have PCI facility, I can do thrombolysis. But alphabet T is also to be remembered for if it is a non-ST elevation MI. Then for non-ST elevation MI, I will be using antiplatelet drug by the name of tirofiban. Then we will be using tirofiban in the patient for non-ST elevation MI. M is morphine, O is oxygen, A is aspirin. Along with A, aspirin is also to be A से याद करना है atorvastatin, and N would be for nitroglycerin in the patient. Door procedure will be best for LV aneurysm. Yeah, that's the only way we can manage. But first we have to manage conservatively. Na? If it's an aneurysm has a high tendency of ventricular tachycardia, so most of the time we have to first prevent arrhythmias. Most surgeons will refuse to operate because of the risk of intraoperative stroke. So we have to first go in for treatment of like we might have to go for cardiac mapping, like we might have to go for electrophysiological studies, determine the cause of arrhythmias, give warfarin, amiodarone in a patient, and then we might plan surgery. Otherwise, usually we don't go for surgery. We try to manage first conservatively. Okay, so Bestmone is the mnemonic that can help you remember beta blockers, enoxaparin, statins, thrombolysis, tirofiban, morphine, oxygen, aspirin, and atorvastatin, and then nitrates in a patient. These are the drugs which are used. Question to everybody: patient came with myocardial infarction. ECG shows a ST elevation in V2, V3, V4. What is the first drug to be given? What is the first drug to be given? Cardiac patients में ना surgery ना ही करवाओ तो better रहता. Yes, the first medicine to be given to the patient. This was a very simple question that came in the paper. Patient came with myocardial infarction. What is the first medicine that you will be giving in the patient? Your answer will be you will be using aspirin. It is aspirin. No, not nitrates. It is aspirin that is the first medicine to be given. Chewable aspirin. And along with chewable aspirin, nowadays we also give a second molecule that is by the name of ticagrelor. According to the American Heart Association guidelines, if it says what is the first medicine to be used, If he says what is the first medicine to be used in any case of myocardial infarction, your answer would be given as DAPT. DAPT would stand for dual antiplatelet therapy. DAPT is dual antiplatelet therapy is the initial approach that we'll be using for this patient. Yes, guys. That is DAPT, dual antiplatelet therapy is the initial approach that we'll be using in the patient. Great. What is the next medicine that we'll be giving? That is oxygen. This oxygen will depend upon the SpO2 values. If SpO2 less than 93, we will be giving oxygen to the patient. Here given a photo of a mask. Can you tell me the name of the mask that we are using? Ticagrelor is preferred over clopidogrel. Yes, because Dr. Sahu, because clopidogrel is a prodrug, it does not work in Indian patients. Poor response in Indian patients. So AHA says in Asian population, ticagrelor is recommended over clopidogrel. Prodrug, poor response in Indian patients. Yes, we will be using Hudson mask, and using a Hudson mask, we will be giving oxygen to the patient. Great, that is a Hudson mask. After that, we will be giving sublingual nitroglycerin. That is a coronary vasodilator, but this medicine is contraindicated if the systolic BP is less than 90/60. If the systolic blood pressure is less than 90/60, do not give nitrates to the patient. Lots of time your nurse might give this medicine without your instructions because she thinks that Dr. Saab gives it to everybody. Don't allow this medicine to be given. It's kept below the tongue. Don't allow it to be given without checking the blood pressure. Sublingual nitroglycerin, and then we will be giving obviously morphine in the patient. There are so many painkillers which are more effective than morphine. So why are we giving morphine is, reason why we are giving morphine is because morphine is a vagotonic drug. It will control the oxygen consumption of the heart. It will conserve the fuel consumption, vagotonic action. It will conserve fuel. It will conserve oxygen in the heart. So that is why it is used. It is not for only analgesic action. Otherwise, we have fentanyl, which is more effective than morphine. The main action in this patient is, yeah, beta blockers is coming next. And then comes the role of metoprolol. All patients of MI are always given metoprolol, beta blocker. All patients of MI are given metoprolol, but metoprolol is again contraindicated if BP is already low. If BP is already low, then we will not be using metoprolol in a patient, especially in inferior wall MI. The blood pressure is very, very low because right ventricle is not working. So therefore blood going to left side is also less, and therefore hypotension is there. So metoprolol is contraindicated in hypotension as well as in inferior wall myocardial infarction. The next medicine that we'll be giving to the patient is a low molecular weight heparin. The reason why low molecular weight heparin will be given is because it will inhibit further propagation of clot. Enoxaparin क्या करता है? Enoxaparin clot को बढ़ने से रोकेगा. It will inhibit the propagation of the clot. That is why enoxaparin is given to the patient. The rationale behind giving enoxaparin is कि it will inhibit the propagation of clot. वो clot को आगे बढ़ने से रोक लेगा. And then obviously we need to give statins. Atorvastatin will be given along with atorvastatin because most of our Indian patients are hypertensive. So I would also like to add that ACE inhibitors can be given. So you can add one more to the A that I'm writing superiorly. That is ACE inhibitors may also be required because most patients are hypertensive in India. So ACE inhibitors will help in preventing like the more stress on the heart. I mean ACE inhibitors will block angiotensin II production. So the stress on the heart will be relatively less. Why inferior wall MI will be not give? कल मैंने बताया था ना बेटा, inferior wall MI right ventricle is damaged. That means already BP is low. If your right ventricle is not working, less blood will go to lungs. If less will go to lungs, your blood pressure will be low only. Na? Less blood coming to left side, the BP will be low. So if already the blood pressure is low, I would not like to give metoprolol to the patient. So this is a baseline treatment that will be done in all patients who are coming to us, and especially like for part number 8, I would like to say that I have to give a cath lab call for a case of ST elevation myocardial infarction, because in ST elevation MI, we will do coronary angiography and we will be doing is a primary percutaneous coronary intervention. But if in the MCQ, he specifically says cath lab facility is not available for a case of ST elevation MI, and he says, what will you do? Then your answer will be, I will be starting thrombolysis. Here the guidelines that I've explained to you are, percutaneous coronary intervention should be done FMC to balloon time, FMC to needle time. That are the words that are written. Either it is written door to balloon time or it is written first medical contact. Instead of writing door, you can write first medical contact to balloon, first medical contact to needle time. These values, you guys have already answered me correctly that the procedure should be done or should be initiated within 90 minutes. Like patient came now, within 90 minutes, all these medicines will be given, ECG will be done, and the treatment in the patient should be done. Yeah, Pranav, you another point. Beta blockers are contraindicated inferior wall MI because of vagus stimulation. I gave a simpler reason: right ventricle not working, less blood to left, and therefore the BP in the patient will crash. But this is a summary, guys, of what are we gonna do in one of the common presentations that we get, that is ST elevation myocardial infarction. Now I will focus on a ECG parameter which they love to ask, especially in FMG exam. I've already explained to you that in inferior wall MI, the changes will be seen in lead number 2, lead number 3, and lead number AVF. So I will be showing couple of ECGs to you where we will be identifying the changes. Just to make you practice this again, you can do this activity with me if you want. Before I go on the actual ECGs, you can make a small box like this. This is lead number 1, 2, 3. This is augmented leads AVL, AVR, and AVF. Please do this activity फटाफट से. Just take a piece of paper if you're not noting down. Even then, if you are on the notes, then note with me. V3, V4, V5, 12 lead की ECG होती है. We do a 12 lead ECG, and I'm gonna tell you what they commonly ask. What they commonly will ask you is inferior wall myocardial infarction. I don't know, the examiner in FMG exam has a fetish for inferior wall MI. The NEET PG examiner has a fetish for posterior wall MI. And why, I don't know. This is ST elevation with the T wave inversion. ST elevation with a T wave inversion. If they give you the findings in lead number 2, lead number 3, and lead number AVF, as I have currently shown here before you, it is a inferior wall myocardial infarction. This is a classical representation that I want you guys to remember. This is inferior wall myocardial infarction, 2, 3, and AVF, and I'll do that on the actual ECGs also. Now use a different color. And we will do for V2, V3, and V4. This is the ST elevation with a T wave inversion. This is the ST elevation with a T wave inversion for V2, V3, and V4. If you are going to be getting changes in lead number 1, V2, V3, V4, V1, even if you're not picking up, I'm okay, but V2, V3, V4 should never go wrong. This means that the person is suffering from anterior wall myocardial infarction. So if it is V2, V3, V4, it's an anterior wall MI. If it's gonna be 2, 3 AVF, it is inferior wall myocardial infarction in a patient. So these are like traditional informations that are given. Now what I want to say is that lead number V1 studies the septum. Lead number V1 studies the septum. To see that you got me or not, please comment. Suppose in your exam, if the ECG findings are present in V1, V2, V3, V4, would you like to say anterior wall MI or would you like to say anteroseptal MI? Hit the comment button once, please. If findings are present in V1, V2, V3, V4, would you like to say anterior wall MI or would you like to say anteroseptal myocardial infarction? Quick answers, please. Exactly, anteroseptal. I'm gonna use a different color pen to say another fact at this moment. Suppose the findings are present in V5 and V6. V5 and V6 help you study the lateral surface of the heart. They help you study the lateral wall. So suppose the findings are present in V2, V3, V4, V5, V6. Would you like to say anterior or would you like to say anterolateral? Anterolateral. If findings are present in V2, V3, V4 and V5, V6 anterolateral, somebody was commenting that, sir, the surface of the heart involvement is very confusing. No, guys, even a technician is able to answer it. There is absolutely no confusion here. It is a very simple data which is to be remembered. That would be changes that are found in V2, V3, V4 is anterior wall. If you add V1, it is anteroseptal. If you add V5, V6, it becomes a lateral wall MI. अगर सबको ऐड कर देते हो V1 से V6 में, then it will become a extensive anterior MI. If I add all of them, V1 से लेके V6, if I add V1, V2, V3, V4, V5, V6, if all are added, if you add anterior plus lateral plus septal, तो क्या बनेगा? Extensive anterior wall myocardial infarction. Great, Tuma. Great, Manav. You got it spot on. And now what I'll do is do a simple activity in front of you where, like, even if you don't go as 1 to 3, you can see that very classical hyperacute T waves with an ST elevation that is present here. And I want you to just focus on the core aspects of where the findings are being seen. आप कितना भी कैजुअल होके इस ईसीजी को देखते हो, आई डोंट थिंक सो एनी डॉक्टर कैन मिस द अनमिस्टेकेबल एसटी एलिवेशन विद द कॉन्वेक्सिटी इन V3 and is going into V5 also. So let me do the markings here. The V2 में भी आपको tall T wave तो मिल ही रहा है. You can see the ST elevation and the tall T wave. V3 also the changes are present. V4 also going into V5, going into V6, and थोड़ा बहुत तो यार V1 में भी ST elevation present है. If all the leads are showing the findings, V1 also, V2 also, V3 also, V4, V5, V6. Hit the comment button, guys. Some guys have already done the answer. What would be the findings present? Even if you check out, no, somewhat in little bit in V6 also, not very significant, but because V5 is involved, that means lateral surface is involved. So we will say that the patient is suffering from a extensive anterior wall myocardial infarction. The minimum that I expect you to remember here is that even if you are not able to answer the word extensive, I'm still okay. इतना तो मानोगे that V2, V3, V4 are having classical findings. I hope all of you will agree that V2, V3, V4 are having classical findings, and even V5 is having a finding. So that means it becomes first anterolateral, and I just added if V1 is also present, then it becomes a extensive anterior wall myocardial infarction. बेटा किसी ने बोला था कि सर रिपीट कर दो, विकास बच्चे हिंदी. ओके, लेट मी डू दिस इन हिंदी वंस. मेरे ख्याल से तो आसान है गाइस. लेट्स डू अ क्विक रिकैप हियर. अगर एंटीरियर सरफेस ऑफ द हार्ट है, उसको स्टडी करने के लिए कौन से इलेक्ट्रोड्स होते हैं? V2, V3, V4. अगर V5, V6 जुड़ गए तो लैटरल सरफेस भी रीड हो जाता है. तो हम दो वर्ड्स को जोड़ देना, एंटीरो लैटरल. और अगर V1 को ऐड कर दो तो एंटीरो सेप्टल मायोकार्डियल इंफार्क्शन बन जाता है. तो दिस वाज एक्सटेंसिव एंटीरियर वॉल MI. बिकॉज आपका मिस हुआ, मैं एक बार फिर से समझाऊंगा. जस्ट गिव मी अ कपल ऑफ मिनट्स. लेट मी जस्ट मूव माई स्लाइड देयर and focus on a ECG. मैं थोड़ा नीचे मूव कर रहा हूँ and this is the classical one. I will not say anything. I'll be totally mum. I want everybody, irrespective of तुम्हें ECG आती है या नहीं आती है, आपने क्या करना है? ऐसे जाना. 1 2 3 देखो जरा. Just check out 1 2 3. I will do the markings here also. I will not give interpretation. This is P. This is looking like a R followed by a ST followed by T. So I can say lead number 1. Normal sinus rhythm is present. This is normal sinus rhythm. Even if you are gonna be like extra casual, I think if I zoom in, you will be able to see this is a P, this is a Q, R, and then you can notice this ST segment elevation present, which is slightly convex upwards in lead number 2. Let me move down to lead number 3. In lead number 3, this is a P, Q, this is R, and then it is a ST segment elevation with a thoda sa ST depression that is coming in. I don't think so, guys. ये तो मतलब I will say like this because I hope you're listening. 2 3, and if you move laterally at AVF, so बच्चे, I hope you are able to pick up. This is a Q. You're going up. Okay, I'll use the red color only. This is the Q. This is the R, and then is the ST segment elevation. Even in lead number AVF. This is a very classical question on findings of inferior wall myocardial infarction. I would also like you to, if possible, just don't draw at all on the last ECG. Just follow my words. You will notice that जो AVL है ना, उसमें reciprocal change आ रहा है. That is ST depression. There is a reciprocal change that is happening. Two very classical findings that I've shown in the first and the third ECG. The last ECG on the printout is where the blue marker is present. This is a favorite of FMG examiner. I put it in the end. There are some reciprocal changes which are also present in this patient. But the main focus is, I hope you have been able to identify changes in 2-3 AVF. The answer is inferior wall MI. I want everybody to hit the comment button for inferior wall MI and let me know that which coronary artery will get blocked here. In inferior wall myocardial infarction, which coronary artery will get involved here? Yes, it is the right coronary artery in the patient. I forgot your name. Somebody said it did not understand. Pranav will not get into vectors, no. It doesn't help. It doesn't help in the interpretations. Perfecto. Perfecto. This is inferior wall MI of the right coronary artery. So we've done two things at the moment: anterior wall MI and inferior wall MI. Very classical findings, including the extensive anterior wall MI that was done. Let's move on to the next one. If you are an FMG student, आप इसके बाद में अगर नहीं भी सुनते हो तो चलेगा. Like these two ECGs should never ever go wrong. But I'm gonna tell you what actually happened in FMG exam. This is the second ECG that I'm showing before you, where my student said, "Ki boss, I was confused." I said, "Why were you confused?" He said, he answered the question correctly. He answered the question correctly. He said, patient has come post upper respiratory tract infection. Post URTI patient has come. The complaint of this patient was development of chest pain. The chest pain of the patient is at rest. And then he said that in this particular patient, the chest pain has been present for past 3 days. तो वन ऑफ माई स्टूडेंट सेड कि सर 3 दिन से चेस्ट पेन था तो एमआई कैसे होगा सर, एमआई का पेशेंट 3 दिन से थोड़ी ना चेस्ट पेन रखेगा. द पर्सन कैन लाइक डाई ऑफ मायोकार्डियल इन्फार्क्शन विद इन फ्यू मिनट्स. सो इन दिस पर्टिकुलर पेशेंट इट्स लाइक चेस्ट पेन विच इज गोना बी प्रेजेंट फॉर 3 hours. सो व्हाट यू विल नोटिस इन दिस पर्टिकुलर पेशेंट इज दैट देयर इज अ वेरी क्लासिकल ST segment change. That ST segment change that I want you to pick up for this patient. That ST segment change that I want you to pick up for this patient is, if you check it out, this is gonna be ST elevation, but it is not convex, guys. It is concave. It is not convex. It is concave. It is present in lead number V4. ECG is something that people don't want to study, guys. So chill. Exam में तो आता ही है. Lead number V4, lead number V5, lead number V6. Even when it comes to the V2 lead and V3 lead, the same thing is being reflected, guys. In the leads, there was presence of ST segment elevation. That is gonna be a ST elevation that is concave in upward direction. Please hit the comment button at the moment if you are going to be encountering that the person is having a ST elevation which is concave in upward direction. It is going to be chest pain for 3 days after a post URTI. What would you like to answer? Would you like to answer this as myocardial infarction, or would you like to answer it as acute pericarditis? Yes, guys, acute pericarditis. The diagnosis, this is last time's FMG exam. I understand lot of students were crying after the paper कि सर इतना मुश्किल क्यों कर दिया उसने. तो I agree, this is not the question. They should put this kind of a question in NEET PG, or they should be putting that in INISET exam. But yep, I mean that is how the question where would be present there. So acute pericarditis, the point to be remembered is ST elevation that is concave in upward direction. Guys, everybody is on his own. It's a war. राइट, फिर से बोल रहा हूँ, हमारी जो पढ़ाई है ना, जब अभी तो आपको कमाना नहीं है, राइट. व्हेन यू विल गो आउट, पेशेंट विल नॉट पे यू, राइट. सो डोंट गो बाय मास, go by your exclusivity. It's you who's gonna be finally facing the patients. You are the one who's gonna be facing the exam. So don't bother about others. Just bother on what you are learning, and you are spot on. Yes, guys. I will repeat this again. It is post URTI. That is a khansi jukam, and the chest pain is occurring for 3 days in a patient. If chest pain is for 3 days, it cannot be myocardial infarction. In MI, within 3 hours, patient mostly will die because of the ischemic changes, or maybe within 5-6 hours, patient will die because of ischemic changes. And then if there's going to be ST elevation, which is concave in upward direction, this is going to be acute pericarditis. So that's the level of performance that they're asking in the exam. Right. So we are sorted for the second ECG for today. We're moving to the next one. In this particular question, forget it, man. Moving to the next one. I hope everybody will agree that in this question there is T-wave inversion. Can you see the T-wave inversion? Please comment in the chat box quickly. Lead number V2, lead number V3, and lead number V4. Anterior surface of the heart. There is a T-wave inversion present. If it is convex, man, it would be myocardial infarction. Even that was in the options. If it is convex, it is MI. I'll go by ECG. I'll not go by days. I'm not saying that by days only the question can be. I'm saying two things. Clinical also, ECG also, pericarditis. If it's gonna be like a ST elevation, I'll say, okay, man, MI will be there. Yeah, we can be having presence of ST reciprocal changes. Okay, focusing on this one, guys. There is a T-wave inversion present in V2 and in V3 and in V4. That means, I hope everybody understands, this is anterior surface of the heart. This is anterior wall of the heart. In anterior wall of the heart, there is a presence of only a T wave inversion. There is an anterior wall ischemia occurring. So let me know what should I write for this particular patient. Yeah, even V1, very good pickup. Even V1 is having presence in the finding. Anteroseptal. Okay, great. Great. Good point there. Let me just mark it there. Okay, V1. So this particular patient is having anteroseptal. Help me out. What should I write on the case file? Should I write the word ST elevation MI or non-ST elevation MI? Patient came with chest pain only. 3 hours of chest pain. What will you write on the case file? Yeah, V6, V5 also. T wave inversion. So going towards lateral extensive की तरफ ही जा रहा है. Let's not get into अभी anterior versus anteroseptal. My question is this a ECG of ST elevation MI, or would you like to answer this as non-ST elevation MI? Yes, guys, your answer would be non-ST elevation MI. Don't get into the surface involvement in this particular case. What I wanted to teach you was that in non-ST elevation MI, it is not a guarantee that you get ST depression. Sometimes you might only get a T wave inversion. I repeat this again. In non-ST elevation MI, it is not a guarantee. In non-ST elevation MI, it is not a guarantee that the person will be suffering from. In non-ST elevation MI, it is not a guarantee that the person will be suffering from ST segment depression. It can be exclusive T wave inversion present in a patient. What I want you to understand is there is a non-ST elevation MI, yeah, a myocardial ischemia is present there. They gave this ECG in the paper. And they said what drug will not be given to the patient. I will give options. Statin will not be given to the patient. Aspirin will not be given to the patient. Streptokinase will not be given to the patient. Nitroglycerin will not be given to the patient. Hit the comment button, guys. Within 5 seconds, I want answers. Not given in this case. The question will say, which of the following is not given in this particular case? Very good. Non-ST elevation MI में thrombolysis is not done. The answer to this question is STK. As I have already explained, non-ST elevation MI is a platelet-rich clot where intravenous drugs would be given to the patient. So what I want you to remember is the main statement, that is ST elevation MI thrombolysis. We don't do thrombolysis in non-ST elevation MI. It is anterior surface. Yeah, we can debate about anterior, anteroseptal, anterolateral, but उसने वो सब पूछा ही नहीं. All I hope I've been able to communicate to you that this is a non-ST elevation MI. In spite of fact, ST depression is not present because T wave inversion is present. So I had very good inputs for this one. Now we come to the question of INISET exam. So this is INISET exam question. Let me do the markings first, and then I will be asking you the interpretations, especially if you are an 8 PG aspirant, INISET aspirant. Focus on this one. This is R wave, this is S wave, followed by a T wave. This is ST depression. I'll use a finer pen. I'll zoom it in. This is R, this is S going down, then is ST depression, and then is the upright T wave. Then there is a upright T wave. All through my discussion, I have always said to you that when there is a T wave inversion, it's always followed by ST depression is always followed by T wave inversion. All through my discussion, I've said, whenever I have described any type of MI to you, in any type of MI, I have said that the person is having ST elevation with a T wave inversion, or I have said person is having non-ST elevation MI with a T wave inversion. It has always been a T wave inversion. This is the first time that I am showing you a positive T wave here in lead number V2. In lead number V3, it is even more clear. In lead number V3, it is even more clear. This is R, this is ST depression followed by an upright T wave. If they give you a question with respect to V2 and V3, if they give you a question in the paper with respect to V2, V3 and V4 showing ST depression with upright T wave, don't answer as non-ST elevation MI. Your answer will be given in this particular case as posterior wall myocardial infarction. This was a difficult one, guys, and most app people, what they've done is they have made this as the first ECG question, which makes the students feel very overwhelmed. In my opinion, it should be given in the end, so that once somebody has learned what is non-ST elevation MI, that he can understand this fact earlier. I want everybody to write in the chat box, what is the traditional finding of non-ST elevation MI? Is it a upright T wave or a T wave inversion? Please hit the comment button quickly. I know you know this, but still, just for reinforcement state, what do you get in a non-ST elevation MI? Do you get a upright T wave or do you get a T wave inversion? You always get a TWI. It is a T wave inversion. Even if you're an FMG student and you are listening to this, I'm really proud of you that you are trying to handle the core things which people are gonna chicken out and run away, man. कि नहीं sir, नहीं हो रहा. Every subject has its merits and demerits. This is what will make money, right? This is what which will ensure that you are able to handle. Because why will somebody pay you money if you are able to identify such conditions? So this would be a posterior wall myocardial infarction, which is currently given to you. Do mark it out on this particular slide. This is a posterior wall MI. For posterior wall MI, ideally, what should be given is V7, V8 or V9. Ideally for posterior wall MI, what should be given is V7, V8, V9. कोई बात नहीं, उसने V2, V3, V4 से हमें पूछ लिया, हम इतने केपेबल हैं कि हम उससे भी निकाल लेंगे. V2, V3, V4, we still gonna be able to solve it. The only thing is here the ST depression will not be followed by a negative T wave, it will be followed by a positive T wave as is shown in this representation. That's the highlight of posterior wall myocardial infarction. Damage पीछे है ना यार. So the vectors will be opposite. If you are gonna check out this ECG in V7, V8, V9, there would be a traditional finding of non-stellation MI with a T wave inversion. ECG is a vector analysis, man. ECG is a vector, it's a mathematical analysis, right? So if I go into mathematics of it, I can go into that also, but that is a routine medical college class where we draw vectors and we talk about posterior wall MI. When you are in that situation, when you have an exam in front of you, you need to learn a hack, how to remember it, how to understand it. So obviously, like, a traditional medical college class, when we go into the vectors part, but yeah, reverse vectors are the reason for the manifestations that are occurring here. So guys, these are a couple of ECG findings that I've discussed before you. Just do this with me and then we go for a lunch break. Answers are right in front, but still comment, check out. Imagine that you don't know the answer. Okay, I'll hide it. You can see the changes in V2, V3, V4 and V5 and V6. So this becomes an anterior wall myocardial infarction. Yes or no, guys? V4R is the special lead for inferior wall MI. I hope it's clear to everybody. This is anterior wall myocardial infarction, changes in V2, V3, V4, right? Extensive anterior wall MI. Okay. If I change the question and say post URTI, after a couple of days, there is a ST elevation which is concave. If the ST elevation is concave in upward direction, not convex, concave, then we will say that the person is suffering from acute pericarditis. That is pericarditis. Yep. Okay, we can extend it. We'll do it, right? That is acute pericarditis. Great. The second ECG. In the third ECG, it is a non-ST elevation MI. And what is the medicine that will not be given in this case is streptokinase. In non-ST elevation MI, we will not do thrombolysis at all because it's not recommended, because we can give drugs which begin with T for management of this patient, that is tirofiban. Great. Then is posterior wall MI with upright T waves, as I showed to you, represented before you. The last one that I've highlighted, the last ECG that I've highlighted is inferior wall myocardial infarction, where the right coronary artery of the patient is getting affected. So that was just a summary of the previous year ECGs that they have mentioned. I have obviously spoken about ECG even yesterday. I've spoken about it today also, but these are like a couple of aspects which are currently discussed for myocardial infarction, including the treatment algorithms. Fine, guys. So since you guys are not interested in a break, I can handle one more topic, right? So एक और कर लेते हैं. We have to move up in the slide and I will do infective endocarditis. That is relatively a easier topic. Infective endocarditis कर लेते हैं. It will take like maybe few minutes, guys. Few minutes. एक infective endocarditis निपटा लेते हैं. So after the break, then we can handle the remaining ECG summaries. NYHA beta, I told you, Nita, bache, I told you, Nada, your name went up, Dr. Neha. So, that NYHA, I told you, na, that it's grade 3, that's gonna be at physical, at minimal exertion. That I have already explained to you. Rest is 4, climbing stairs is 2. One though you'll not say, na, that is like, would be present only when the person is like working out in a gym. So it's 3 to be remembered. Okay, fine, guys. Let's do infective endocarditis topic here. Page number है बेटा 27 infective endocarditis. यार पेपर हिंदी में नहीं होता ना यार, मेरा बस चले तो मैं पूरा क्लास हिंदी में लूँ, बट द प्रॉब्लम इज दैट The exam is in English, so I am forced to use the English words. Otherwise, okay. Yes, yes. Chalo, okay. Ji. Native valve endocarditis, that would be hospital acquired. So let's focus on like the organism that would be useful. Native valve endocarditis, the organism. Yes, guys. Which is gonna be the core aspect that would be remembered. Native valve endocarditis, hospital acquired. Yes, guys. I'll continue with English only, man. Yeah. What is the hospital acquired infection? That would be hospital acquired is Staph aureus, man. If the question says what is the hospital acquired native valve endocarditis, then your answer would be given as Staphylococcus aureus. Only if he says the word community acquired, then your answer would be given as Streptococcus, because in hospital no patient would be having a central line in place. Hospital environment, Staph aureus is a common organism, but for community acquired it is Streptococcus viridans which is responsible. Then is the concept of prosthetic valve endocarditis. Prosthetic valve endocarditis means like artificial mitral valve was put. Like for example, in this particular patient, mitral valve replacement was done. The reason why mitral valve replacement was done was discussed yesterday. This gentleman was suffering from calcified severe mitral stenosis. In a person with calcified severe mitral stenosis, mitral valve replacement needs to be done. The organism that is usually responsible in the first year is cons, that is coagulase negative staphylococcus. This patient had a calcified severe MS, so mitral valve replacement was done. So in the first year, the organism is cons only, coagulase negative staphylococcus. After 12 months, what will be the organism responsible? Organism after 12 months, guys. I think this is the easy data that you have to remember. Organism responsible for infective endocarditis. After 12 months, yes, it is Streptococcus viridans. This is again a very straightforward data. This has been taught in microbiology also, so I hope it will be a revision for you. That in infective endocarditis, if after 1 year of surgery somebody is having a lesion, then it is viridans, and otherwise it is coagulase negative staphylococcus. The next question is on TAVR. TAVR is transcatheter aortic valve replacement. The meaning of the word TAVR is that this is a transcatheter. This is a transcatheter aortic valve replacement that has been done. This is the only MCQ where answer is either not Staph aureus and neither is Streptococcus. Normally in the topic of infective endocarditis, all the answers will always be either Streptococcus or will be like Staph aureus. This is the only MCQ of aortic valve replacement that was done, transcatheter aortic valve replacement, where the answer will not be either Staph aureus or Streptococcus. Yes, Dr. Nadeem was the first one to hit the correct answer. This is Enterococcus, and I would rate this as the most important MCQ of this entire question, of this entire box. Everything else, I think everybody knows. It is Enterococcus, which is to be mainly remembered. I'll repeat that once again. In all questions, if you answer Staph aureus, Streptococcus, you will be able to figure out the answers in majority of cases. But for this one, you need to read it is Enterococcus as an answer. Next is the case of CIED. CIED means patient is having a pacemaker in place. The full form of CIED would be cardiac implantable electronic devices. CIED would mean cardiac implantable electronic devices. That could be a pacemaker, it could be a implantable cardioverter defibrillator. So the wires of the pacemaker will go to the heart and they can transmit a bacteria that is again coagulase negative staphylococcus. You will realize that only 2 times the answer is Staph aureus. One is the Staph aureus answer for intravenous drug user. I did not initially ask you that because that is very simple. IV drug user will not be following hygiene. He'll be injecting drugs like in Udta Punjab movie they have shown right across the border the drugs come. That is Staph aureus, or it's gonna be for hospital acquired. Everywhere else either it is Streptococcus or it's gonna be like Streptococcus viridans is the answer. Otherwise it is Staph aureus or it is coagulase negative staphylococcus. The special entries to be remembered in the discussion. The special entries to be remembered in the discussion. The one that you are not able to supposed to forget is Enterococcus. And now what do you mean by infective endocarditis, where we use Duke's criteria for diagnosis, is that there are vegetations on the surface of the heart. Infective endocarditis का मतलब क्या होता है? तो infective endocarditis would mean like if this is the representation of the heart, this is gonna be the heart valves. So on the surface of the heart valves, there is growth of bacteria. Millions and trillions of bacteria are growing. And when millions of trillions of bacteria are growing, then every time when the heart valve will open and when it will close, the vegetations will embolize into the distal circulation. The vegetations will break off from here and they will go into distal circulation. So there is a shower of infective emboli into the distal circulation. So Cons is the organism for cardiac implantable electronic device. Now, because the infection will go into systemic circulation, this is how the question will begin. The stem of the question will say it's a case of rheumatic heart disease. Or he will say it is a patient who's having a pacemaker in place. Or he will say it is a patient with hypertrophic cardiomyopathy. Or he will say it is an alcoholic. Alcoholic written in cardiology always means dilated cardiomyopathy. Or he may say IV drug user. Any of these terms can be used in a question. And after describing these terms, he will say patient is having fever for past 2 weeks. If you read about presence of fever in any patient of known heart disease, it can be rheumatic heart disease, pacemaker, hypertrophic cardiomyopathy, alcoholic, intravenous drug user. If you ever read a question in which there is fever for 2 weeks and he says that on examination in a patient, because the infection will go to the spleen, so it will cause a splenic abscess, it will cause a splenomegaly. If in an Indian exam you get a question in which a person is having a known heart disease or a known heart condition, it can be rheumatic heart disease, pacemaker, hypertrophic cardiomyopathy, known heart condition patient is having fever and there is a splenomegaly, you always have to think in terms of infective endocarditis. Sometimes they might be mentioning a finding with respect to the changes in the nails of the patient. This finding in the changes in the nails of the patient would be presence of clubbing. But in an Indian situation, known heart disease patient may, agar the buzzword in the question is presence of fever and there is a splenomegaly given in a question in a known heart disease patient, you will say that you are dealing with a query infective endocarditis and you will use modified Duke's criteria to demonstrate the presence of organism. This is a clinical based question that just came simple. He said known heart disease patient having fever and on examination splenomegaly. What is the probable diagnosis? In cardiology, if there is fever present in splenomegaly, answer infective endocarditis. And we will obviously be studying regarding modified Duke's criteria to be confirming the diagnosis, where we will have major criteria and minor criteria. So I will talk about each one of them. The crux of the discussion is that whenever we have major and minor criteria, we need to demonstrate the organisms. And we need to demonstrate the damage in the heart valves of the patient. We need to demonstrate damage in the heart valve by doing echocardiography in a patient. At the moment, just to emphasize this further, just to emphasize this patient, IV drug usage. This alone is sufficient. It can be splenomegaly, it can be brain. I mean, not always there is like an abscess formation in the brain. So it's mainly a splenomegaly and clubbing. That is much more sufficient. HASEC is like culture negative. HASEC would be culture negative, but then the basic point is this is gonna be like the heart valve which is present. The bacteria are growing deeper and deeper. So there can be abscess formation in the valve. This abscess formation can be picked up on echocardiography. We can do a PET CT, we can do a cardiac MRI, we can do a echo, and there we can pick up a valve abscess in the patient. And then what can happen in this person is the infection will destroy this valve. Look at the horrible thing that I'm showing. The infection will destroy the valve, due to which the blood can leak back. Like at this moment, I modulated the diagram to show that now the aorta blood is leaking through this leaflet into the cardiac chamber, and there can be a murmur developing in a patient. You can see I have shown a perforation. In the valve leaflet. This perforation can be seen on echocardiography because there would be jet of blood going back into the heart of a patient. So if you ever read the phrase new onset murmur, if you read a question saying new onset murmur in any patient of pre-existing heart disease, the examples of pre-existing heart disease I have already given to you. Pre-existing heart disease can be like rheumatic heart disease, IV drug user, it could be hypertrophic cardiomyopathy, alcoholic cardiomyopathy. New onset murmur is a diagnostic criteria for infective endocarditis. So examiner, if he will add more data, like if he starts saying murmur, he says valve abscess, he says there is structural damage which is causing a new onset murmur. Those are like additional hints given in a question. But then the point is, if you are not having all of this, simply known heart disease patient having fever with splenomegaly, it is infective endocarditis. Though it's given in the printout, please answer for my satisfaction. How many major criteria are required? Then your answer is 2 major criteria. How many minor are required is what you need to comment. How many major and minor combination is required? It is 2 major or it is 1 major with how many minor? Yes, guys. It is either 2 major criteria. Major can be like blood culture is positive. For Staph aureus, echo is showing vegetations. That is sufficient for diagnosis. But if it is gonna be only 1 major criteria, how many minor would be required? Yes, it would be 3 minor criteria. This operates a little different. This criteria operates a little different. This criteria operates a little different. From Jones criteria that you study in pediatrics, it is 1 major with 3 minor criteria, or it can be 5 minor criteria. So yes guys, that's the algorithm name that you need to remember, that in modified Duke's criteria या तो 2 major, इसमें कोई गलती नहीं करता. Mistake occurs here only. It is 1 major with not 2 minor. It is gonna be 1 major with 3 minor, or it is 5 minor. These two everybody is comfortable. This is where the errors usually happen. So just take care of that. Most of you have done a great job. I've answered that very clearly. So the criteria is based on pathological. Pathological would mean like you are able to demonstrate the bacteria. You are supposed to show vegetations on echo. Clinical means like there could be the manifestations that I'll be explaining to you. Like murmur was one of the findings I mentioned. Splenomegaly was one of the findings. So we are going to discuss each of them, major and minor, separately. And now I will first focus on like what are the minor criteria, because most of the time in the exam he will not ask you major, he will ask you minor criteria. In the PYQ he said calculate the total number of minor criteria. I will first just state that MCQ before you. The question began by saying IV drug user patient came to the hospital. One criteria. He is having fever for 2 weeks of 102 degree Fahrenheit. 2 criteria. On examination, Janeway lesions were present. 3 criteria. And on physical examination on the tip of the finger, Osler nodes were present. He said calculate how many criteria are present. 4 criteria are present in a patient. I will explain more in detail, but I just wanted to say the PYQ said IV drug user came to the doctor with complaints of unexplained fever for 2 weeks. He also mentioned fever hovering around 102, 103, comes back after the paracetamol effect goes away. On examination, I will teach you what is Janeway, what is Osler. So be patient. But he just said calculate how many criteria are present. So you just had to basically pick up the words in a question and say 4 clinical criteria. Yes, Kirti, you are spot on. This was 2024. Now, how to remember them? The query of most students is, sir, how to remember them? First, pick up immunological phenomenon. Immunological phenomenon begin with a mnemonic ROG. ROG, disease को हिंदी में रोग बोलते हैं. Disease called as रोग. Alphabet R will stand for rod spots, but R will also stand for positive rheumatoid factor. Rod spots and positive rheumatoid factor. Normally rheumatoid factor is read in rheumatoid arthritis, but it's an antibody. So can be present in this because infection is there. So any of the two, rod spots or rheumatoid factor, can be present. O is Osler nodes, on which the famous American US residency of Osler in Harvard is present. That Osler nodes is painful nodules. इनको कहाँ देखते हैं तो pulp of the fingers में. These are painful nodules. These are immunological manifestation because there is bacteria. Antibodies are also getting formed. So painful nodules in the pulp of the finger. जो फिंगर का टिप होता है, फिंगर का जो टिप होता है, पेनफुल नोड्यूल इन द पल्प ऑफ द फिंगर्स is the Osler nodes that is present. And then G will stand for glomerulonephritis, that is like post streptococcal glomerulonephritis. It is PSGN. It is post streptococcal glomerulonephritis. Let's do a recap. ROG. R से क्या किया हो गया, बिना देखे प्रैक्टिस करना. R से हो गया rod spots. They are a fundus examination. R से rheumatoid arthritis positive, O से Osler nodes, and G is glomerulonephritis. So that is sorted for immunological. For vascular phenomenon, what you have to understand is the meaning of the word vascular phenomenon is that the vegetations will break off and they are going everywhere into distal circulation. So one of the words which was an FMG exam question जो था ना, वो बड़ा सिंपल सा था. उसमें तो उसने डिटेल भी नहीं बोला हुआ है. एक और FMG क्वेश्चन बोल रहा हूँ. उसने बोला mycotic aneurysm is caused by. All of you know that mycotic means fungus, but mycotic aneurysm is caused by Staph aureus. I'll say this again. when you focus on the word mycotic, mycotic would obviously mean it is a fungus, but it is caused by, like, what I want you to appreciate is bacteria are growing on the heart valves and they're going out of the heart into the systemic circulation. So it would be a mycotic aneurysm involving the brain blood vessels of the patient. Mycotic aneurysm कहाँ पे होता है? तो brain blood vessels में होता है, and it can rupture and cause intracranial hemorrhage. Just like you guys are comfortable कि berry aneurysm can rupture and it can cause subarachnoid hemorrhage. Just like you are aware that berry aneurysm can rupture and can cause a subarachnoid hemorrhage, ऐसे ही परेशान नहीं होना अगर intracranial hemorrhage is written in a question of infective endocarditis because this mycotic aneurysm can burst. इन्फेक्शन आया कहां से? फ्रॉम द हार्ट वेल्स, इट वेंट टू द ब्रेन ब्लड वेसल, उसने ब्रेन ब्लड वेसल को स्ट्रक्चरली डैमेज कर दिया, एंड ड्यू टू द स्ट्रक्चरल डैमेज टू द ब्रेन ब्लड वेसल इट विल पॉप ऑफ लाइक अ balloon, and that's why you have a brain hemorrhage occurring. You could have damage to the blood vessels of the conjunctiva, so conjunctival hemorrhage. But of main interest is the examiner wants to hear this classical terminology, that is Janeway lesions. Janeway lesions are, what are Janeway lesions? These are reddish erythematous macules. What are Janeway lesions? They are erythematous reddish macules, and these erythematous reddish macules are present on the palms, or these erythematous macules are present on the soles of the foot of a patient. So unlike ossular nodes, which was in the pulp of the finger, which is in the tip of the finger, this lesion would be seen on the palms and on the soles of the foot of a person. Janeway lesions are classified as a vascular phenomenon, that is embolization occurring, and immunological means antibody antigen based reaction, which is ROG, rod spots, rheumatoid factor, ossular nodes, and glomerulonephritis. In vascular phenomenon, one more thing which I have written earlier, but you can see at the moment, is infection can go to the brain. So brain abscess, it can go to the spleen. So it can be a splenic abscess that would be occurring in a patient. So the main point is that the person would be ending up with development of this extensive manifestations which are currently highlighted before you, that is vascular phenomenon, immunological phenomenon, and then is microbiological evidence which is with respect to a culture. But at this moment, what I want to bring to your attention specifically is that for minor criteria आपको याद क्या करना है? It is presence of predisposition, that is some cardiac condition will be given, fever, vascular phenomenon, immunological phenomenon, and then you will be able to, yeah, Janeway lesions are gonna be painless. Janeway lesions are painless, and pain and painless is very subjective finding, guys. Pain and painless is very subjective. The main thing is the site where you check it. The site where you check it, that is the main thing. It's not the pain that is subjective. So these are the minor criteria which are useful for diagnosis. And now I will explain to you the major criteria which are used. For major criteria, I want you to remember the following aspects, which is the word to be remembered is MIS, MIS. For the major criteria, the word to be remembered is MIS, MIS. Let us now practice MIS here. Major criteria for diagnosis of infective endocarditis which have gone a significant change. First is microbiological criteria, M. Then is imaging criteria, then is surgical criteria. This is the update that I'm telling you. MIS is microbiological, immunological, and surgical criteria. MIS that you need to remember. This is the update that I'm telling you. In the older version, there was none of these manifestations given. It is micro, immunological, imaging, not immunological, imaging, and surgical criteria. So let's work them one by one. For the microbiological criteria, you need blood culture. But the problem with blood culture, it is overrated, guys. Blood culture is the most overrated test in whole of microbiology. Nowadays, he says, what is the need of like wasting your time on blood culture report when you are having PCR facility nowadays? Even if you are not using PCR, you can go for IFA, you can go for immunofluorescence antibodies for IgM and IgG, because if any infection is present, we can use IgM, IgG. Obviously, we will be doing a blood culture. I don't dispute that. Obviously, we will do a blood culture. Lekin he says that why should we be wasting our time waiting for blood culture? Blood culture report will take 2-3 days to come, na? So he says, why should we waste our time 2-3 days to identify on the basis of like what is the blood culture report? We can do a PCR, we can do for a immunofluorescent antibody identifying the antigens. So the first message is don't rely only on blood culture. Now hear me out very carefully. All eyes on the board, please. Remember the words 3, 2, 1. Remember the word 3, 2, 1. What you mean by 3, 2, 1 is that you will take 3 sets of 2 culture bottles each. 3 to 1 means you will be drawing 3 sets of 2 culture bottles each. Like for example, you came to the round in the morning today at 8 a.m. You will draw 20 ml blood of the patient, 10 ml, 10 ml in each of the culture bottles. One culture bottle will obviously be aerobic, one will be anaerobic culture bottle. So you will be having two sets. You will be having 2 culture bottles. 3 to 1 means 3 sets of 2 bottles each at a gap of 1 hour. That is, you will take sample of 20 ml at 8 a.m. and 10 ml, 10 ml in both culture bottles, aerobic and anaerobic. Sorry, I wrote aneurysm. The word is aerobic and the second is anaerobic culture bottle, because at the moment I don't know what is the bacteria present. So I'm trying to be as broad as possible. So aerobic and anaerobic culture will be done at 8 a.m. 20 cc blood taken. Now at 9 a.m. I will take a blood sample from a different site. Like suppose I took first sample from the right cubital fossa. Now I will take it from the left cubital fossa and I will be taking 20 ml blood. And at 9 a.m. again divided into like aerobic and anaerobic culture bottle, send it to the lab. At 10 a.m. I will be again taking 20 ml blood, 10 ml, 10 ml and send it to the lab. So at a gap of 1 hour, this 1 stands for at an interval of, this 1 stands for interval of 1 hour. The 2 means that it is 2 sets of culture bottle, it is 2 bottles. And 3 would mean that it is total of 3 sets that are being taken. This is the ideal way. If he says what is the ideal way to identify that the person is having infective endocarditis, it is 3 sets of 2 bottles each at a gap of 1 hour. But the problem is that when you will take 60 ml blood of a patient will cry, sir, you are like literally like a vampire, you are drinking my blood. If you ever taken blood sample, the patient will cry. He will say, sir, you are literally like a vampire. You are like literally drinking my blood, sir. I am not happy, doctor. Like I want a discharge. You guys are literally draining me out of blood. Already the blood is very less. So the update now he says is, the update he says nowadays is, that is what you guys are pointing out. The update says that you can take 2 sets of 2 bottles each. You can take 2 sets of 2 bottles each at the same time that you will have to draw 40 ml blood of the patient. तो रोएगा तो अभी भी पहले से कम रोएगा. You will have to take 2 sets of 2 bottles each. At the same time, he says you don't need to prick him at like, one in the right cubital fossa, one in the left cubital fossa. At the same time, you can like put a cannula and draw 40 ml blood, 2 sets of 2 bottles each. This is for, he says, if it is typical organisms. Typical organism is when you're suspecting Staph aureus, Coagulus negative Staphylococcus, Streptococcus, then you can take 2 sets of 2 bottles at the same time. It is like for typical organism, it is gonna be 2 sets of 2 bottles at the same time. So if they specify in the question that update, then it is 2. But if it is ideal word written in a question, if it does not say the word update, if it says ideally what we should be doing in a patient, then the traditional data is it is 3 in a patient. And now when you will talk macro people, they will laugh over it. कि क्या सर काय झंझट में फंसना, PCR है ना. Yeah, both reports should be with the same organism. Both reports should be for the same Staph aureus, Streptococcus, cons, like that. Obviously, I mean, out of 3, 2 sets should be positive with the same report. But what I'm trying to say is, guys, that blood culture is overrated and lots of time culture reports come sterile, especially because patients have taken antibiotics. That is the reason why he says if you're suspecting rare organism could be like Staph aureus, it could be like Coxiella. So for rare organism, he says that don't bother, go do a PCR, do antibody test. So this is what is given in the latest edition of Harrison. He has mentioned that for if you are suspecting like Q fever, he says like if you suspect that the patient got infection from cattle in the house or sheep in the house, no, like rheumatic heart disease patient is at home, जैसे घर पे गांव में ना घर पे वो sheep रखते हैं. In the house, they keep goats. In rural India, wherever you go, right from Kashmir to Kanyakumari in India, you'll notice that at home, like animals are kept, no, like lamb, sheep, like, if it's colder, they might be keeping lamb and sheep, that is for wool and meat, goats, right, cattle, etc., for milk, etc. So, if he says rural India specifically, and he says specifically that patient probably got infection from a zoonotic infection, then it is Coxiella burnetii or Bartonella, that could be coming from pets, na, like the pet could be a dog. The pet could be a dog, no? Like the dog, cat scratch disease. I mean, it could be a cat, right? Most of the time, cat scratch disease. So my message at the moment is whether he says the word pet or if he says domestic animals, livestock, then it is like a PCR test that would be present in a patient. So the main message in this particular patient is update is two sets of two bottles each. Update is for typical organism like Staph aureus, two bottles, two sets of two bottles each. Two sets मतलब जैसे कि like two sets means two bottles each of aerobic anaerobic, another set of aerobic anaerobic, and like I said aerobic and anaerobic simultaneously, so it is 2 to be remembered, but it is not going to be drawn at like 8 a.m. and 9 a.m. It is like you put a cannula, and from the cannula you can draw the blood, or you can put a scalp vein in the patient, and from the scalp vein you can draw the blood. It would be like 40 cc blood that is taken in the patient. So how do we know clinically, na? If it's an IV drug user, then it is Staph aureus. If it's a bacha at house, what did I say? Bacha coming from rural India and they are having pets in the house, तो बच्चा थोड़ी ना IV drug use करेगा. There is no dental manipulation done. Streptococcus comes from where? Dental extraction. If they say अब root canal treatment करवाया था, dental extraction was done. That is when Streptococcus bacteria can come from the mouth. If there is no history of dental extraction, if there is no history of IV drug usage, there is no history of valve replacement in a patient, then probably the infection came atypical in a patient. So total is 4 bottles. It is 6 bottles. Then now it is 4 bottles, two sets or two bottles here for the aspect which I mentioned at the moment. So this is like an ideal situation that is present, that is can be used. The next statement that I will make is for NEET PG questions. He said that single culture is sufficient. If single culture is positive, for which organism will even a single culture report turn out to be positive? If you're an FMG statement, you can neglect this statement. This is a NEET PG PYQ, that for which bacteria single culture positive report is sufficient. Normally out of 3, 2 should be positive. Out of 2, both should be 2 positive. Like 3 out of 2, out of 3, 2 should be positive, or 2 out of 2 should be positive. But only scenario where even one culture bottle positive is for Coxiella burnetii, that is responsible for development of Q fever in a patient. So it is like, again, practical aspects are you have to follow what we are saying, and this is the update of the international society, the American Infectious Disease Society, which is to be followed. So for pathology, you follow slides, I'm okay. You follow the type 1, type 2 hypersensitive, it is okay. But what is done practically, that for that you have to follow what we are saying. So it's not a 12-hour gap. It is at the same time that the sample will be taken, right? It's like this, yaar, mujhe slide dekhna nahi aata na, yaar. So I might say something which is like maybe artifact, and I might think that it is an abnormality. Similarly, from their domain, like the interpretation of how to analyze a patient would be limited, because their role is not criticizing a branch, not glorifying a branch case. Everybody has their limited. मेरा जो domain है वो मैं देख सकता हूँ, दूसरे का domain दूसरा देख सकता है. Coming back to the agenda, Coxiella is where single blood culture would be positive, and now comes the imaging criteria which have again been updated. Echocardiography is not able to scan the periphery of the heart valves, so we now have updated criteria in the form of cardiac CT. Earlier in the MCQ, like it was echo only. Now it is cardiac CT. And another investigation he has mentioned, very interesting, FDG PET scan. So for SIR, MIS, it is microbiological, that is blood culture and PCR, and IFA, 3 points I mentioned, that is indirect fluorescence, immunofluorescence assay for IgM, IgG antibody. In imaging, you need to remember echo, cardiac CT, PET CT, any written is sufficient for diagnosis. And the most important update, if you are a NEET PG aspirant, is what they asked, direct documentation. Patient is undergoing heart surgery. And the surgeon can see the vegetations on direct inspection. Earlier, nothing like this was ever mentioned in the textbook. But now he says during heart surgery, if you see vegetations growing on the heart valve, it's a destroyed valve, damaged valve, that is taken as a major diagnostic criteria. So the points that I want, especially like if you're a NEET PG aspirant, to be very, very thorough are the blue markings that I've done. Single blood culture for Coxiella, cardiac CT and a PET CT, direct inspection on heart surgery is the surgical criteria. Any one of them is positive is a major diagnostic criteria. Any one of them positive is a major diagnostic criteria. To summarize, guys, I can say like this. If I suppose say to you, culture is positive, echo is showing vegetations, cardiac CT is positive, 2 criteria satisfied, no need to read the clinical detail. But because patients have taken antibiotics in advance, therefore culture will come sterile. imaging might come normal because vegetations will be chota chota because person has taken antibiotic, vegetations are chota chota. So how do I identify now? Either I can go for PCR, I can go for a cardiac CT in a patient because cardiac surgery not all patients will be undergoing. No? So we have to rely on major and minor criteria for interpretation of this. So this is an like an updated details that I wanted to remember for the topic of infective endocarditis. So do check out this slide, guys. The important one, that is MIS. I would say this slide is like relatively, because more questions have come in NEET PG from this, so I focused on this. And for FMG exam, they mentioned the minor criteria, which I've already explained to you, and the combination of these is what is called as infective endocarditis. So I hope everybody is okay with a break at the moment. I think we've been going for 3 hours straight, guys. I can push 1 hour more only, but I think that you can imbibe limited information. So when I start getting less responses there, I get an idea, right? People are getting tired. So, okay. So we go for a break at the moment. It's like 30 minutes break. So at 3:30 will be 3:35. 3:35. It's almost like a little more than that. So 3:35 we will start again, guys. Break. This is the break time. 3:30 is when we are starting again. Great. Take care, guys. Okay, guys, please join back so we can get started. Hi, Charan Tej. Hi, Krishan. So so we can get started. Fine. You guys need to come to page number 22. What we do in the next half an hour is just summarize the common ECG findings, and then we'll start with a new topic that is neurology. Hi, Raman. Today's Turkish for lunch. नो नो विल डू न्यूरोलॉजी थोड़ा सा न्यूरो के टेक्निकल एस्पेक्ट्स करेंगे फिर एंडो कर लेंगे एंडो विल आल्सो बी प्लान ओके गाइस सो आई थिंक वी गुड टू आई सेड एंडो ओके फाइन एंडो करा देंगे तो नॉट अ प्रॉब्लम okay so we'll do it subsequently what we do at the moment is we just summarize the ECG findings at the moment and after doing those ECG findings then next would be like I can summarize the dukes and then we can move on to the neurology component okay ji fine. So at different points of time, these abnormal ECG findings have been discussed, and what I'll do is summarize them at the moment. Let's look at the first information that is being provided to you. The first wave in the ECG is the P wave, and it indicates atrial depolarization. The vertical height of the P wave is less than 2.5 millimeters, that is 2.5 small squares. And when it comes to the duration, the P wave will fit into something like 3 small squares. One small square is 40 milliseconds. So the duration will be less than 120 milliseconds. So at the moment, the first thing is that I mentioned the normal height and the normal duration. Now what they can ask you in the paper is one, what is called as P mitral. P mitral, 99% of doctors are able to solve it simply by saying English mitral means mitral stenosis related and mitral stenosis, mitral valve is on the left. So the answer will be P mitral is seen in left atrial enlargement. But technically speaking, I just want to say that meaning of the word P mitral will be that the duration of the P wave will be substantially increased. Like what I have done here is that I have substantially tried to increase the duration because left atria is super dilated. So current will take more time to go across the left atria. Even if you don't remember the diagrammatic representation, chalega, what you need to remember is the fact that P mitral is seen in left atrial enlargement. The logic is mitral valve is on the left side, so left atrial enlargement in a patient. So the point to be remembered would be P mitral indicates left atrial enlargement. Now we will talk about P pulmonale that was asked in last year's NEET PG. P pulmonale, as the name suggests, is like problem, like pulmonary artery. Where is it? It is on the right side of the heart. So 99% of the students who sat for the paper were able to solve it by English only, that pulmonary artery is connected to the right side, so it is going to be like right atrial enlargement. But technically, like what we find in this condition is that the vertical height also is significantly increased. Like as compared to normal, if you see in this condition, I caused a substantial increase in the vertical height, that is P pulmonale, which is indicative of right atrial enlargement. I'll do the activity once again. If you look at the word P mitral, it means mitral valve is on the left side. So LAE means left atrial enlargement. That is the answer in the question. If he says P pulmonale, pulmonary artery is on the right side of the heart. So right atrial enlargement. The technical answers are the vertical height in this case would be more than 2.5 millimeter. And in P mitral, it is specifically a duration part that is concerned. And once you've done it, then is another NEET PG question that says pseudo P pulmonale. Pseudo P pulmonale means that the vertical height of the P wave is still more than 2.5 millimeter, but it is not in the patient who's having any like problem in the pulmonary artery. It is seen with the electrolyte imbalance. Why are you calling it pseudo? You are calling it pseudo because of the fact that the problem is not in the structural damage to the heart. It is with the electrolyte imbalance. So the name is pseudo P pulmonale. Yeah, Karthik, a good input. COPD has P pulmonale. Why? Because one simple COPD will affect the lungs. Damage to lungs will cause pulmonary artery hypertension, and pulmonary artery hypertension will cause the right side of the heart to enlarge. So P pulmonale is a ECG finding that is seen in COPD patients also. A good input that you provided. I'll just do the writing once again. COPD hypoxia will cause pulmonary artery hypertension. Due to pulmonary artery hypertension, the right side of the heart will have to do extra work. So we get a right chamber enlargement. I mean the right ventricle, right atria will get enlarged, and when the chambers enlargement occur, then atrial enlargement will be showing P pulmonale and P mitral. This is actually old year data. It is very classical, and nowadays like nobody uses ECG for chamber enlargement. We use echocardiography. But because of the fact that this is given in medicine books, so that is the reason why this is being discussed. And now we come to, yeah, the clinically relevant one. This was an FMG exam question, has been discussed already, but I'm going to write it once again. Absent P wave is seen in, that is the one of the common arrhythmias in clinical practice, especially in alcoholics, where you get holiday heart syndrome, that is atrial fibrillation. In the MCQ, he may not write the word atrial fibrillation. If you ever read a question that an alcoholic went to a party and he drank himself to death, an alcoholic went to a party and drank himself to death, then binge drinking can trigger an arrhythmia by the name of atrial fibrillation that is called as holiday heart syndrome. I repeat that again. Atrial fibrillation in some questions can be written as holiday heart syndrome. Alcoholic went on a holiday and drank so much that the binge drinking. What will the binge drinking do? It will suppress the vagus nerve, and when the vagus nerve will get suppressed, then the arrhythmia will be able to cause a fast beating of the heart, and therefore the blood pressure of this patient collapsed. The next condition that causes this is sick sinus syndrome. Logical to say SA node is malfunctioning. The malfunction of the SA node, the sick sinus syndrome, the P wave will be missing. And third is electrolyte imbalance, that is hyperkalemia, which will be discussed even subsequently. So three causes of absent P wave are atrial fibrillation, malfunction of the SA node, and hyperkalemia. This is a summary for all the findings or abnormalities of the P wave, which is an upright wave. Now we have an irregular pulse. Now I will be teaching you abnormalities of the Q waves. Normally the Q wave is very, very chota. But if they become very, very deep, then we call it a deep Q wave in a patient. You see, normally the Q wave will fit into one small square of the ECG. Like in one large square, there are 5 smaller squares. So what I'm saying is that normally the Q wave is very chotusa. It will fit into one small square of the ECG. But deep Q wave is what you get with respect to myocardial infarction. Then is a peculiar term that will be discussed in respiratory system S1, Q3, T3 pattern. The meaning of this is that there would be presence of deep S waves in lead 1. There would be deep Q waves in lead 3. If you read the data, it is deep Q waves in lead 1. It is deep Q waves in lead 3. And then you have a T wave inversion in lead 3. But he will not ask you this. He will ask you that this particular pattern will be seen in which cardiac condition. The hint is that the question will begin by describing that the person was having deep vein thrombosis, calf pain, swelling in the foot. Then the clot migrated from the deep vein towards the heart, and there was a sudden onset breathing difficulty. You can very well understand what am I talking about. Deep vein thrombosis clot is going in the right side of the heart and is sandwiching at the pulmonary artery bifurcation. That is a saddle embolus. The condition that I'm talking about is massive pulmonary embolism. So when a person is having a big clot that is occluding the pulmonary artery, it is a complication of deep vein thrombosis. If deep vein thrombosis was being managed by giving heparin to the patient, this would not have occurred. But if deep vein thrombosis will not be diagnosed, then it will cause massive pulmonary embolism and S1Q3 pattern. Some students say, sir, can you simplify this further? Then I say, yes. If the clot will occlude the pulmonary artery, then right ventricle will be in strain. Right ventricle will have to do more work. Na? So don't be surprised that in some questions, instead of writing the word classical massive pulmonary embolism, he may just write a simple term, right ventricular strain pattern. S1Q3 T3 is called as right ventricular strain pattern because the right ventricle is working hard against a resistance, which is a big clot, which is occluding the pulmonary artery of the patient. And here, Dr. Sahu, you're right. If there is a immobilization history given, or he might himself make it easy by saying deep vein thrombosis. I mean, the guy, if I say calf pain, if I say foot movement, dorsiflexion is causing calf pain, it implies deep vein thrombosis in a patient. But point well taken that if he says immobilization, things become easier. Yeah, Charantej, we'll talk about all those signs that you are saying and CTP in the respiratory system when the time comes. But at the moment, this is a summary of abnormality of the Q waves. And now we will talk about PR interval, the classical short PR interval versus prolonged PR interval. The examiner has some attachment in FMG exam to Wolff-Parkinson-White syndrome, so I will be giving you inputs for the same. And then in NEET PG, it is like some attachment with heart blocks, which I've already explained to you. So first point, which I want to say is that PR interval always has an inverse relation with heart rate. Because PR interval has an inverse relation with heart rate, any condition causing tachycardia will always be contributing to a short PR interval, and bradycardia condition will be causing a prolonged PR interval. Just for the sake of completion, if I say that if somebody is having a panic attack, somebody is having generalized anxiety disorder, if you do the ECG, you will be able to notice that they'll be having short PR interval. Instead of writing anxiety, he might write words like Graves' disease. You know, Graves' disease will have excessive catecholamine, excessive thyroid hormone activity that will cause sympathomimetic stimulation. He may write pheochromocytoma patient. Pheochromocytoma will be having excess of catecholamines. That will also result in short PR interval in a patient. Or he may write heart failure patient who will also be having tachycardia. So first are common things like anxiety, Graves, pheochromocytoma, heart failure. And then comes what you guys are saying, Wolff-Parkinson-White syndrome. Now, what is Wolff-Parkinson-White syndrome? It is a condition of accessory pathway in the heart. What I mean by the word accessory pathway is that the current in a normal person will go from the SA node to the AV node, then will go to the bundle of phase, then will utilize the Purkinje network, and finally will be hitting the cardiac muscle. So this is how like normal conduction in our heart is occurring around the clock. The current is going down like this into the bundle of phase as we have discussed yesterday. But today I am going to show you a abnormal conduction pathway that somebody had commented very rightly, bundle of Kent. Wolff-Parkinson-White syndrome is a genetically acquired condition where bundle of Kent will be present. Because there are two pathways in the heart of the patient, so we will also use the word accessory pathway. Why I am saying the word accessory pathway is because there are two conduction systems in the heart of the patient. One is the normal conduction system and the second one is this accessory pathway. This accessory pathway does not have vagus nerve innervation. Vagus nerve is present where vagus nerve innervates the AV node and it slows the conduction. But this red that I've shown can be taken as like an express highway where there is no decremental property, there is no vagus nerve. So the current will race like this. The current in this condition will race like this down directly and activate the ventricles earlier than normal. The problem with Wolff-Parkinson-White syndrome is early activation of ventricles. And again, like I explained to you yesterday, early activation of ventricles is bad. Why early activation of ventricles is bad is because the ventricles will not get time to get filled with blood. If you have early activation of ventricles, they will not be getting properly filled with blood. That means endostolic volume will be less than 130 ml. If input is less, output will also be less. So cardiac output will also be less. The question will begin by describing a young guy. He has come to the hospital because of two complaints. One, he says that even when he's sitting on a chair, he's having palpitations. So some psychiatrist has started him on anti-anxiety medicine. But in spite of that, like this guy's symptoms of anxiety are not decreasing. Like he has started on benzodiazepines. You are yet to like let me know what is, like I asked you yesterday, like nobody commented what is the benzodiazepine that is used. Coming back, palpitations are occurring in this guy. He's taking anxiety medicine in spite of that, and he also is telling me that he's having exercise intolerance. What I mean by exercise intolerance is cardiac output is less. So थोड़ा भी exercise करता है तो थक जाता है, तो he says sir I'm not able to dance or like do any physical activity. So I told him थोड़ा exercise ज़्यादा किया करो, live a healthy lifestyle, पानी ज़्यादा पियो, it's hot, and like routine. I thought he's having a psychiatric issue, so I told him like routine general health के parameters. He said, okay, doctor, fine, as you say, but I just want to tell you that my brother was also having similar problems. And one day, in spite of the fact that he had been to so many doctors, some doctor साहब ने बोला, nothing is wrong with you, and my brother had died suddenly. I was like, what? He says, yes, sir. My brother was also having a similar problem, and my brother had unfortunately died suddenly. So, like, I realized, यार ये तो गलती कर रहा था मैं I was telling this guy कि you have to take care of health and drink water and पानी पियो, ये इससे थोड़ी ना होगा. This guy was having history of sudden cardiac death, so I said तुरंत ECG करा के आओ मेरे पास. When I got the ECG of this patient done, then I wanted to remember, see, this is a revision class, so I want to highlight the core aspect here. The core thing is that because there's a tachycardia, the ECG will always be showing a short PR interval. Along with the short PR interval, the second thing will be that in this person, when you will check out the ECG, there will be abnormality which people have already commented, that is called as delta wave. So in the exam, the P wave will finish, and the moment the P wave will finish, you will notice a change in the slope in the upswing of the R wave. That is what is called as delta wave. So if you look at this diagrammatic representation, what I've tried to show is normally to you and me the R will go straight up. Here the R is having a change in slope. Why? Because the current is going in the heart in an abnormal fashion. If you check out the diagram, the current is not going in the heart the normal way. In your and my heart current goes by the AV node, then both sides of the AV node into bundle of his and then into the cardiac chambers. But here it is bypassing the entire circuit. There is no septal activation happening, so there would be no Q wave present, and you will get the core thing that is delta wave. The C point of this discussion is to be remembered. If you want to get into the mathematics of it, I've discussed in the main, but in the exam, what is the core aspect which is to be remembered is that he will write a parameter called as PJ interval. Now, students, if they've not listened to this, they say that, sir, I've read about PR interval, you wrote PJ interval. So I'll draw line diagram for the same also, but I want to say that first remember what is to be answered. The PJ interval in this particular condition is normal. I'll give you the quick rationale also, but the point is this is not PR interval, guys. It is PJ interval. That is to be remembered is normal in this condition. And now what I'll do is I can use a finer font here and just show you the PJ interval. This is P, this is QRS, and this is the T wave. Multiple times in the discussion, I have told you that starting of the P to the starting of the Q wave is called as the PJ interval, PR interval, and our PR interval is not till the R wave. I said that yesterday also. Today, what I want to say is that the end of the S wave, this end of the S wave is what is technically called as the J point. It is the isoelectric point. So if you join the distance between the purple point and the black point, it is called as the QRS complex. If you join the distance between the purple point and the black point, it is the QRS complex. And if I combine the whole thing together, then this entire thing that I am currently marking before you is a new parameter about which I have never ever spoken earlier, but I hope I've been able to explain to you the PJ interval. The rationale is in this condition, the PR interval becomes chota, less, and due to the delta wave, the QRS will become broader, and mathematically the shortening of PR is equal to the prolongation of RS. So the PJ interval in this condition remains normal. They will not give you a diagrammatic representation. I just wanted to show to you like what is PJ interval. So I drew this before you. The final point to be remembered is PJ is a combination of PR plus QRS complex in this patient, and because the PR is short and the Q becomes absent, RS is broad, so mathematically we find the PJ interval does not show any change. So in the MCQ, the core aspect that you need to remember are 2 points. Delta wave and PJ interval are the keywords which are to be remembered for patients of Wolff-Parkinson-White syndrome. There is a cousin brother of this also that I'll discuss called as Lown-Ganong-Levine syndrome. But at this moment, what I have realized is that this guy is having a short circuit in the heart. There is a dotted red is the intermyocyte conduction also, which causes the broad RS complex. Nadeem, as you've answered correctly. Now, I want all of you to hit the comment button. What is the treatment for this particular patient? What is the best way for management? Would you like to go in for a pacemaker? Would you like to put a pacemaker in this person? Would you like to put in a implantable cardioverter defibrillator? Or would you like to use a laser beam and destroy the abnormal pathway? Yes, we will go for RFA. Radio frequency ablation is the main treatment of this condition. I'll write this on the extreme right and on the left hand side. The main treatment of this condition is we will use radio frequency. And using the radio frequency, we will destroy the abnormal pathway, because in this guy's heart, two abnormal systems are present. Normal and abnormal both are present. You destroy the abnormal, current will go through the normal pathway. The current says, give me a rasta to go, give me a way to go. I will go by normal also, abnormal also. I destroyed the abnormal pathway. We destroyed the express highway. Current will go through the normal pathway here. This guy was born due to genetic reasons with a abnormal situation. So we will destroy the abnormal pathway, and radio frequency ablation is the best treatment for this patient. Yeah, if he is not having, financial muscle power to go in for radio frequency ablation, like he says, sir, I don't have money, I don't have insurance, I don't have Ayushman Bharat card. Like I think you're aware now, Ayushman Bharat is like free medical insurance of 5 lakhs for people more than 70 years of age. But gradually they are gonna increase it to everybody. Like in US you have a social security number and you have to pay insurance. Thankfully in India you don't have to pay medical insurance. Everybody in India, an Indian citizen, that's the beauty of Indian healthcare. In the forthcoming year that the government plans, in the forthcoming years, I wish they make money enough to do that everybody should be having a Ayushman Bharat card, and like anybody can go to hospital and get a cashless treatment. God forbid if somebody has a bike accident, somebody has a MI, at the moment somebody goes to private hospital in Mumbai or anywhere else, they ask for a lot of money. Nobody is carrying cash nowadays. No, okay, take 1 lakh rupees. Like, UPI limit is also 99K only. So people are having hardships, but ideally, like cashless medical insurance of 5 lakhs should be minimum for critical illness. Critical is like head injury, myocardial infarction, miscarriage, abortion, ruptured ectopic pregnancy, like common things. Obviously, they'll not cover joint replacement in that. They'll not cover like expensive interventions like pacemaker, but common things should be ideally. That's the vision of the government, and like that is how equitable distribution of health should be. So coming back to the agenda, what I want to say before you is that WPW is what they love to ask. There is a variant of this condition that is called as Lown-Ganong-Levine syndrome that I'll write on the subsequent slide. But mostly because the questions have focused on Wolff-Parkinson-White with respect to ECG, so this is what I have written. I will write the drugs for WPW on my next page and the LGL also on the next page for completion. But this is the ECG finding a delta and PJ interval that we need to remember. Yes, Vipin, there was a catheter ablation there. This time it is like a radio frequency ablation. The concept is still the same that we are using. Yeah, the PR short, PJ normal, then it shows a QRS broad. No, QRS are PR and QRS are normal in WPW. No, why will PR be normal? Because fast conduction हो रहा है ना. Red pathway is having a fast conduction, so PR will be short. And RS will be broad. क्यों RS क्यों broad होगा? आप देखो ना, मैंने बोला था यहाँ पे यार. I said this dotted thing that you see here is the intermyocyte conduction. This is slower than the when we were discussing BT. Also, that is when I had highlighted this, that the intermyocyte conduction is always slower than the routine conduction fiber in the patient. So the main aspect, no, we cannot interchange the processes. So intermyocyte conduction is the reason for why the RS complex is broad, but then the short PR suppose decreases by 5 points and the RS increases by 5 points, then the decrement and the increment will be equal. That's what we see mathematically. Suppose PR decreases by 5 millisecond and RS increases by 5 millisecond, PJ will not change, no? So the reason for the normal PJ in the patient is that the decrement of PR and the increment of the RS complex remains the same. But like in this particular case, it's like the core aspects that are present. Yeah, Purkinje is the fastest conducting, but here Purkinje use nahi ho raha na. You can see the Purkinje not getting used. So some information I'll be jotting down on the next slide. Let's do a comparison at this moment. The comparison will be, they will give you questions on short PR interval with prolonged PR interval. For the prolonged PR interval, you just need to remember the following statements which have been explained to you already. That is first degree heart block. So prolonged PR interval. Another condition that can be having development or prolongation of PR interval is second degree heart block, which can be written as Mobitz 1. Instead of writing the word Mobitz 1, I can write the word Wenckebach phenomenon as I explained to you yesterday. Or instead of writing the word Wenckebach, I can also write the word that this particular patient is having a intranodal conduction defect. Any of these terminologies the examiner can play with. So with respect to PR interval being prolonged, it is first degree heart block, Mobitz 1 heart block, and then he will incorporate something like hypothyroidism. In hypothyroidism, thyroid hormones are less, so sympathomimetic activity will be less. This MCQ will be a all except variety, and the fourth option in the MCQ will be Mobitz to hard block. I did a sufficient amount of hard work yesterday to explain to you that in Mobitz to hard block the problem is below the level of the AV node, so the PR interval remains normal. That I've already highlighted here. So this is a all except question that I've covered. PR interval will be prolonged in all of the following except. So both compensate each other. Yes, exactly, Malchari, you are right. Both compensate each other. PR interval remains normal in Mobitz to hard block. So it is first degree hard block, Mobitz 1 and hypothyroidism which cause a prolongation of the PR interval. I can say one more point, marathon running etc. They would be responsible for also increased vagal tone and prolonged PR interval. So this is a comparison between like short PR and the prolonged PR interval. Now I will move on to my next slide, and before I write the QRS complexes, I just want to add up a couple of general questions that came up, which is that if he says what is the drug of choice, if he says what is the drug of choice for Wolff-Parkinson-White syndrome, or if he changes it to Lown-Ganong-Levine syndrome. Lown-Ganong-Levine syndrome is a cousin brother of Wolff-Parkinson-White syndrome. Both of them, the main treatment, the drug treatment is the same. Mobitz 1 के नीचे Vancebag, man. I अब कल पढ़ा था ना हमने. Below Mobitz 1 heart block, what I've written is Vancebag phenomenon. I'll just write it again, just in case maybe the handwriting part was there. Mobitz 1, Vancebag, intranodal conduction defect, they all basically mean the same. Yes, I'm having good inputs. Whether the question says what is the drug of choice of WPW or Lown-Ganong-Levine syndrome, the answer will still remain the same. It is procainamide that can be used in a patient, or another drug that can be given orally. In emergency, we will give IV procainamide, and like on daily basis, we will go for flecainide. The treatment of choice for both of them, the treatment of choice for both of them would be answered as RFA, that is called as radio frequency ablation. The basic concept is both conditions are having an accessory pathway in the heart. And now we will talk about when do you get narrow QRS complexes versus when do you get broad QRS complexes. So if you look at the data here, for the narrow QRS complexes, for the narrow QRS tachycardia, it is a supraventricular tachycardia by the name of PSVT. The ECG of that was explained to you yesterday, abnormal single looking wave with a minimal ST depression, and the QRS is ultra narrow. This is the recording of PSVT we discussed yesterday. But then came up broad QRS tachycardia, that was VT, which was having this sinusoidal pattern with the Josephson sign. So this is VT. Then comes the aspect of delta waves, which we have already discussed, that is WPW. Do not mix up the delta waves versus the J waves or the Osborn waves, obviously because names are different, so you guys will not be missing it there. But then yeah, TP, that's another word we can be using here because of the merging of the electrical activity there. Perfectly right, Rohit. And then comes the J wave or Osborn waves. So one, I want to remind you that J point is normal. If they say what is J point, then J point is the isoelectric point which I had represented earlier also. But now what I will draw before you is the J waves or the Osborn waves, which is a very famous question of your exam, both FMJ and NEET PG. They have not given an image of that. They have not given an image of that. All they do in the paper is that they say that patient is a soldier he was buried under avalanche in the Siachen glacier, or he might mention like in New York there was an Arctic storm and somebody was buried, or somebody is in Moscow and like in the month of December, January, like the heating went off and due to some accident and then the person froze to death, hypothermia. So J waves or Osborn waves are seen in hypothermia. That's the statement to be remembered. And yes, I mean, how does it look like, that also I've tried to make here before you. What I've currently shown before you is two aspects. One is J point is normal, and then is the J waves, which is perfectly the okay part. And hypothermia is like cold temperature less than 35. We will talk about that in the thyroid topic also. But now comes the aspect of epsilon waves. For epsilon waves, I would suggest you to draw with me, especially if you're a NEET PG aspirant. You need to draw it right at the starting of the ST segment. It will look like a slight M pattern. It will look like a slightly M pattern. Okay, maybe I did not bring up the slide sufficiently. So do with me here. I hope your pen is ready, pencil is ready. Draw P, PR interval, QR. Take down the S, bring it up, and now show that deflection like a M, and then this would be the T wave present. This slight aberration that I've currently shown here at the moment before you, This slight aberration or abnormality that I currently share before you, this is what is called as epsilon wave. This is the highlight of a condition that was discussed yesterday as well as even today morning, arrhythmogenic right ventricular dysplasia, where there is a fibrofatty deposition, in the right ventricle of the patient. So I've shown the epsilon wave at the moment for ARVD. This is arrhythmogenic right ventricular dysplasia. It is a disease related to desmosomes. It is related to a gene that is called as placo. It is a defect of cell versus cell connection, like the desmosons, right? Placoglobin gene, right? The most important thing is that there is a fibrofatty. The most important phrase that I want you to pick up is fibrofatty replacement. It is the key word in the question will be fibrofatty replacement in the right ventricle of the patient. That's the main statement to be remembered. There will be history of sudden cardiac death in this particular case also. Sudden cardiac death in sibling. Multiple conditions can be having sudden cardiac death in the sibling. Arrhythmogenic right ventricular dysplasia is the same. So when this young guy had come to you with complaints of palpitations, he told you that his elder brother had died suddenly while dancing at a marriage party, or his brother was playing football and he died suddenly, and like the team tried reviving but nothing worked. So that is ARVD. And like the young boy is saying like not exactly, not all cases are associated with Naxos syndrome. Not all cases would be related to Naxos syndrome. So this looks like this would be not always associated with Naxos. That woolly hair thing may not be present in this case in all the scenarios. So the aspect to be remembered here would be that you would be telling this guy that we have to use a ICD, implantable cardioverter defibrillator, by which we will be able to manage this patient. And Brugada will be looking totally different. So I will draw the Brugada syndrome before you also. That will come in ST segment changes that we're going to discuss in a subsequent slide. But at this moment, the key word is fibrofatty deposition in the wall of the right ventricle. For epsilon waves, two must know pattern is delta wave and epsilon wave, as I've explained to you. Now we will talk about ST segment changes. So till now I've taught you P wave changes, PR interval, Q wave, and now QRS complex. Like what have we covered? We have covered P abnormalities, PR interval abnormalities, short and broad, Q wave abnormalities. Then is I have described the QRS complex abnormalities. So these are the abnormalities that I have discussed till now in front of you. And now what I will focus is I will be focusing on the ST segment changes in a patient. So let's look at the ST segment changes now. Elevation versus depression. First, we will fill up the findings of depression because they're shorter and lesser. The point to be remembered is angina of all varieties. Only one angina has ST elevation that I will write subsequently, but otherwise the standard anginas that they will always give you, like he says person is having chest pain on exercise, that is when you call it chronic stable angina. If person is having chest pain at rest, then we call it unstable angina. The point is whether it is stable angina or unstable angina, by default there will always be a ST segment depression in angina. The problem in this patient is that in angina the coronary blood flow will be reduced because these patients can be having double vessel disease, triple vessel disease, atherosclerotic narrowing is there. So due to the atherosclerotic narrowing in the patient, the blood supply to heart is lesser, contributing to ST segment depression in this patient. Then ST depression is also seen in non-ST elevation MI. That is what we drew earlier, that non-ST elevation MI that was discussed with a T wave inversion. Though I showed ST depression even in posterior MI, but I hope you remember it was having a upright T wave. But at the moment, like angina, non-ST elevation MI are sorted. The point number 3 to be remembered here would be hypokalemia. Point number 3 to be remembered here would be hypokalemia. Yeah, Wellen syndrome. Yep. Then is hypokalemia. That hypokalemia, the arrow is going down, so ST depression is present. And the fourth entry is, that is the neglected part, digoxin. Mark my words there, I did not say the word digoxin toxicity. For toxicity, it is a arrhythmia by the name of ventricular bigeminy. I did not use the word toxicity. I just said simply digoxin administration is being done. So for these patients, when digoxin will be given, it will be a ST depression that would be present. Digoxin is lanoxin. Digoxin is a terminology that can be given. So 4 entries for ST segment depression. Now I will tell you ST segment elevation. For ST segment elevation, the mnemonic is elevation only. So alphabet E, we'll take them up one by one. The alphabet E is for like electrolytes. And the electrolyte that we will talk about here is hyperkalemia. The arrow is going up, so there would be a ST segment elevation that is present. Yeah, hockey stick sign. Alphabet L would be for left bundle branch block. Then alphabet E. When I got my ECG done first time, I was for a shock because my ECG was showing ST elevation at 25 years of age. Why? Because there is a physiological ST segment elevation also that can occur in some people. That is early repolarization variant. Very common finding of ST segment elevation. Lots of time false diagnosis of MI is made in people because of this finding. But how do you differentiate that? That you learn in your post graduation. But yeah, early repolarization variant is like where some people can have physiological ST elevation. My ECG shows a ST elevation, though I don't have anything, right? So crazy. Okay. Then is we are focusing on the word elevation at the moment. So the next word to be remembered is VNA. VNA is a structural damage to the left ventricle that is called as ventricular aneurysm. This is a complication of full thickness MI where stroke can be occurring. Then alphabet T is for trauma. The trauma can be blunt trauma to the chest. I is one of the most important thing discussed all through this lecture, that is ischemia, that is myocardial infarction. And then O and N have been deliberately introduced in the MCQ just to complete the mnemonic. That O alphabet is because of the Osborn wave component coming up. That is just to incorporate that it is like very close to the ST segment. But yeah, it can also cause a false ST segment elevation present as a false diagnosis, but can be easily differentiated because hypothermia will be a cause. Say that again, which one having convex or concave? MI is always convex. MI is always convex. In all of them, it would be standard like the convexity. Concave is what will coming up very soon. N is for non-occlusive vasospasm. Yes, Osborn wave in hypothermia, great. And N is for non-occlusive. N is for non-occlusive vasospasm. That is what is called as Prinzmetal angina. It is for this word I went into such a long story that all anginas by default will be having a ST depression, but the only angina which has a ST elevation is called as Prinzmetal angina. I'll repeat the statement once again. All anginas by default have a ST depression except Prinzmetal angina that has a ST elevation. It will look like MI, but you can differentiate on the basis of biomarkers because angina patient will not have necrosis, so biomarker will be normal in a patient. So therefore, this angina, as Pranav mentioned, is also called as variant angina. Why we call it variant is because only angina having ST segment elevation. Now, most of the time people get tired by the time we reach the end, and that is where the question is hiding. Most of the time, by the time we reach the bottom of this, people tend to get tired or fatigued. So it is A and B, which is the main things which are to be remembered. The main things to be remembered would be one A and B, that is left ventricular aneurysm. A and B. The A to be remembered is acute pericarditis. That was the last time's FMG exam question that I discussed, post viral pericarditis in a patient. And alphabet B was what you guys were prompting me earlier, that is Brugada syndrome, which is a sodium channel defect. In Brugada syndrome, the ECG would look like this. Now look at the subtle difference that I'll be making. Like if you check out this ECG, let me do this again because I think it was not very much visible. So let's do it. P, Q, R, make it with me. This is S. When it's going up, it should level off here at ST. It's still going up, still going up, still going up, and then show a T wave inversion also like this. This is what is called as a Cove pattern of ST segment elevation. Yes, in some of these patients, you might be having slightly different. So do with me again. R, S, then bring it up and show like a saddleback. It can be either of the two. There are different varieties of Brugada 1, 2, but the minimum I expect you to remember is this word. Cove pattern of ST segment elevation. This is the elevation, or instead of saying the Cove pattern, the word to be remembered would be saddleback pattern. Both of these terminologies that I mentioned at the moment, the Cove pattern or the saddleback pattern, would be with respect to the both. There are total 3 types. Yeah, they can cause sudden cardiac death. On the next slide, that will come up. But yep, that AB component that I currently highlighted is the core 2 things that I want you to remember. इसको बना लेना यार एक बार अपने हाथ से ना, तो थोड़ा सा ओरिएंटेशन रिलेटिवली बेटर हो जाता है. And once you get this difference between ST segment changes of ST elevation and ST depression, we will just finish off by lastly mentioning T wave abnormalities of inversion, Toll-Tented T wave and hyperacute T waves. I will draw the T wave inversion here also. has been drawn multiple times, but for one last time, T wave inversion has been shown. Alone T wave inversion. Tall dented T waves. So I've shown like a very tall dented T wave like this. And then I've shown a T wave again, but this time I've not shown it very tall. I've rather shown it more broader. Like this one is pointed like the tip of the pen that I'm using. Pointed like the tip of the pen that I'm using. The other one is relatively much more broader, I would say. So T wave inversion, where we have read it, it is non-ST elevation MI. It would be present in anginas of all varieties, including unstable angina. So any type of angina, learning point is angina always has ST depression and T wave inversion. नीचे नीचे angina में नीचे नीचे भगवान जी बुलाएंगे ऊपर, that is God will call to him ST elevation and myocardial infarction. So angina and then is hypokalemia. So the findings that I've said for ST depression are valid even for T wave inversion. These findings were told to you even for the ST segment depression. The same findings are valid for T wave inversion only. Tall dented T waves, nobody I think ever will forget, because this is very classical for hyperkalemia. Tall dented T waves and then the heart can stop and cardiac arrest, and hyperacute T waves has been discussed for myocardial infarction. So what I've done in the discussion is, what we have to see in the question is the aberrations or the variations in the T waves that I mentioned at the moment. So pretty straightforward data as far as the interpretations are concerned. Can you comment on the drug of choice for hyperkalemia, please? We will discuss it separately, but quick answers, please. Drug of choice for hyperkalemia. Drug of choice for hyperkalemia, please. Yeah, ST, ST elevation MI also, all types of MI. And ST elevation MI, like I described in ECG, where there was no ST depression. So that's what I wanted to highlight again, T wave inversion. Yeah, calcium gluconate. The drug of choice for hyperkalemia is rule of 10, 10 ml or 10% calcium gluconate that would be given intravenously to the patient. Yeah, insulin drip is not to be answered as the drug of choice. The drug of choice is calcium gluconate, and insulin drip would be given later to decrease, I can say the insulin drip would be given later to lower the potassium values in the patient. So these are the abnormalities in the ECG that I have mentioned. Let's just compare. Insulin with salbutamol is also given. Yeah, we'll discuss that separately in the treatment algorithm for the patient. Yes. So next, our aspects to be remembered is, yeah, calcium gluconate is a stabilizer of the membrane. चलो अब आपने बोला ही तो let me know the, since you guys have mentioned it only, let me know what is the novel potassium binders which are given nowadays. Because nowadays they will not ask you calcium gluconate and insulin drip and salbutamol nebulization. No? Dialysis is for refractory hyperkalemia. Don't answer dialysis as the treatment of hyperkalemia. It is for refractory hyperkalemia. Yes. Yes. It is. We will use Patiromer. Yes. Patiromer. Is Patiromer, which will be used. Novel potassium binding agents are like Patiromer can be used. Sodium zirconate can be used. Sodium polystyrene sulfonate can be used in a patient. These are novel potassium binders that would be used in the patient. Patiromer, sodium zirconate, sodium polystyrene. SPS I have written in short only. That is sodium polystyrene sulfonate. So at the moment, it is the abnormalities of the waves that I have currently highlighted before you. And now we will focus on like the differences between Brugada and ARVD. This would be the last slide in the cardiovascular system that we'll be discussing. Then I'll summarize the Dukes and we'll move on. So pathophysiology component Brugada syndrome is a channel defect. There is a defective depolarization in some part of the heart. It is a SCN5A defect, sodium channel defect. The problem in this condition is that some areas there is a defective depolarization, some areas there is a normal depolarization. So there is a voltage gradient created. You see, whole of the heart should depolarize simultaneously. If some heart will depolarize, some will not. There would be a voltage gradient happening, which will result in an electronic gradient, and that electronic gradient will result in development of re-entrant arrhythmias or like maybe ventricular tachycardia in the patient. Yeah, chromosome 3. Very good. It's chromosome 3 defect. Then is defective depolarization that would be happening. SCN4A is yeah, it can be either of the two, hypo and hyperkalemic periodic paralysis. But let's look at the features. This is the most common cause of sudden cardiac death. This is the most common cause of sudden cardiac death in Southeast Asian males. This will be a young guy, he's sleeping. He's not even like, dancing in a marriage party. The guy is sleeping and he dies in his sleep. Family members are saying that maybe snake bit him. Like in the village, they will say snake bit him or somebody had poisoned his food. So like the exact cause is not known most of the time, and this goes without a diagnosis till his brother came up for follow-up. The manifestations would be agonal breathing and syncopal episode. This would most of the time be like early morning. Like normally this is a rural family and they wake up at 5 a.m. in morning because they have to fill water and they have to like give food to the cows in the house. They have to give food to the cattle in the house. So like farmers etc. they wake up early. So this farmer woke up early and he found his teenage son having agonal breathing. एगनल वुड मीन टर्मिनल ब्रीदिंग, जैसे जिसका किसी का डेथ होने वाला है तो कह रहे सर मेरा जो लड़का था बड़ा लड़का था उसको एगनल ब्रीदिंग हो रहा था एंड ही वाज ट्राइंग टू वेक हिम अप, सो मे बी ही ओपनड हिज आईज, ही ट्राइड टू गेट अप एंड देन ही फेल डाउन एंड ही सेज ही नेवर स्पोक अगेन. So agonal breathing and syncope is the usual presentation that you will be getting in this condition, and the patient will die. Unfortunately, no diagnosis will be made. They will think somebody had poisoned him, maybe a snake had bit him. Most of the time, the diagnosis will go unknown till his younger brother comes to you and says, boss, my brother had died like this suddenly in his sleep and I want to get your evaluation. And that is when you will do the ECG, and the ECG in this patient will be showing what I was drawing before you earlier, that is a ST elevation with a cove pattern, because this is a comparison table, so I'll mention the more common pattern, that is a cove pattern in this patient, and I will be telling this guy's brother that you need to get a ICD deployed. Implantable cardioverter defibrillator is the management for patients of Brugada syndrome. In these patients, family history of sudden cardiac death would still be given. Most of the time patient will die. It is the family member who comes for a checkup where usually the diagnosis will be made, and this ST elevation will not be present in all the leads. It is present usually between V1 to V3. So that's the additional point I want to bring to your attention, that the depolarization vector is defective mainly in the anterior leads of the heart. It is not any lead, it is the anterior leads where the defect is found. When it comes to arrhythmogenic, yeah, we will do ABC to hota yaar, we'll do this. Then is arrhythmogenic right ventricular dysplasia, where the problem is with respect to the desmosomes. It is a desmosome versus desmosome defect that is occurring, and there would be fibrofatty deposition also occurring in the heart, as I explained. Palpitations and recurrent syncopal episodes will occur in this patient also, and the question will again mention that there was a family history of sudden cardiac death in his brother or sister. When you will evaluate the ECG again in the anterior leads, you will be able to notice the epsilon waves. And the treatment in this patient will also be, yeah, very much possible. Never see, the symptoms were there, nobody recognized them. It is just that symptoms were there, nobody recognized them. Most of the time what happens is symptoms were there, but like young people, they don't complain much. Na? Young people are supposed to be tough, and like family members will also say, अरे कुछ नहीं होता, उठ के exercise कर. Like the young boy is saying, कि मम्मा मेरे को ना weakness हो रहा है. So she'll scold him. She'll say, okay, I will complain to your papa. And the papa comes in the room and he scolds him. अरे तू लेटा रहता सारा दिन, चल exercise कर. So lots of time, like you will notice that those symptoms are very much there, but they don't realize that there was something wrong, and then the person will die. So what are the indications for a implantable cardioverter defibrillator? The mnemonic is ABC. In ABC, A would stand for arrhythmogenic right ventricular dysplasia, B will stand for Brugada syndrome, and C will stand for cardiomyopathies of all variety, because any cardiomyopathy can cause structural damage and therefore the arrhythmias could be developing in a patient. To see you got me or not, please tell me what is the most common arrhythmia that is seen in patients of hypertrophic cardiomyopathy. Question for everybody, hit the comment button, sir. Sir, Naxos हमेशा नहीं होता है. You may not have Naxos presentation in ARVD all the time. Like there was no Naxos in that player. Na 2021 में there was this European player. I again forgot his name. 2021 in a Euro Cup match, the guy was playing football. He is a professional footballer. Aparna. He collapsed on the pitch in 2021. Ericsson शायद नाम है. Right? He is from Denmark. If I pick up, guys, can you help me? I think Ericsson. Search करना जरा. 2021 ARVD. I think the player's name is Ericsson. And he collapsed on the football pitch. The team did a CPR. He recovered after that. So he was not having any Naxos syndrome. Okay. So Ericsson here, fine. Now the point is, if he says what is the most common arrhythmia that is found in patients of hypertrophic cardiomyopathy, then it is not hypertrophic cardiomyopathy is not ventricular fibrillation, guys. The most common arrhythmia in hypertrophic cardiomyopathy, dilated cardiomyopathy, restrictive cardiomyopathy, in all types of arrhythmia, the commonest type of arrhythmia is atrial fibrillation. This is a common mistake that students make at the end. If I was saying he's playing football and he's dying, If I said he's playing football and he's dying, and you answer ventricular fibrillation, I agree to it. If I say to you that the guy was playing football and he dies suddenly, and then you say, sir, that he's ventricular fibrillation, I agree to that. But overall, the most common arrhythmia in hypertrophic cardiomyopathy, Christian Eriksen. ठीक है. तो मोस्ट कॉमन एरिथमिया इन हाइपरट्रॉफिक कार्डियोमायोपैथी, बिकॉज 2021 में लॉकडाउन था ना यार, तो करना क्या था, मैच फुटबॉल मैच देखते थे और क्या करना है. So most common arrhythmia in cardiomyopathy patients is atrial fibrillation. This is one of the common mistakes that would be done. Question for everybody: what is the most common arrhythmia in hypertension patient? What is overall the most common arrhythmia in hypertension patient? These are kind of questions that should never ever go wrong. What is the commonest arrhythmia that is seen in a patient of hypertension? The answer is still atrial fibrillation. What is the commonest arrhythmia in old person? No risk factors, atrial fibrillation. What is the commonest arrhythmia in patients of Graves' disease? Still atrial fibrillation. This is a chronic sustained arrhythmia. Atrial fibrillation is a chronic sustained arrhythmia. Here patient will not immediately die because of arrhythmia. It will rather cause clots, and these clots will go in the brain, and that will cause stroke in a patient. So like in the later part, maybe tomorrow or next week when I interact with you, when I'll be teaching you stroke, I'll be again discussing atrial fibrillation. If you listen to my earlier videos, again I've been very very vocal about it, that all neurology cases are actually cardiac cases. Majority of like emergency, neuro emergency cases are all cardiac patients. हाइपरटेंसिव, एट्रियल फिब्रिलेशन, दवाई नहीं खाते, बाबा रामदेव की दवाई खाते हैं, आप क्या मेरा मजाक उड़ाते हैं और फिर आईसीयू में भर्ती हो जाते हैं. If I was saying playing football, basketball, no problems. Hypertrophic cardiomyopathy, sustained tachyarrhythmia that is occurring in a patient. अगर वो आपकी हेल्प करना चाहे ना, यहाँ पे तो वर्ड लिख देगा. Most common sustained tachyarrhythmia. This word may or may not be written. Don't be with the bharosa of this word that sir, if it will be written sustained only then we will answer it. No, because this is a common one. So general data is to be remembered. The most common sustained arrhythmia in cardiomyopathy patients is atrial fibrillation in the patient. Okay, guys. So at this moment, I just want to draw your attention to this particular ECG. This is having that Cove pattern of ST segment elevation, especially in like lead number V1, V2 and thoda sa V3 also, but I can say like yeah, V1, V2, V3, three areas are showing that Cove pattern that I will mark here before you. The Cove pattern of ST segment elevation. This is that T wave inversion that is happening simultaneously, is what I've highlighted at the moment. That's the Cove pattern of ST segment elevation. Great, Brugada Cove pattern. So especially if you are a INISET aspirant, guys, Brugada, that is like bread and butter for you, standard routine information. And now what I will do is I will invest about few minutes into topic of infective endocarditis. Bacteria we had discussed. I think nobody has issues with the then we will talk about infective endocarditis, the organisms you know. I will focus on what is the update. I think minor also is not a problem, because here you just need to pick up words like oscillatory nodes, Janeway lesions, fever, etc. So it will never cause a problem. It is the major criteria that I will focus on. The major criteria which are to be remembered by the name of MIS, MIS. Microbiological criteria, imaging criteria, surgical criteria. I will go in reverse direction. Everybody on page with me. MIS is the word that we are studying. That is microbiological, imaging and surgical. First new thing has been added, surgical criteria, that was never a part of the discussion. Surgical criteria simply means that surgery is occurring and the cardiothoracic surgeon has identified vegetation. So cardiothoracic surgeon is literally like God, na sir. Somebody operating on heart and then operating on a beating heart. That too putting sutures in the beating heart on blood vessels, coronary artery bypass grafting. Those people are God only. The thing is, nowadays young guys don't want to be cardiothoracic vascular surgeons, so CTVS seats are going vacant. Can you beat that? Most of the cardiothoracic vascular surgery, because it has a very long incubation curve, it is the seats go vacant. I'll say like this: when you were in first year, if somebody would have asked you, "Tum kis cheez ke doctor banoge?" you would have said cardio doctor or neuro doctor, right? The cardio doctor is the CTVS guy, and neuro is obviously the neurosurgeon. Nowadays, young people, they take up surgery, but they don't. Everybody wants cancer surgery, because cancer is very common in India and patient will have to pay also. Nobody wants to do cardiothoracic vascular surgery, neurosurgery, because seats are going vacant, sir. I mean, government hospitals, private setups, it is like, yep. चलो we'll talk about other pathies also यार. अभी देखो, अभी let's focus on the job at hand, right? So I mean, otherwise we'll get distracted. So first is the god has picked up vegetation. CTVS guy, the real big shot of the hospital. Two big shots I can say of medical circle is one, you know, Devi Shetty in south, and here in Medanta nearby, that is Naresh Trehan sir, right? I mean, they are the ones who made Indians realize what is coronary artery bypass grafting and how it is critically important. Just to share with you the importance of just to share you the importance of cardiothoracic vascular surgery, I want to say that one of our former prime ministers, that is Manmohan Singh sir, he lived up to 93 years of age. Normally in people in India die by 68 70 years of age, max 75 Indians die. Manmohan Singh sir lived up to the age of 93 because he underwent coronary artery bypass grafting. Coronary artery bypass grafting adds more than a decade to the life of a person. Look at the magic of medical science. You add 10 years by one surgery to the lifespan of a person. People die at like 60s, and he lived up to a good age of 93. Obviously, good genetics will also be there, but then at the same time, like, you know, what I'm saying is CTVS guy has picked up the vegetations. Then is imaging criteria. In imaging, earlier it was all about vegetations on echocardiography. Now he says do a PET CT, do a cardiac CT, you will be able to scan. Yeah, obviously he was very chill, that is also fine, but then obviously medical science played a role. So cardiac CT is the new thing, FDG PET is the new thing, and now we come to the bacteria. Blood culture is overrated. The rule is 3 to 1. 3 to 1 means 6 tubes, 3 sets or 2 bottles each. 1 hour gap पे 8 a.m., 9 a.m., 10 a.m. You puncture the patient at different areas. You want to demonstrate dissemination of infection. Dissemination of infection. So you take it one sample from the right cubital fossa, left cubital fossa, dorsum of hand at different times. Patient is crying, खून पी गए मेरा, 60 ml खून ले गए. Now he says no point of puncturing the patient again and again at different sites. You can manage with, instead of 6 tubes, 4 tubes, only 2 sets or 2 bottles, aerobic, anaerobic, aerobic, anaerobic taken at the same time in a patient, and you will be able to effectively identify the bacteriological analysis. But this he has put a rider, typical organisms. Typical organism would mean something like Staph aureus or Streptococcus. Unfortunately, if he is talking about atypical organism, then we should rely on technology. Technology is like the infection came from the cat in the house. Infection came from the lamb in the house, cattle in the house, cow in the house, Coxiella burnetii. Then use PCR or use IFA evaluation. So apart from blood culture in the patient, yeah, Raman, I agree to what you are saying. It comes sterile. That is why PCR. Na? PCR, so even if you have taken antibiotics, it will still not get affected. Na? And antibodies IFA would still be positive. So that is the same thing. In the update, same or different, same site, man, same site, you know. Same time means one site only. Put a scalp vein, clean the skin properly, spirit and betadine, and then you can take it at the same time. So you don't need different punctures. Out of these two sets, 2 out of 2. See, if it is 1 out of 2 positive, then it becomes a minor criteria. Na? 2 sets you have taken. Both sets positive with Staph aureus. So that is major criteria. If suppose 1 out of 2 is positive, it becomes a minor criteria. Similarly, out of 3, 2 should be positive. Out of 3, 2 should be positive, 2 out of 2 should be positive. If only 1 is positive, then it becomes a microbiological, then it becomes a minor criteria for diagnosis. Yes. So Sairaj, I've answered your query, and this is like the diagnostic criteria for infective endocarditis that I mentioned. Obviously, like IV antibiotics would be used here. Broad spectrum treatment is given for these patients, and yeah, good that I raised that point, so it occurred to me. Which of the following conditions will be having the highest chances of development of infective endocarditis? Quick comments here. Highest incidence of infective endocarditis will be seen with the rationale is infective endocarditis is directly related to pressure gradient. Which condition? Sir, will not be doing bundle branch block. That has never been asked in the exam. That is present in main videos for the completion sake. Will not discuss bundle branch block. Highest incidence of infective endocarditis is with respect to which of the following conditions? Yes, guys. The highest incidence of infective endocarditis is with mitral regurgitation. Mitral valve in our body operates at the highest pressure gradient. It is LV minus LA. Aortic regurgitation will operate at pressure between aorta and the left ventricle. That is 120 only. Aortic regurgitation nahi. Mitral regurgitation has the highest incidence of infective endocarditis. The ulta MCQ of this is atrial septal defect. Atrial septal defect will operate on the least incidence of infective endocarditis. ASD is atrial septal defect. It will operate at the least incidence of infective endocarditis because the pressure difference in the patient is very, very less. So I want to add another statement, that is infective endocarditis is directly proportional. Infective endocarditis is directly proportional to infective endocarditis is directly proportional to the severity of the mathematical gradient present in the heart. So these are a couple of aspects from cardiovascular system that I have currently discussed here in front of you. So what we will do next is, one option is I can do seizures with you. I think seizures is a topic, we can do it. And then I'll not discuss stroke today because that will become too much to remember the stroke aspects and all those technical issues. But I think can we do aortic dissection will come up with stroke only, na? Aortic dissection, Yashika, will come up with the stroke component, right? I will speak about it subsequently. So endo उसके बाद कर लेंगे, like stroke if you are okay, right? I think stroke is a easy topic, we can easily manage that. Seizures and epilepsy. DORAs, na, we just have to remember the drug of choice there, and then we'll go to easier stuff like, towards the later part of the day, we can do infective endocarditis and everything. And aortic dissection is a combo of cardiac and neurological because the tear will cause damage in the brain also. Because when the tear will up, then it goes to carotid arteries, goes to brain. So that will be the only MCQ which will be where cardiac features and neuro features will be given together. So Dr. Yashika only, I think the name was. Remember the question said chest pain with Horner syndrome. Got my point now? Chest pain with Horner. Chest pain is cardiac, Horner is neuro. So the only time when you have junction of cardiac and neuro is the aortic dissection component. So I'll handle it when the time comes. Okay, so abhi kar lete. हाँ जी, Yashika beta. Okay, so I hope beta I answered your query, and now we will be doing no beta, no Karthik. Man, Pancoast will not have that chest pain. No, Pancoast will have Horner syndrome and wasting of the muscles. Okay, anyway, let's not get distracted. When the time comes, my job, I'll do it. So let's focus on a couple of important questions here. Like you have to tell me, this will be revision of your drug zone. So, okay. You are turning to page number 48. What is the most common cause of acquired epilepsy in India? I will be answering these questions from you guys. What is the most common cause of acquired epilepsy in India? Okay, very good, very good. Rajesh was the first one to comment. More people, please. Yep. The most common cause of acquired epilepsy in India is neurocysticercosis, the calcification in the brain. Even if you kill the worms, as we will be discussing subsequently, there is a development of intracranial calcification, and this calcification will work like a epileptogenic focus in the patient. And before we go forwards, I also no doctor, that's perfectly fine. You need to go through the pages that I've given, and yeah, aortic dissection, and you are good to go. Okay. Look at this calcification. Everybody, please focus on this calcification that you can see in the lateral horn, temporal horn of the lateral ventricle. Can you see that white dot, lateral horn of the temporal horn, of the lateral ventricle? So what is that calcification, guys? You see it in the old people also. Like this is obviously not neurocysticercosis, so they put an arrow at this calcification, and this is at the temporal horn of the lateral ventricle. So what is this calcification, especially seen in geriatric age group? The image which is shown here is a choroid. This is like choroid plexus which is present here. So in old age, what happens is that there can be calcification in the choroid plexus. So in the lateral horn of the temporal ventricle, you can see a white dot that is like a choroid plexus calcification. And in the NEET PG, in FMG exam, they put an arrow at this area, third ventricle area. So if you are an FMG aspirant, please let me know that white dot, what is showing, what is it? Yes, Ridhima, you are spot on. Calcification of the choroid plexus, you are spot on. Yes, guys, what is that white dot in the third ventricle? I think I've given sufficient lag time, guys. You should have like killed the answer to the question by this particular time. Pituitary, okay, very close, very close, very close. Hanji, pineal gland which produces melatonin. Melatonin is for the circadian rhythm. This is pineal gland. The pineal gland calcification is present. So sometimes they just ask you very simple things, like they'll put up a arrow at a calcification area, and obviously it is not neurocysticercosis, because neurocysticercosis will mainly involve the brain parenchyma, as we will see subsequently. This is pineal gland beta, pineal gland at the third ventricle, and I will be showing you calcification of the starry sky in the lateral part. Obviously, this image is the unmistakable image of white, which is obviously blood, that is the star of death. This is again, I would say, a very hot favorite question of our examiners. They always mention the star of death. I think everybody knows, so I don't need to even ask you that the star of death is a finding of subarachnoid hemorrhage. So these are two miscellaneous facts which I just wanted to say before we move forwards. Like these are like you look at it and you know the answer that star of death is a feature of subarachnoid hemorrhage, and obviously more technicals will be added subsequently. Rigidity, I will teach you when the time comes at RISE ICT. Yeah, worst headache of my life. Now, what is the normal EEG finding with eyes open and with eyes closed? Like at the moment your eyes are open, so the rhythm that will be present at this moment will be called as a beta rhythm. But if I say, okay, please close your eyes, then all the external stimulus of the world is gone, all the problems of the world are gone, then it will be alpha rhythm. Like you do yoga, then you achieve alpha state, that is eyes closed, otherwise it is a beta wave. As far as the beta wave is concerned, the discharge frequency will be 13 to 30 hertz. 13 to 30 hertz. So in 1 second, we will be able to count, like, I can say more number of waves, and they will be also smaller in amplitude. So what I've done at the moment is just symbolically try to make about 13 to 30 waves in that period of 1 second. This is like 1 second period, 30 waves present. But if I compare this for 1 second interval with alpha waves, then I have made the waves bigger also, and you can see frequency is also lesser. So the alpha waves that would be coming up in any person would be relatively slower. The discharge frequency in this would be 8 to 13 hertz. So 13 is the overlapping there. 13 is the overlapping there between the two numbers. But then 8 to 13 and 13 to 30 is the frequency that is present. And now is a question for NEET PG aspirants. Everybody who's a NEET PG aspirant, attention please. Tell me this condition where you get less than 3 hertz spike and slow wave pattern and multiple seizure types. There are two informations which are given in the question. One is it is less than 3 hertz spike and slow wave pattern, and second is multiple seizure types. I will ask FMG students also. First option, this is for NEET PG aspirants. All of you who are NEET PG aspirants, ANICET aspirants, hit the comment button. Less than 3 hertz spike and slow wave pattern and multiple seizure types would be seen with. I'm waiting for answers for people to comment quickly. Waiting for another 10-15 seconds. Okay, very good, very good, very good. Yashika, you got it spot on. You can mention the name also, beta. Yes, yes, Anjali. Okay, Maria, beta, you are like थोड़ा सा गलत there. Dr. Future अभी थोड़ा सा गलत जा रहा है. Vipin, you going wrong. Okay, okay. I'll wait for another 5 seconds. Think. Less than 3 hertz. Equal to 3 hertz नहीं है. Less than 3 hertz spike and slow wave pattern and multiple seizures type that are present. This would be seen in what is called as where combinations are present. जैसे patient सुबह उठेगा, when he will wake up in the morning, GTCS. In the afternoon, there can be atypical absence seizure, then there can be myoclonic seizure in a patient. Guys, this is Lennox-Gastaut syndrome. What you have to pick up here is the word less than 3, not equal to 3. In the FMG exam, he kept it simple. Child having vacant staring spells with 3 hertz per spike and slow wave pattern, where he said vacant staring spells and 3 hertz spike and slow wave pattern, that is simple absence seizure, so no problem. In NEET PG, he made it थोड़ा सा tricky by mentioning the word less than 3 hertz. जिन्होंने मिस किया होता absence भी मार्क करके आया सर absence seizure था. And guy said no sir, question ही यही नहीं था. It was less than 3 hertz spike and slow wave pattern and multiple seizures type. That is what I am saying. NEET PG question ज़्यादा खतरनाक होते हैं, one liner होते हैं, उसमें ना एक भी word sure, right? The word miss hua and whole thing kaboom, right? In that 3-4 liner question, you still have a scope. यहाँ से नहीं निकला, किसी और point से पकड़ लिया. But in the one liner, you have to be very, very focused. So here, I will teach you more about it. But at the moment, write the name, which a lot of doctors have identified very correctly. This is Lennox-Gastaut syndrome. Now comes two EEGs, which I will teach you what are the type of. अभी मैं verbally बोला था GTCS, atypical absence myoclonic. I'll teach you also कैसे याद करना है. But at this moment, the point to be remembered is now is those very classical questions, which is both combo of FMG and NEET 1 that they've asked. Like they will mention, they will say child is having poor scholastic performance. To waste your time, he will say the child is having poor scholastic performance. And then he will say that this child is having vacant staring spells. So the question can easily be solved on the combination of poor scholastic performance being poor and vacant staring spells. The EEG of the patient will be showing presence of 3 every 1 second, 3 abnormal waves present every 1 second. So this is like a piece of cake, 3 per second spike and slow wave, and superiorly you can see it was less than 3. That's why I was asking you to be careful. So here nobody will have an issue. This is what is going to call as absent seizure, which is also called as petit mal epilepsy. With age, the severity of this disease will become less severe. With age, the severity of this disease will become relatively less severe. Which drug is contraindicated in patients of absent seizure? Which drug can worsen the absent seizure? Which drug can worsen absent seizure? One of the common anti-epileptic drugs which are available in government supply and is given to epileptic patient is dilantin, that is phenytoin. Phenytoin and carbamazepine should never be given in these patients. They can actually worsen. So this was a pharmacology question that was asked in your exam, that phenytoin and the question was not what is the drug of choice. That is easy. That is super easy. You will obviously answer drug of choice for management of absence seizure is ethosuximide. If it is older patient, we can use valproate or we can use lamotrigine also. The question was ulta, that which of the following anti-epileptic drugs can worsen. This was FMG exam question only. Which can worsen episodes of absence seizure? It is phenytoin and carbamazepine that can cause worsening of seizures in the patient. Question open to everybody. Tell me the biggest side effect of carbamazepine. One from the perspective of electrolyte, second from the perspective of white blood cells. सर वो जो चैनल्स होते हैं ना, जो बेसिकली फेनिटोइन जो होता है, दैट बेसिकली इज अ सोडियम चैनल ब्लॉकर. So it facilitates the unopposed electrical activity of the neurons which are causing the focal seizures in a patient. The question is why. उसका why का reason ये है कि phenytoin is a sodium channel blocker. So sodium channel को जब block करते हैं तो क्या होता है कि sodium channels की जो activity होती है that counterbalances the T type calcium channels activity. Absence seizure is caused by T type calcium channel activity, and the activity of T type calcium channels is kept in check by the sodium channels. If you block the sodium channels, the activity of the T-type calcium channels becomes unopposed, and that is why the seizures tend to worsen. So I hope bache, that answer is clear there. Yes, Raman was the first one to comment regarding what is the problem. Carbamazepine is always asked in your exam for SIADH, that will result in dilutional hyponatremia, and you also do TLC monitoring in this patient because there is a risk of agranulocytosis. So these are again two miscellaneous. You know why I'm discussing this? Pharmacology. This gives me an opportunity to touch on the pharma aspects because see, you have all read pharmacology, but now I'm telling you from the clinical perspective, कहाँ पे use करना है, कहाँ पे use नहीं करना है, what is the common side effects that are present, and okay, so it's clear, right? It's just a balance, sodium and T-type calcium channel activity balance, एक को बंद कर दिया, दूसरे की activity unopposed, so the seizures will worsen in the patient. Okay guys, moving to the right hand side. A EEG which looks like earthquake आ रहा है, पूरा क्रेजी हो गया सीस्मोग्राफ के जैसे. दिस मैनिफेस्टेशन इज व्हाट इज कॉल्ड एज हिप्सरिथमिया. व्हेन यू रीड इट फॉर द फर्स्ट टाइम इट लुक्स लाइक समथिंग फ्रॉम द पर्सपेक्टिव ऑफ कार्डियोलॉजी, बट इट इज नॉट कार्डियोलॉजी. द वर्ड इज हिप्सरिथमिया. व्हेन यू रीड इट द फर्स्ट टाइम the impression that would be, yes, when you read it the first time, the impression in mind of any young medical student will be, must be a cardiac problem. No, but it is not a cardiac problem. It is a gross chaotic activity which is present in a patient. So yes, this is a manifestation that can be seen in those patients who are having this neurocutaneous marker. You can see this white patch present here. Ash leaf macules can be seen in the patient. These ash leaf macules can be seen. Considering that this is associated with neurocutaneous disorder ash leaf macules, between ACTH and vigabatrin, if this is the image based question that is given to you, that patient has hypsarrhythmia and ash leaf macules are present, and he says what is the drug that will be used for management of this patient, then beta, this is not neurofibromatosis. Beta, neurofibromatosis will be brown. दैट इज कैफेयुलेट मैक्यूल्स। अब देखो इंडियन पेशेंट है, डार्क स्किन है, डार्क स्किन के ऊपर में वाइट वाइट लीजन्स प्रेजेंट है, सो ही विल गिव यू द सिचुएशन से सिलेक्ट द राइट ड्रग फॉर द पेशेंट, देन डोंट आंसर ACTH. Answer is vigabatrin if it is associated with tuberous sclerosis. If I did not give this photo of Ashley McHughes, if I did not give you this photo of Ashley McHughes, then it would never had caused any problem. Then the answer would have ACTH only. But specifically, if he says the word tuberous sclerosis association, then it is Ashley McHughes. Exactly. Kushagra, you answered it very rightly. ACTH is for West syndrome in a patient. If the question simply says that will come on the next slide, West syndrome, then your answer is ACTH. That's the only scenario where hormonal treatment has been given. So there are 3 MCQs that I've covered here. I'll say them once again. The first one is a pure dedicated NEET PG question. Lennox-Gastaut syndrome, less than 3 hertz. The word is less than 3 hertz, spike and slow wave pattern, sorted. देन इज एन एफएमजी एग्जाम क्वेश्चन कि क्या दवाई नहीं देंगे, तो नहीं देने वाली दवाई है फेनिटोइन एंड कार्बामेज़ेपिन, देंगे क्या इथोसेक्सिमेट, उसको कोई गलती नहीं करता है, देन इज द साइड इफेक्ट्स ऑफ कार्बामेज़ेपिन एन्यूमरेटेड, एंड द लास्ट क्वेश्चन आई डिस्कस्ड वाज इफ देयर इज hypsthymia described. We are not supposed to blindly answer as ACTH. Just check out if the association with tuberous sclerosis is given in a patient. If the association with tuberous sclerosis is given, then our answer will change over to vigabatrin. So that's like the summary of the first particular slide. Now again, this time the question is open to FMG question. Patient students, drug of choice for management of patients who are having seizure for more than 5 minutes. It's a known case of generalized tonic-clonic seizure. The next question after this will come to NEET PG aspirants. So I would like everybody to be ready for their turn. Yes guys, JTCS का पेशेंट है, दवाई खाता नहीं था या खाती खाती दवाई छोड़ दी, तो अगर जोड़ दी तो क्या करेंगे, तो क्या वैल्पोरेट देंगे या लोराजेपाम देंगे, या यू विल गिव डाइजेपाम लोराजेपाम टू द पेशेंट, बिकॉज द क्लिनिकल डायग्नोसिस इन दिस पर्टिकुलर पेशेंट इज GCSC. The clinical diagnosis of this chap is GCSC. A person is having seizures for more than 5 minutes. A person is having seizures for more than 5 minutes, then the technical term that we use for it is generalized convulsive status epilepticus, and we can use lorazepam as the first line management. Now is the question for NEET PG aspirants. Answer is not valproate because this is status epilepticus. देखो ना, किसी को 5 मिनट से ज्यादा सीजर हो रहे हैं, 5 मिनट से ज्यादा सीजर हो रहे होंगे तो एस्पिरेशन का रिस्क बढ़ जाएगा, हाइपरथर्मिया, लैक्टिक एसिडोसिस, उससे थोड़ी देर पहले चाय पिया था, अभी उल्टी कर दिया, तो एवरीथिंग विल गो इन द लंग्स. सो आई डोंट वांट टू टेक अ चांस. सो इट इज lorazepam that would be given in a patient. Now the question is, if you have given 1 dose of lorazepam and there is no improvement, yeah, the seizure is recurring, like you gave lorazepam, it stopped, and then you turned back and you went to second patient, patient's mother came running, doctor sahab दोबारा दौरा पड़ गया. When you gave the injection, episode got controlled. You said okay, इसको अभी आराम आ जाएगा, let him sleep because of sedation will be there, and you went to the next bed. So the mother came running, doctor sahab, patient को फिर से दौरा पड़ गया, wife came running, husband had an episode. What is the next drug? What is the next drug to be given? What is the next step to be done in this patient? Yes guys, waiting for your answer. 1 dose of lorazepam has been given. What is the next injection to be given? Yeah, the answer will be repeat IV lorazepam. बेटा मिडाजोलम अभी बहुत लेट आएगा. The algorithm, the updated algorithm, इसको ऐड कर लेना अगर आपने मेन नोट्स में भी सुना है. The updated algorithm says that in GCSC 2 shots of IV lorazepam should be given. The updated guidelines say that 2 shots of IV lorazepam should be given. This patient is having seizures. हाँ, प्रोपोफॉल अभी करते हैं यार, प्रोपोफॉल अभी नीचे आएगा. यस रमन, प्रोपोफॉल अभी आएगा, अभी बारी बात करते हैं प्रोपोफॉल की. पेशेंट केम विद सीजर्स फॉर मोर देन 5 minutes. That is generalized convulsive status epilepticus. So first agenda is to remember that this is status epilepticus in a patient, and answer will not be sodium valproate because obviously person can die while the episodes are occurring, and the updated algorithm is that 2 shots would be given. Sir dose तो पूछते नहीं ना आपसे, तो अभी हम डोज में क्यों जाएंगे, right? So we can use diazepam, lorazepam, any of the 2 molecules. So at the moment keep on focusing on the drugs that would be used. They ask you drugs, so it is 2 shots of lorazepam that would be given to the patient. Now question for everybody, if IV access is not possible, what will you do? If IV access of lorazepam is not available, how would you control the episode? You have tried IV, adult patient is having a seizure, you tried putting an IV access, IV access could not be obtained. So if IV access is not available, then how would you give the injection? Rectal. Okay, so बच्चे में rectal देते हैं, adult में rectal देंगे. Do you think that एक 70-80 year old आदमी, 70 किलो के आदमी को who's having convulsion, you will be able to turn and then you are gonna put something in the anal canal and insert it in the rectum and suppose it defecates on the hand of the doctor. It's gonna be messy, it's gonna be difficult, no? So what will we do? Yeah, it's not possible, sir. What will we do? Yes. It is intranasal midazolam. तो आप दवाइयों को mix कर रहे हो. What you guys are doing is you are mixing up all the drugs. It is in emergency. We can use intranasal midazolam in a patient. Or a simpler answer you would have given me, sir, I will give intramuscular lorazepam. The simpler answer that I expected out of you was, sir, I am not able to get IV line, I will give intramuscular, it will act after 1 or 2 minutes, action will start, na? Or I can use intranasal midazolam in a patient. The point I want you to understand is, one is intranasal or we can use simple intramuscular. I agree to the fact that in intramuscular, the effect of the injection will come a little later. And in government hospital, if you don't have lorazepam, you can give diazepam, and standard diazepam 5 milligram, 10 milligram shots that you're using. The algorithm at the moment is now, I'll repeat the facts again. Generalized convulsive status epilepticus is a medical neurological emergency. In these patients, don't waste your time trying to secure the airway. You won't be able to secure the airway. Because the patient's whole body is shaking like this. Eyes ऐसे ऊपर चढ़ गया है, they would be frothing at the corners of the mouth, so you would not be able to intubate. You're not supposed to do bag and mask ventilation. Get an IV line in place, make a vein and push diazepam, lorazepam, whatever is available. If you're not able to get that access, give intramuscular. Better still, in the emergency nowadays, we start keeping intranasal midazolam and we can manage the patient. Patient is non-cooperative for injection. All patients of seizures are non-cooperative for injection. Patients of seizure are not in their senses, beta. When if you seen the patient's eyeball is like this, eyes are closed, uprolling of eyeballs, frothing from the mouth, cyanosis, whole body is very tight and the whole body is shaking like this. So cannula the counter होगा ही. अभी तो पूछा मैंने आपसे कि जब कैनुला काउंटर होगा तो करोगे क्या? नो, यू विल नॉट अप्लाई फोर्स. नो टच पॉलिसी. No touch policy, guys. No force is to be applied. No touch policy. The point is, right? Relatives hold the patient very tightly. Doctors hold the patient tightly. You will cause a muscle tear, you will cause a ligament tear, you will cause a hematoma, you will cause a shoulder dislocation. So not touch policy is to be used. Patient will not be cooperative at all. That is why we are discussing. Patient will not be cooperative. Okay. After this, the next thing that we'll be using in this patient is phenytoin. Either of the three drugs can be used. So you need to remember the algorithm. We give phenytoin infusion. We give phenytoin infusion, or we can give valproate or levetiracetam in a patient. The main aspect is that if the patient shows failure to respond to 2 doses of benzodiazepine, lorazepam given twice, and first line anti-epileptic drug, then diagnosed as refractory status epilepticus. And now will come what you were saying, that can we use propofol for the patient? Yes, this is the time for propofol. This is what they have asked in the exam, that a patient shows failure to respond to 2 dosages of benzodiazepine and the first line anti-epileptic drug. What is the first line anti-epileptic drug here given? Phenytoin. Or instead of phenytoin, you could be using valproate or levetiracetam. The yellow it is for the first line anti-epileptic drug that we are given to the patient. If the person is not responding to this conventional treatment, that is when you will be using propofol for the patient. We should be fast in our treatment. You see, there is a risk of neuronal injury. The T2 is the time to treat. We should treat within 5 minutes. Or as early as within 5 to 10 minutes. T2 is risk of neuronal injury, which is usually by 30 minutes. So I'll not get into writing those mathematical values. What I want to say is that the faster we operate, yeah, pentobarbital, coma and all those things will come subsequently. So propofol करके क्या करेंगे? Propofol देके, why are we doing a propofol? Why are you giving propofol, by the way? What will you do after giving propofol? Will it control the seizure? Thiopentone sodium नहीं देते बेटा आजकल. Thiopentone sodium is not used anymore. Why are you giving propofol? You want to secure the airway. The guy will otherwise choke. He will vomit, aspirate and die. Rapid sequence intubation. अभी कल परसों पढ़ा है ना एनेस्थीसिया में, जब पेशेंट को आरएसआई करते हैं तो रैपिड सीक्वेंस इंट्यूबेशन के टाइम पे क्या देना होता है, उसको प्रोपोफॉल देना होता है, एंड यू विल बी इंट्यूबेटिंग द पेशेंट, गेट अ endotracheal tube access in a person, because ventilation is of paramount importance, because the guy will aspirate and die. So propofol will be given, rapid sequence intubation, and intubation is what is required. What is the color of the urine after giving propofol to the patient? You will put Foley's catheter also, because patient is not in his senses. RSI is rapid sequence intubation. What is the color of the urine in the urobag? Like you put a catheter, urobag. What will be the, all advantages, decrease ICP, decrease the risk of seizure, it will cause a green discoloration of urine. So lots of time like the relatives will be asking you कि sir इनको ना green color का urine आ रहा है. Green urine in the urobag is a normal finding. Green urine in the urobag is a normal finding after propofol. Rhabdomyolysis नहीं बेटा, वो तो हो जाएगा. That is the risk here. The person was having continuous seizers. If I had not given this aggressive treatment, then rhabdomyolysis would have occurred in a patient. Let us summarize. Everybody on the same page with me. 2 shots of benzodiazepine. Either IV, IM, intranasal, doesn't matter. 2 shots of benzodiazepine must be given to the patient. How do you give those 2 shots? IV, you can give it IM, you can give it intranasal. Rectum is for bacha. For adult, it is like heavy person. Now, how will you turn the patient? It will become very, very difficult. And then you give antiepileptic drug like phenytoin infusion in the patient. And then subsequently, what you will do in the patient is you will use propofol in the patient. So exactly. Like these are the interventions that you will be doing for this particular patient. Drug of choice for seizures in a patient more than 5 minutes is what I've explained. GCSE. When I was a student your age, the cutoff was 30 minutes. It was like very tormenting for patient. No, 29 minutes seizures happening. 30th minute you say, all right, this is GCSE. Then they changed the algorithm, and now the algorithm is don't wait for 30 minutes. After only after like 5 minutes start treating the patient in. Okay, guys, moving ahead. Focal seizures. So we give either of the two, bache, either of the two. Either it is phenytoin, or it is valproate, or it is levetiracetam. Either of the 3 would be given. Okay, so we move on to the next one. That is gonna be focal seizures. Focal seizures would be starting with the aura. Aura means like there would be visual complaints. Like aura is like what you get in migraine also. So lots of time focal seizures patient might be complaining of visual blurring, like zigzag lines in the visual blurring would be there. And then when the attack will begin, the patient will say that the involuntary movement started in the hand. Then it involve the first start in the thumb and the hand, then in the wrist, then in the elbow, and then the whole hand will be shaking uncontrollably. Patient will use the other hand to control it. So we call it Jacksonian march, or instead of that we use the word marching epilepsy. So the manifestations will first start in the hand, then in the elbow, then in the shoulder, and then maybe like the whole of the hand would be shaking. T1 and T2 मैंने बताया था, आपने सुना नहीं. T1 is the minimum time in which we should be treating. That should be under 5 minutes. I mean, usually by 5 minutes. And T2 is the risk of neuronal injury. That is usually irreversible damage हो जाता 30 minutes पे. तो वही तो बता रहा था कि जब मैं आपकी उम्र पे था तो हम 30 minutes के बाद ट्रीटमेंट चालू करते तब तक न्यूरोनल इंजरी हो जाता था. So now the time to treat is by 5 minutes start treatment in the patient. By 5 minutes start treatment in the patient. And T2 is if you don't intervene, there would be irreversible brain damage in the patient. So that is what I've tried to explain. That is T1 and T2 beta. Okay. Now is focal seizure. In JTCS, the whole body will be shaking. In focal seizure, it is one hand or one side of the face. Face का twitching हो रहा है, हाथ में झटका आ रहा है, जिसको जैक्सोनियन मार्च बोलते हैं या मार्चिंग एपिलेप्सी बोलते हैं. After the end of the episode, patient will not be able to use the affected arm. उसको बोलते हैं Todd's paralysis. Todd's paralysis means that at the end of the episode, because lactic acidosis हो जाएगा, हाथ में ऐसे झटका आएगा तो मसल्स टाइट हो जाएंगे, लैक्टिक एसिडोसिस हो जाएगा, तो पेशेंट विल डेवलप इनएबिलिटी टू यूज द आर्म, or he may develop inability to use the leg for maybe a variable time. It can be 5 minutes, it can be 10 minutes, it can be 5 hours, but the patient will not be able to use the arm. इसका मैं एग्जांपल ऐसे दूंगा, आप जिम में वर्कआउट करते हो तो जैसे जिस दिन आप लेग्स करते हो तो उस दिन तो सीढ़ियां भी नहीं चढ़ पाते ना. सपोज यू गो टू अ जिम एंड यू डू लेग्स, your trainer made you do too much of legs today. So you will not be able to even like climb stairs because muscles में pain होगा ना lactic acidosis की वजह से. So similar spirit here, what is happening in the patient is that there would be severe pain that is experienced by the patient. There is weakness experienced by the patient at the end of the episode for a variable duration. It can be like few minutes to few hours. That's gonna be like Todd's paralysis. Some of these patients can be having complex hallucinations. कॉम्प्लेक्स hallucinations would be जैसे कि वो बोलेगा कि कहीं पे ना बर्निंग रबर का स्मेल आ रहा है. Like if somebody will burn a tire, then when the rubber will burn, it will produce a very peculiar smell. Or I can say like when dead fish, right? जैसे dead fish होता है, like आप अगर fish market में गए हो तो dead fish का जो bad smell होता है, like the person is saying he can smell some fish in the ward, dead fish in the ward. There's only antiseptic smell in the ward, but the patient is saying that he can smell dead fish in the hospital. So burning rubber, dead fish, that is subjective phenomenon, that is olfactory aura in the patient. And that would be, I understand, Raman, that is complex hallucinations in a patient. And what is automatism? Automatism है जैसे कि ऐसे लिप माउथ ओपनिंग करता रहेगा, क्लोजिंग करता रहेगा. He will keep on licking his lips, or he will keep on like picking on his clothes. Picking मतलब जैसे like ऐसे कुछ निकाल रहे हैं, जैसे बंदर नहीं करते monkeys, ऐसे they keep on picking of flocculation होता है जो automatism, that is involuntary. या automatism का best example है involuntary smacking of the lips. So patients who are having focal seizures, there would be no like jhatka in the body. It is like some part of the body which is getting involved. And in some cases, MRI will always be having. Aura का मतलब है visual blurring, जो माइग्रेन में भी मिलता है. और यहाँ पे अटैक स्टार्ट होने से पहले ब्लरिंग हो रहा है, एक आंख से धुंधला दिखाई दे रहा है, दोनों आंखों से धुंधला दिखाई दे रहा है, और फिर हाथ में झटका आ गया. द क्वेश्चन विल बिगिन बाय सेइंग IT प्रोफेशनल 30 years of age sitting on a laptop, he says I cannot see the screen properly, something is wrong. And then he starts having this involuntary movement in the hand, starts in the hand, then the involuntary movement elbow, and then the whole of the hand. If you have not seen a seizure in a patient, my request is go to YouTube, just type my name on the prep letter channel only. I put a patient of seizures के हर type के seizure मैंने describe किए. Just check that out for 10-minute video. That will help you actually solve even like the MCQs also, because you will understand how the seizures would be looking like. Like suppose you've been abroad and you say कि सर हमारा तो मतलब internship वगैरह में इतना exposure नहीं हुआ seizure वालों से, तो अगर मैंने patient नहीं देखे हैं तो just check it out for 10 minutes and you'll get a better understanding here. So like something like tics, yeah, but different. Like tics would be totally grossly. This is pure motor manifestation that is happening. And now we will talk about MRI finding. This may or may not be present in a patient, that is hippocampal sclerosis, that is fibrosis in the hippocampus. But this is especially if you're a NEET PG aspirant. Can you help me with the diagnosis, please? Hippocampus is in the temporal lobe. Person is having focal seizure, IT professional having focal seizures, hippocampal sclerosis. इसको बचपन में फेब्राइल सीजर भी होते थे. The question is exclusively for FMG students. अब अगर आप FMG student हो तो लास्ट लाइन को छोड़ देना, कोई दिक्कत नहीं है. Hippocampal sclerosis, what is the diagnosis? Okay, when I will write it, I'm very sure you would have done a MCQ on it. It is called as mesial, not medial, mesial exactly. Nadeem was the first one to comment. Mesial temporal lobe. It is mesial temporal lobe sclerosis because there is a fibrosis in the brain and that is causing seizures in the patient. This mesial temporal lobe sclerosis, there is a fibrosis. इसको मैंने इसलिए बताया कि this condition, NEET PG aspirants, pay attention at the moment. This will not respond to carbamazepine because there is fibrosis in the brain. So in this particular patient, surgery needs to be done. The question in your paper said, in which of the following presentations in epilepsy will you require to do neurosurgery in the patient to remove the area of the fibrosis? Then this is one such example where medicines will not work and neurosurgery would be required to remove that epileptogenic focus of fibrosis. It is refractory to drugs. Yes, Maria, you're right. It would be refractory to medicines. Very good. MTLS, medial temporal lobe sclerosis, basically implies that there is a fibrosis. So we will have to go for neurosurgery. We'll have to go for neurosurgery for management of these patients effectively. So traditionally for focal seizures, if he says what is the management, that I've already told you. The main drug for management is carbamazepine. So in routine questions, he will just say what is the drug of choice of focal seizure? No, beta, we'll use carbamazepine. Specific drug is LCOP. The specific drugs that we use for this are focal seizures is LCOP. L-carnitine we can use lamotrigine. Like lots of time history is not very clear. Patient कभी बोलता है वन हैंड में आता है, कभी कहता है फुल हैंड में आता है, तो फोकल सीजर्स में secondary generalization will also be there. So we use lamotrigine, or we use carbamazepine, or we can use oxcarbazepine in the patient, especially in older patients. We can use oxcarbazepine, or we can be using phenytoin in this patient. So yes, lamotrigine is a broad spectrum antiepileptic drug. It can be used in focal seizure also, and it can be used in management of GTCS also. Both in focal seizure, both in patients of focal seizure as well as in patients who are having GTCS. In all of them it can be used. Oxcarbazepine का फायदा ये होता है कि it is like it shows very less interaction with other drugs, statins and nitrates and all those things. So that's why it is like a drug which is recommended in old age group. So these are the drugs that would be recommended specifically for management of focal seizures, including the side effect carbamazepine that I've said. So a high-yield slide, guys. मतलब you have studied the drugs, but what I'm trying to tell you is कि करना क्या होता है and how the patients would be presenting in front of us at the moment. And now I will give you presentation of GTCS, generalized tonic-clonic seizure. Okay. पहले तो नाम पढ़. Mesial temporal lobe sclerosis. Temporal lobe के अंदर hippocampus, and there is a fibrosis in this area. This acts like a, ये क्या करता है बेटा? This acts like a epileptogenic focus. This acts as a epileptogenic focus. It will trigger seizures in a patient in some part, local part of the brain में abnormal activity. तो face की touching हो रही है, हाथ में झटका आ रहा है, बार बार आ रहा है. आप कार्बेमाज़ेपिन दिए जा रहे हो, ठीक ही नहीं हो रहा, because this is the fibrosis in the brain. So if you will not remove the fibrosis, medicines will not work. So this is one example where surgery would be used. Lamotrigine and carbamazepine as a mood. Yeah, that's okay. For focal seizures, that is perfectly fine. Pranav, I've answered your query. And let's move on to the next one. That is, let's move on to GTCS. Okay, ictal cry. GTCS is the most common variety in adult population. GTCS is the most common type of seizures in adult population. This guy, this is a young guy, he woke up in the morning, so he says कि मुझे ना ठीक नहीं लग रहा था. Like most patients of GTCS will say that when I wake up in the morning, I was having headache, I was not feeling well, vomiting भी हुआ. So that is warning symptoms are there. Premonitory symptoms का मतलब क्या होता है? Premonitory का मतलब होता है कि there would be warning symptoms experienced by the patient. Premonitory means warning symptoms are experienced by the patient. So his mom told me, बेटा आज बाइक लेके मत जाना, you can have an accident. So he said, okay mama, I will take a metro. Now this particular guy has gone to the hospital. Now this guy has gone to the college, like he is a non-medical person, so he has gone to college in a metro. And he is sitting with his friend, like रास्ते में उसको स्कूल का फ्रेंड भी मिल गया, who is like going by metro. So two guys are watching a video in their mobile phones, they're laughing and joking, and as normal guys would do. And then the history is given by his friend. इसका फ्रेंड कह रहा है कि सर ये ना हम मेट्रो पे बैठे, सीट पे बैठे थे, बैठे बैठे ना ये सीट से नीचे गिर गया और जोर से चिल्लाया आह. तो इसका फ्रेंड कह रहा है सर मुझे लगा पता नहीं इसको चोट लग गई, क्या हो गया. लाइक दिस गाय वाज peering into his phone, scrolling the phone like this normally, and he says suddenly he fell down from the chair in the metro, like on the side rail of the metro where he's sitting, he fell down. He says when he fell down, the whole body became very tight. You have to appreciate अगर किसी को ना vasovagal syncope होता है, if somebody will develop vasovagal syncope, then the whole body will become very loose. But here it is not vasovagal syncope. The body will become very very tight. That is tonus which will last for 15 to 30 seconds. जिसके बाद में उसका फ्रेंड कहता है कि सर after that the whole body started shaking uncontrollably. This uncontrollable shaking in the body is what is called as clonus, and this clonus is the critical part, because in the clonus part you will be having development of violent jerking. This violent shaking, this violent jerking that you will be noticing will be involving all the limbs in the body. It will be involving all the muscles in the body. At this point of time, the patient will not be in his senses. उसकी आंखें ऊपर चढ़ जाएंगी. There would be uprolling of the eyeballs of the patient. There would be violent jerking of the all limbs. There would be violent uprolling of the eyeballs, and patient will be not be able to swallow his saliva. So you were noting frothing at the corners of the mouth. His friend is saying, sir, I got very scared. He fell on the ground and his lips were deathly blue. क्योंकि आदमी सांस नहीं लेगा ना. The patient during a clono stage will be holding his breath. If you put it on yourself, if you hold your breath for 15 seconds, 30 seconds, there is a high probability that the person will develop perioral cyanosis. So this particular individual is going in a clonus stage. This clonus may be lasting maybe 15 to 30 seconds, but they are the most critical 15 to 30 seconds of the life of this guy. Because if at this point of time he will vomit, he can aspirate and die. So the history is ictal cry. Ictal cry, there can be tonus, there can be clonus, and yeah, in some cases the patient may clench his teeth very tightly. When the person will clench his teeth very tightly, accidentally the tongue may come between the teeth. So you might even be reading regarding tongue bite developing in these patients. This is a standard history in generalized tonic-clonic seizures. The drug of choice for management of this condition is sodium valproate. But you will not answer valproate if it is the young female in the reproductive age group. If the MCQ deliberately will say that this is a young female, FMG students, now pay more attention. Rest was the clinical detail. He said young female, this kind of description given, and she is getting married next month. What will you do? Then obviously you all know the fact that valproate is teratogenic and it can cause neural tube defects. So he said, what is the safest antiepileptic drug in pregnancy? Your answer is levetiracetam can be given. If this is not in the options, you can answer lavotrigine also. But in the Harrison, first levetiracetam is given. So with this kind of a clinical presentation in a female patient, your answer would be young female planning to get married, conception. Then it is levetiracetam and lamotrigine that would be used. Otherwise, it is sodium valproate that is given for 2 years and then tapering is done. Antiepileptic drugs should not be stopped suddenly. Antiepileptic drugs should not be stopped suddenly. Sudden withdrawal of drugs can result in development of rebound epilepsy in a patient. And as I've explained to you, lamotrigine is one drug which has an advantage that it can be used in both GTCS and focal seizure. Some patients of focal seizures will give you that, tell you that someday I have focal seizure only in one hand, and sometimes I have GTCS. So if a patient is giving a history of double kind of seizure, focal also and secondary and GTCS also at different times of the week and different times of the month, then we can use lamotrigine for management of these patients. Please tell me the commonest side effect of sodium valproate. What is the commonest side effect of sodium valproate? Yes, guys, quickly. One of the biggest side effects is sodium valproate. Most common side effect of valproate, please. I'm waiting for your answer. Alopecia, hair loss will be there. Yeah, if she's already pregnant and she can continue if she's already conceived and we give folic acid. That's okay, perfectly fine. Biggest side effect of nausea, vomiting. When we are failing in the exam, then we answer nausea, vomiting. The biggest side effect of sodium valproate is, nahi bhai, hepatotoxicity. The biggest side effect of sodium valproate is hepatotoxicity. How will he write that in the MCQ? He will write this word hyperammonemia. The biggest side effect of valproate is always check LFT in the patient. Hyperammonemia is always a big side effect. It is elevated liver enzymes. Yes, Dr. Sahu got it right. Behera got it right subsequently. It is hyperammonemia, which is the biggest side effect. Then are obviously the traditional things like alopecia, weight loss in a patient. But if you got this wrong, guys, you need to fix and study antiepileptic drugs again today. I have introduced this topic post lunch because one usually like antiepileptic drugs is something which people think that they know, but like the rationale behind the discussion is not to tell you that you don't know. Rationale is to tell you how to use these drugs, right? Because a pharma chap will tell you what is the mechanism of action and what is the drug of choice where, but then how the case will present and what is to be done at what point of time, that is what I have tried to explain here. Like the most important two questions of this topic which I don't want you to ever mess up is valproate causes hyperammonemia, never to be forgotten, and what is first line management for GCSE, never to be forgotten. 2 shots of benzodiazepine. If it controls with first shot, cool. Most of the time it won't. So he will ask you what is the second thing to be done. Very good. I was waiting for that. GI side effect next is pancreatitis. Valproate is notorious. Why it is asked in the paper is because of the 2 aspects which now have been added. Yes, I was waiting for that comment to come up, right? Hyperammonemia, alopecia, pancreatitis is a side effect. Let me repeat this once again. Hyperammonemia, pancreatitis, point number 1. Point number 2, how do you manage GCSE? 2 shots of benzodiazepine. If first is gonna be reported, first is gonna be okay. If patient will be okay after the first one, then you can give a second shot. Okay, fine. Next, we will talk regarding absence seizures. Absence seizure is sudden brief loss of consciousness without loss of postural control. The word is without the loss of postural control. Patient will not fall down. If the MCQ says need PG aspirants, hit the comment button. If the question says brief loss of consciousness with loss of postural control, what will be the diagnosis? Yeah, we will have a chai break. Listen to me carefully. Need PG aspirants, please. If I change the word to with, if I change the data to with loss of postural control, can I have the clinical diagnosis, please? ऐसे गर्दन गिर गया, बंदा नीचे गिर गया, ड्रॉप अटैक्स. वेरी गुड, वेरी गुड. ऋषि करण, Dr. Sahu was the first one to comment on this one. You have to pick up the words very, very carefully. Absence seizure will say loss of consciousness without loss of postural control. The patient will not fall on the ground. If they change the question to with loss of postural control, it will become atonic seizure. In the MCQ, it was written as drop attacks. Atonic seizure is also called as drop attacks. यहीं पे खत्म कर लेते हैं एटोनिक सीजर को. टेल मी द ड्रग ऑफ चॉइस फॉर एटोनिक सीजर गाइस. आई हैड गुड आंसर. सिमरन, दिलीप, परफेक्टली राइट. नदीम, यू आर स्पॉट ऑन फॉर दैट. यस गाइस. वेटिंग. ड्रग ऑफ चॉइस फॉर एटोनिक सीजर. यप, सोडियम वैल्प्रोएट. जहां पे भी कुछ भी फिट ना हो वहां पे वैल्प्रोएट फिट हो जाता है. कमिंग बैक टू एब्सेंट सीजर. In absence seizure, there would be vacant staring spells, 3 per second spike and slow wave, and carbamazepine and phenytoin can worsen the absence seizures in a patient. And absence seizures have a good prognosis because I can say that with age, the severity of the disease will decrease. Like as the patient of absence seizure will become older and will start going to college or will start going to work after 18, then the severity of the disease will tend to basically begin to reduce. Question for everybody. What is the most common type of epilepsy in children? Commonest type of epilepsy in children. Febrile. Okay, Rohit, but febrile will you call febrile epilepsy? Will you call febrile as epilepsy? No. Okay, one answer came in between. Waiting for answers, man. Nope. The most common type of epilepsy in children is benign Rolandic epilepsy. What you are supposed to do is now, all of you, homework for you is, if you say ki sir I have read anti-epileptic drugs, believe me, you have not read them, neither from pediatrics, neither from pharma. You are just superficially thinking that I am. My words might look a little bad, but bura mat mana, because I want you to produce results, right? You are my students, right? If it's your career, it is my reputation at stake. If it's your career, it is my reputation at stake. सर एवरीबडी इज एज्यूमिंग कि मुझे आता है. यहाँ पे जो मैं फीडबैक देख रहा हूँ ना, वन आई अंडरस्टैंड इट इज पोस्ट लंच, सो द फीडबैक विल बी स्लो. बट what is happening at the moment is that you are assuming कि मुझे आता है, but you are making big mistakes at the moment, और ये blunders होते हैं और ये blunders नहीं करने. So आपने अब करना क्या है? First you read my notes, go back to pharma, finish pharma, read pediatrics again, the pediatric neurology, the epilepsy wala chapter, and then read this again. Then you will get a holistic view of how the Dora part is corrected. It is benign Rolandic epilepsy. These kind of questions should never go wrong. What is Rolandic epilepsy? It is simple focal seizures. The mother will say कि बच्चा जो था वो रात को सो रहा था, सोते सोते मुंह की ऐसे ट्विचिंग हो रही थी. The focal seizures that are occurring in a patient, would be twitching of the face or involuntary movements in the hand of a patient. We will give carbamazepine for this patient. So basically, नहीं यार, it's not like this that नहीं आता है. Like you're not supposed to think like negative vibes नहीं लाने. Never circulate in a group that is negative. You know, the people who will say पता नहीं कैसा पेपर आता है, मुश्किल बनाते हैं, easy बनाते हैं. No man, you are like okay, bring it on. But then at the same time, we have to realize what is our negatives and what are our positives. Positives are obviously you guys have been doing very well the whole day, right? But they would be waxing waning course. That waning course has to be minimized so that I'm able to optimize your performance. So aata hai, right? It is just that at critical times we have what is called as brain fog. Brain fog is like brain shuts down. And that is to be देखो ऐसा कोई मैजिक दवाई तो है नहीं है, right? No teacher, no medicine in the world can say this can switch on and your brain will suddenly start working. No, it's not like that, man. It's just a part and parcel of life. Okay, moving on. Yes, most common type of seizures in children. यहाँ पे द आंसर इज फेब्राइल सीजर्स. यहाँ पे भी मैं देखता हूँ कि स्टूडेंट्स गलती करते. द आंसर इज एब्सेंट सीजर. एब्सेंट सीजर्स आर नॉट कॉमन गाइस. प्लीज अप्रिशिएट द फैक्ट. The most common type of seizures in adults is GTCS right on the top. Then in children, it is febrile seizures that are happening. What is the commonest type of seizures when it comes to newborn babies? Their answer is subtle seizures. Then it is subtle seizures. What is the leading cause of subtle seizures? That would be hypoxic ischemic encephalopathy. What will be the feature of subtle seizures? Then it would be written in MCQ. You can read that in pediatrics. It is written as jitteriness. जिटरीनेस मतलब बच्चा बार बार अपनी आईज ब्लिंक कर रहा होगा, फ्लटरिंग ऑफ द लिप्स कर रहा होगा. सो दैट इज जिटरीनेस. इफ यू रीड अ क्वेश्चन न्यूबॉर्न बेबी हैविंग जिटरीनेस, इट इज सटल सीजर. द लीडिंग कॉज इज बर्थ एस्फिक्सिया, दैट इज हाइपोक्सिक इश्केमिक एन्सेफेलोपैथी. सलाम सीजर्स, ओके, दे आर नॉट कॉमन. रीड दे वेरी रेयर. इसके लास्ट में आएगा. What is the best drug for intermittent prophylaxis of febrile seizures? I will give options फटाफट से. I want everybody to participate. Oral diazepam, rectal diazepam. Hit the comment button. Oral diazepam, tremors of fingers and lips. Nadeem, you spot on. What is the best drug for intermittent prophylaxis? Yes, guys. Febrile seizures have a tendency, na? It's so hot nowadays. Child had a fever, viral URI, the seizure will occur. How would you manage the patient? Oral diazepam or rectal diazepam? I want more comments. Yes. Yes. Okay. हाँ, बच्चे की बात कर रहा हूँ मैं. बच्चे की बात कर रहा हूँ. बच्चा है, फेब्राइल सीजर है. व्हाट इज द बेस्ट ड्रग दैट यू वुड बी गिविंग टू द पेशेंट? ओके. Guys, intermittent prophylaxis for prevention. For prevention मतलब वो बच्चा बड़ा होके आपको कितनी गाली देगा. ये डॉक्टर साहब जो थे ना, इन्होंने मेरे को कितना तंग किया है ना. हर बार रेक्टम में आपने दवाई डलवा दी बेचारे के. बेस्ट ड्रग फॉर इंटरमिटेंट प्रोफिलैक्सिस. Best drug for intermittent prophylaxis of febrile seizures is oral diazepam. It is not rectal diazepam. That is for management of episode. If the question was like I told you that a mother has today come to the clinic, she says my child is having seizures again and again. Doctor, how do I manage? So I'll say don't come to the clinic again. She says, doctor, you're so rude. You're telling me not to the clinic. I said, ma'am, I wanted to manage the kid at home. She says, I'm not a doctor. How do you expect me to manage at home? मैंने कहा, ma'am, next time the child might aspirate on the way to the clinic. Start treating the child at home only. She says, how will I do it? I'm not a medico. I said, ma'am, we will teach you rectal diazepam. We can teach the mother rectal diazepam. Suppose she said, no, I can't insert something in the anus of the child. No, sir, ना बाबा, छी, मैं नहीं करती सर ये. तो as doctors तो ठीक है ना, हम लोग तो rectal diazepam देने के बाद में we just take off gloves and pizza भी खा लेते हैं. And this she is like चीची मैं नहीं करती. तो हम बोलेंगे no, not a problem. Then it is intranasal midazolam that she can be using. Guys, you are mixing up the data. It is for episode treatment at home. It is rectal diazepam or intranasal midazolam. But how do we prevent? Then the prevention is gonna be oral diazepam. And here the single best answer is oral clobazam, not clonazepam. It is oral clobazam. Or it could be oral diazepam in a patient. So when you attempting questions, I hope you would not make these mistakes once again that are currently explained to you. If they say, how do you prevent oral clobazam? Sometimes in febrile, next line is specifically for NEET PG aspirants. बेस्ट फॉर कंटिन्यूस प्रोफिलैक्सिस. समटाइम्स थोड़ा सा भी फीवर होता है ना तो उसको फेब्राइल सीजर हो जाता है. इट्स नॉट दैट इट विल गो अप टू लाइक 100 डिग्री और 101 दैट यू विल हैव अ सीजर. इट इज लाइक sometimes the seizures just keep on happening even with little bit of fever. Like it's hot nowadays ना, थोड़ा सा बुखार हुआ, खांसी जुकाम हुआ, the child is having seizure. For continuous prophylaxis, it is oral valproate. If you're an FMG exam student, the first and the third statements are to be remembered by you. First statement and the third statement to be remembered by you. If you're a NEET PG aspirant, all the three statements to be remembered. Best drug for intermittent prophylaxis, oral clobazam. Best drug for acute episode, rectal diazepam or intranasal. If he changes the word to continuous prophylaxis, then it is oral valproate. And then another question on NEET PG, which is never ever to be given for continuous prophylaxis, it is phenytoin. The middle line, if you're an FMG student, just forget about it. The top two, never swap between the two with respect to febrile seizures in a patient. Now I am describing a 8 mahine ka bachcha. This child had started sitting without support. So the mother today, this child is like playing with toys. He's playing with toys. He's playing with some toy car, something. 8-month-old child has just started sitting, and the mother left the child with the grandmother and she went to take a bath. When she came out of the bathroom, she says, "Doctor, I was horrified. The whole body of the child, ऐसे पूरा body ना ऐसे झुक गया था आगे को, जैसे झुक के सलाम करते ना किसी। The whole body of the kid was bending forward like this, and the child was not responding. This is the presentation. It will benefit versus loss. Bhai, aspiration, Lavish. Aspiration pneumonia versus hepatotoxicity. I'll balance it out, man. I'll decrease the dose. I'll not give it high dose, na? Yes. This at the moment is salam seizure, in which he might use the word myoclonic jerks, in which he may say myoclonic jerks involving the truncal musculature. Myoclonic jerks involving the truncal musculature. The mother says, "I was petrified, horrified to see my baby who's having this myoclonic jerks involving the truncal musculature." He will also assist you by saying that the doctor has done EEG in this patient where hips arrhythmia word is given. In some MCQs, because hips arrhythmia you are able to pick up, because now I've taught you hips arrhythmia, you will be able to pick up. You would have noticed the MCQ saying the word grossly chaotic rhythm. If the word is grossly chaotic rhythm, that is an alternative expression. Grossly chaotic rhythm is an alternative expression for hips arrhythmia, which was told to you earlier. The manifestation is still the same. It is ACTH that would be given for management of this patient. So what I've tried to explain in the end is another type of seizures in children, but I hope it is clear to everybody that when I've described these seizures episodes, both in pediatric age group as well as the adult degree age group, you've been able to figure out that the drugs are to be used in a specific order and in a specific manner. And it's not random answers that we can give, that just if it is febrile seizure given, we give rectal diazepam. That is not the condition. Yes, jack and a knife. बैकग्राउंड सप्रेशन इज जस्ट दैट जो नॉर्मल अल्फा और बीटा वेव्स होते हैं ना, उनका एम्पलीट्यूड कम हो जाता है. बैकग्राउंड सप्रेशन सिंपली मीन्स बिकॉज देयर इज अ abnormal activity ना, so the prominent electrical waves will suppress the background alpha and the beta waves that are happening in different areas of the brain. That's the meaning of the background suppression. Okay, fine. So 10 नहीं है, 15 ले लो यार. We'll take a 15 minutes break. Timer at the moment, what's the time? हाँ, चाय ब्रेक है, चाय ब्रेक. टाइम कितना हो गया यार, मेरे पर टाइम नहीं आ रहा इसमें. हाँ, 5:31. So 15 minutes break है guys. 5:45 we will start again. 5:45 is the starting time. 5:45 is the starting time. Take care. Hi guys, welcome back to the discussion. So you guys can rejoin and we can get started in a while. The topic we'll be discussing is bacterial meningitis. So this would be a revision of microbiology components as well. Okay, so I think we're good to go and people will gradually start joining. So we can wait another few seconds and then we can join. So today was a little more data intensive than what it was yesterday, but then it's okay. Part and parcel of life. Fine. So we're good to go, guys. We'll talk about bacterial meningitis. Again, a very simple and a small topic that we can cover regarding, the organism specific approach. And I think micro to ho gaya tha, so you guys will be in a better position to answer like, aspects related to each one of these. Okay. So the first question that we'll discuss is a leading cause of meningitis in a newborn with bulging anterior fontanelle and vacant stare. You know that whenever there's gonna be bulging anterior fontanelle, it means that the child is having raised ICP. That's an indirect parameter. Just like in adults, when you do a fundus examination, there is a papilledema. Here, instead of papilledema, the word written is bulging anterior fontanelle, and the child is like having a vacant stare. The bacteria which is responsible for new meningitis in newborn babies, the overall most common one is called as group B streptococcus. In some multiple choice questions, even madam would have used the word streptococcus agalactiae for describing this bacterial meningitis. But if they change the question and say what is a rare organism, then the rare organism is Listeria monocytogenes. So at this moment, like there are two organisms that I want to say. One is that famous tumbling motility wala bacteria. The tumbling motility wala bacteria is Listeria monocytogenes, but this is relatively rare. So when the patient will come, then I will not be aware what is the organism that is responsible. Is it Streptococcus agalactiae or is it Listeria monocytogenes? So I will be giving broad spectrum treatment. In broad spectrum treatment, two antibiotics will be given in neonatal intensive care unit. One of the antibiotics that is used is cefotaxime. Cefotaxime will be giving coverage for Streptococcus agalactiae and Listeria monocytogenes. This is surprisingly, this is an FMG exam question that Listeria monocytogen does not respond to cefotaxime. What antibiotic will be used? Answer is ampicillin. So initially, because culture report will take a long time to come, so what you will do in the patient is you will be using two antibiotics for the patient. Cefotaxime and ampicillin are two standard antibiotics that are given, and when the culture report will come, then we will manage the patient accordingly. E. coli is the answer if nothing else is like, if he says the word India, if he says what is the leading cause of neonatal meningitis in India, like this is again an FMG exam question. He said India, then answer is E. coli. But on a global basis, the answer is not E. coli. The usual answer is Streptococcus agalactiae, and then is gonna be then is gonna be Listeria monocytogenes. Listeria monocytogenes does not respond to third generation cephalosporins. Listeria monocytogenes does not respond to third generation cephalosporins. It surprisingly responds to ampicillin. So broad spectrum antibiotic treatment would be given in neonatal intensive care unit. Question for you guys is what is the leading cause of bacterial meningitis in adults? This is the range group age. This is the range that is child also. It is the same organism. Adult is also the same organism. In fact, after 3 months of age and up to 55 years of age, the organism will remain the same. And no, it is not ciprofloxacin. It is not ciprofloxacin anywhere. The leading cause of pyogenic meningitis in adults as well as in children happens to be Streptococcus pneumoniae. It is strep pneumoniae overall the most common cause of bacterial meningitis. But if they change the question and says that the person is also having purpuric rash, if he changes the question and also says that the patient is having purpuric rash and distributive shock, then the organism will again change. If he says adults and children, I'll emphasize this statement again, leading cause of bacterial meningitis in adult and children, Streptococcus pneumoniae. But if he specifies that it is an adult patient and he is having rash present and distributive shock is present, then the organism will change over to meningococcus, that is Neisseria meningitidis. You know this bacteria is known to cause DIC. Neisseria meningitidis is notorious to cause disseminated intravascular hemorrhage, and due to disseminated intravascular coagulation, they can be like thrombocytopenia developing. This thrombocytopenia will first cause petechiae on the ankles and then it will go upwards. So the petechiae will first appear around the ankles and then they will go upwards, and therefore petechiae and purpura will be given in the question. So I've covered 3 MCQs till now. If he says newborn baby, agalactiae and Listeria monocytogenes, antibiotics told for each of them, cefotaxime, agalactiae, ampicillin, Listeria. For adults, it is strep pneumonia. For child, it is strep pneumonia. But if he says rash, then it is Neisseria meningitidis. Then he has said antibiotics should be started within how many minutes of arrival of the patient to the hospital. There are 2 aspects we will discuss here for Streptococcus pneumoniae. Everything that is being discussed here is for Streptococcus pneumoniae. He says you have to perform a guarded lumbar puncture. I mean, if I don't do guarded lumbar puncture, then person can develop a brain herniation as well. So within how much time antibiotics should be started in the patient? Yes, perform lumbar puncture and then start antibiotics within 60 minutes. Like you do the empirical, you have already done a lumbar puncture guarded with mannitol, and after that you can ensure that the antibiotics are given within 60 minutes to decrease mortality. If you think that the person meningitis is chota mota illness, if you think that meningitis is chota mota illness, it is not. There's a 30% mortality. So within 60 minutes, antibiotic should be started. Then is the name of the antibiotic. The 2 antibiotics, they were again asked in last July FMG exam. Empirical antibiotic therapy for strep pneumonia started with. Waiting for your answers. Last summer, the question was Streptococcus pneumonia, meningitis, empirical antibiotic treatment will be started with. Yes, it is ceftriaxone and second is vancomycin. A query that I get from students is why vancomycin is being given, because there is no staph aureus. But I want to tell you that vancomycin is not being given for staph aureus coverage. It is being given because strep pneumonia can exhibit resistance. So it is 2 antibiotics. In the MCQ, ceftriaxone alone was also given and vancomycin was also given. You have to select the combination. It is ceftriaxone and vancomycin combination that needs to be given. We always give 2 antibiotics because nowadays we are having resistance, because these quacks in the villages, they keep on using antibiotics with steroids. So antibiotic resistance is coming up at a big way in our country, and due to the high incidence of resistance, now we are using vancomycin. The next question that I'll be teaching you is having a twist. He's mentioning immunocompromised statement by saying alcoholic or heart transplantation patient. So one additional antibiotic needs to be given here. This additional antibiotic that needs to be given is to be given for coverage of Listeria monocytogenes. Earlier I was teaching you Listeria monocytogenes is present at newborn age group. But now I'm telling you that Listeria monocytogenes is not only present in newborn age group, it is also present in immunocompromised patients like heart transplant patient in anti-rejection drugs or alcoholics as well. So the additional antibiotic that will be given to this patient is ampicillin. So while attempting questions, NEET PG aspirants, hear me out very carefully. For you, the question was, he said alcoholic 55 years of age is brought to the hospital with suspected bacterial meningitis. What is the antibiotic regimen you will give? Because alcoholic word was given, then your answer is 3 antibiotics will be given, ceftriaxone plus vancomycin plus ampicillin. In FMG exam that was conducted just 1 week before the NEET PG exam, the question simply mentioned that like what is the treatment, it is 2 antibiotics. And then in NEET PG they slightly twisted the question by mentioning alcoholic or heart transplantation, whatever the case may be. He can mention HIV positive also, it doesn't matter. The point to be understood is that if immunity is lesser, we need to give more broad coverage. So at this moment, I hope I've been able to explain to you that Listeria monocytogenes, the bacteria famous for its tumbling motility, is present in neonatal age group. It is also present in alcoholic patients irrespective of the age group and heart transplantation patients. Neisseria meningitidis can cause petechiae. So the question also said mass chemoprophylaxis for Neisseria meningitidis will be given with. Here the answer is ciprofloxacin, which a lot of guys were saying initially. That is for chemoprophylaxis, that to a mass chemoprophylaxis, all the contacts. If here I change the question for healthcare worker chemoprophylaxis for Neisseria meningitidis, then the answer will again change. If he says mass chemoprophylaxis with Neisseria meningitidis, like all the contacts are being given ciprofloxacin, that is true because Neisseria meningitidis has a has a very critical nasal spread, right? It spreads by nasal droplets. But if he says healthcare worker, like doctor is exposed, nurse is exposed, cleaning ward boy of the person is exposed, then we need to give protection to healthcare worker. That is when the doctor should be given ceftriaxone. So for Neisseria monocytogenes, be careful of the fact that if he says healthcare worker, it is ceftriaxone. If he says for routine general population, the answer is ciprofloxacin. So this is what is taught even in micro. This is taught even in I think PSM people also teach it. But then the remaining aspects apart from outside this box that I've told you are critical medicine data. I'll repeat the critical medicine data once again. What is the empirical antibiotic treatment in a case of bacterial meningitis, whether adult or child? Answer to antibiotics, ceftriaxone, vancomycin. If he adds the word alcoholic, he adds the word heart transplantation, he adds the word immunocompromised patient, he says HIV positive patient, then change your answer to 3 antibiotics to give coverage for listeria also. Ceftriaxone is basically killing Streptococcus pneumoniae. Vancomycin is also killing Streptococcus pneumoniae. Why 2 antibiotics for one bacteria? Resistance. Why 2 antibiotics for the same organism? Resistance. Because the MIC of the antibiotic, minimal inhibitory concentration required of the antibiotics, is dramatically rising. So I can't keep on loading the patient with ceftriaxone, and therefore vancomycin will be given to the patient. So everything that I've said here is like organism specific approach that is given. The last question is again a repeat. It says recurrent meningitis. Till now I was talking about single episode. This is a teenager. This pathologist has covered in immunity chapter when she has taught you complement system. There is an alternate complement pathway. There is a killer pathway that is called as membrane attack complex C5 to C9. So if it is recurrent meningitis in adults with meningococcus due to C5 to C9 deficiency, this is again because of meningococcus bacteria. The question was asked in reverse. Like he did not say the fact that C5 to C9 deficiency is seen with which, like meningococcus causes recurrent meningococcal infection is seen with. The question was ulta written. Person is having membrane attack complex deficiency. The person is having membrane attack complex deficiency, MAC. That is the one you have alternate complements, one you have the classical component. Alternate complement begins with immunoglobulin A, classical with immunoglobulin G, and then you have a membrane attack complex. This coats the bacteria, that punches a hole in the cell wall of the bacteria, and the bacteria will die. So membrane attack complex deficiency predisposes to recurrent meningococcal meningitis in a patient. 90% of the data that I have said here right after the break is a repeat from what has been taught in other subjects, but I have tried to summarize that in a single slide. Now I will be handling the slides also which are given. So let me know regarding what bacteria is present here. Like there was history of meningitis given, lumbar puncture, Gram stain was shown, and my student said that we were able to pick up these 2 bacteria. These are 2 blue bacteria. So I'm saying gram positive bacteria, that is a diplococci. So if you are having 2 gram positive cocci, right, 2 gram positive bacteria, that is diplococci, which are present, then it is Streptococcus pneumoniae. This particular slide is a very classical slide that is always given for strep pneumoniae. This is actually a capsulated organism, but obviously the capsule cannot be seen. The capsule cannot be seen with Gram stain. So the image here shows a Gram stain, and this is a strep pneumoniae organism. Now, can you help me? How will you pick up the capsule? Can you tell me how will you pick up the capsule? There are 2 ways. One, I will write quelling reaction. You have to tell me the second one. Strep pneumoniae or pneumococcus is a capsulated organism. One is quelling reaction. What is the second way to pick this up? Yep. The second way to pick this up would be India ink preparation. This is very neglected. India ink is used for Cryptococcus, but it is also used to demonstrate the capsule. No, it is not McFadyen. India ink preparation is used to demonstrate capsule of Streptococcus pneumoniae. It is McFadyen is that related to the negative. McFadyen is again, I agree to you. You're not wrong. Quelling reaction and McFadyen is perfectly fine, but apart from this, they ask the stain, that India ink stain can be used here also. So India ink is a negative stain that can demonstrate the capsule. So McFadyen is okay. Your answer is not wrong. I should have clarified background stain. The background stain is the India ink stain. Now I will move to the second slide where my student said that the bacteria were present in where my student said that the bacteria were present in the security system. Like if you look at it, the bacteria are present in the security system. Intracellular bacteria. So because this is pink bacteria, intracellular. So this is gram negative. This is intracellular. This is Neisseria meningitidis. To help you with the diagnosis, simultaneously also given was the presence of petechiae. So it helps you identify this organism relatively easier. It's present in the security system. They would be free also in the CSF also. Some cells will die, so they'll come in the CSF, but then they are present in the neutrophils also. That is why, like, this is Neisseria meningitidis with a meningococcal rash present, and the shock that will occur in this condition, the shock that will occur in this particular condition would be development of septic shock. Ultimately, patients of Neisseria meningitidis can go into development of septic shock also. A vasopressor of choice for septic shock, as discussed before you, is NORAD, and if he says fluid of choice for septic shock, it is normal saline. Fluid of choice, normal saline. Vasopressor of choice for management of septic shock is NORAD. Okay, question for NEET PG aspirants: what is the target mean arterial pressure? What is the target mean arterial pressure that you need to achieve in septic shock for survival? MAP. MAP is a systolic plus 2 times diastolic, whole thing divided by 3. So NEET PG aspirants, please quickly chat in the type in the chat box. Mean arterial pressure should be more than how much? Yes, very good, 65 millimeters. 3 questions for septic shock to be remembered are normal saline, NORAD, target MAP to be kept at more than 65. And this would be details for like the various organisms, and then I mentioned the various antibiotics which are to be used here. The most important information that you're not supposed to forget is 2 antibiotics for children, adults, and 3 antibiotics if he mentions alcoholic or heart transplant or immunocompromised patient. I'll come back to this particular slide of the box a little later. Let me just complete the list for viral meningitis. Okay, one more thing I can write on this slide: triadomeningitis. If I say the word triadomeningitis will be having fever, there would be headache, and there would be nuchal rigidity. These 3 things together, fever, headache, and nuchal rigidity, is a feature that we counter with meningitis. Obviously, like the algorithm that we need to use in any one of these patients is, if person will come with this manifestation, we have to just give me a second. Let me come back to the original slide. If they give you a case of fever, headache, and nuchal rigidity, and he says like what are the steps that you would be using for management of this person, then first you have to rule out raise ICP, because lumbar puncture is always contraindicated in patients of raise ICP. So how will you rule out raise ICP? You can either do a fundus or you can do a neuroimaging like a non-contrast CT scan. Do not do a lumbar puncture directly in any patient of suspected raise ICP or any patient of meningitis, because high chances of brain herniation would be present. So any patient, like, you have to look for papilledema, you have to look for fundus finding of papilledema or CT head showing dilated ventricles. I mean, rule out raise ICP. If ICP is elevated, then I must, in those circumstances, first lower the pressure in the brain by giving mannitol to the patient, but I must rule out raise ICP in the patient initially. Any of the following things can be present. Subsequently, after this, if raise ICP is absent, then I will be doing a guarded lumbar puncture. Using this guarded lumbar puncture, in the lab itself, I can see microscopically neutrophils. When neutrophils are present in the microscope seen in the ward only, like we keep a microscope in the ward only, we are able to see the neutrophils, then we can start empirical. Then in these patients, we can start empirical antibiotic treatment, which is like the antibiotics I was describing. Most of the time would be in the form of ceftriaxone, vancomycin, to be managed accordingly. And yeah, one more thing that I would like to do is, like I have to anyway put an IV line in a patient, so I can also send a sample for blood culture. So I would just like to modify this by saying slight modification that I would like to put up in the data is, give me a second. A slight modification in the data is like I have evaluated that this guy is having neutrophils. Now I'm putting an IV line because I anyway need to give antibiotics to this patient. So he says that when you are taking the sample for blood culture, like you can put an IV, send the blood culture, and then subsequently you can start antibiotics in a patient, because it is always advisable, though I can start early also, but he says that ideally it is advisable to start antibiotics after taking the blood culture. So if in the algorithm they ask you to plan it accordingly, then because you putting a cannula, so you draw the blood culture and then start antibiotics in a patient. That way, like, the algorithm will be relatively better. And how do I lower the pressure in the brain? I can give mannitol in the patient. The message I want to say is that wherever possible in any infection, we must always try to do a blood culture first and then start the antibiotics, because the infection went via the bloodstream into the brain of the patient. Now comes the aspect of viral encephalitis. Viral encephalitis, overall the most common cause to be remembered for viral encephalitis is herpes simplex 1, HSV1. This infection is so dangerous that it can destroy the temporal lobe of the brain. This can cause complete destruction of temporal lobe. Temporal lobe is the area in which the hippocampus is present, and hippocampus is the seat for memory. If there is a delay in treatment of this person, the person will not even remember what his name is, what his mobile phone number is. Just like Alzheimer disease patient will not recognize son and daughter, Alzheimer disease patient will not remember what he ate for lunch or for breakfast. Similarly, this patient will have complete loss of memory, because you know that this guy will be having so much of severe damage, because you know that this patient will be having so much of severe damage that he can have complete loss of memory. So therefore, empirical treatment is started in all of these patients with acyclovir. What is the antimicrobial treatment that you will be starting is, don't wait for the PCR report to come, don't wait for the lab report to come. Empirical acyclovir can be done. And what are the hints that will be given in the question? If the MCQ itself mentions MRI head shows temporal lobe inflammation, most of the time, this that I'm mentioning was again FMG. He described a patient who was having fever for 1 day, only 1 day, and then said that the person stopped recognizing his mom and dad and went into altered sensorium. In Hindi, we call it dimagi bukhar. In English, we call it brain fever. In Hindi, they call it dimagi bukhar. In English, we call it brain fever. The question mentioned, doctor examined the patient. There was no nuchal rigidity. I mean, nuchal rigidity is absent. That tells me it cannot be meningitis. There is no meningeal irritation. So there were 3 points given in the question: fever for 1 day, altered sensorium, and absence of nuchal rigidity. Then it cannot be meningitis. It can be encephalitis. The doctor then took up this patient for MRI. MRI shows temporal lobe inflammation. The moment you read this information of brain fever and it also says temporal lobe inflammation, then you will say nuchal, then you will say this is viral encephalitis. In NEET PG, the question was slightly different because he knows ke temporal lobe se bata doge. So he said the doctor had done lumbar puncture of this patient, got it, and that showed RBCs in the CSF. This is again very, very peculiar because RBCs are normally seen in subrecurrent hemorrhage, but here I'm teaching you viral encephalitis is causing RBCs. Then the EEG of this patient. This is an INISET question. These 2 questions are INISET 1. They did not mention temporal lobe inflammation. One, they mentioned regarding CBC showing CSF showing cerebrospinal fluid showing RBCs in the CSF. Second showed PLED. What is PLED? PLED is a EEG finding. The name of the EEG finding is periodic because it is occurring again and again. Lateralized because it is occurring in the temporal lobe. Abnormal electrical discharge, that is called as epileptiform discharge. If you just look by English here, you can solve the question. Lateralized means temporal lobe. Now here on the side temporal lobe is present. So periodic, lateralized, epileptiform discharge are the hints in the question that would be present. The investigation choice for diagnosis of this condition is to perform a guarded lumbar puncture and send the sample of this patient for PCR for herpes simplex 1. So if he says that the report is available, cool, but then you're not going to wait for the report to appear for the person to be started. That is why I stated right in the beginning that empirical treatment in this patient must be started. This is the leading cause of viral encephalitis on a global basis. But now we will go to Uttar Pradesh, we will go to Gorakhpur. If he specifically mentions the state of UP, if he mentions Yogi Ji's constituency, in Yogi Ji's constituency for years altogether, there was due to, there was a nala there was like this drain there, open drain in Gorakhpur, and that drain was causing like breeding of mosquitoes, because which mosquito breeds in like dirty water or like, sewage water is Culex mosquito. So there was a huge problem of drainage, and the entire city's drainage was like, causing extensive Like now the summers have started. You would have noticed, irrespective of whichever part of India you are in at the moment, and you are listening to me, Culex mosquito. You go out in the evening for a walk, no, the mosquitoes will literally hound you. And these mosquitoes that are growing at 40 degrees Celsius are growing in sewage water, the dirty water, that is Culex mosquito. And the Culex mosquito would be causing, presence of like Japanese bee encephalitis manifestation. I mean, the name is Japanese, but it is common in India. Lymphocytic pleocytosis. Yeah, we will look at the reports also. Next slide. When we will study the next slide, we will look at the lymphocytic pleocytosis. But at the moment, the word is leading cause in the state of Uttar Pradesh, Gorakhpur would be Japanese bee encephalitis. And in these patients, there is no definitive treatment, but there is prevention available with vaccines. So I would request you to, from your PSM classes, read regarding the live and the killed vaccines available for Japanese bee encephalitis. So Culex mosquito is like the nuisance mosquito, but now we will go to Kerala. When we go to Kerala, or like this time, he will mention Siliguri. This happened in West Bengal. In this couple of months back. So Kerala outbreak and West Bengal outbreak, that is going to be Siliguri. That is where problems have occurred with respect to the Nipah virus. Nipah virus also causes development of the same thing. And how is the Nipah virus transmitted? It is transmitted by bats. In Nipah virus, what is the main cause? In Nipah virus, how is the virus transmitted? It is by consumption of fruits. How is Nipah virus transmitted? Nipah virus is transmitted by yellow 17. तो yellow fever होता है ना यार. Not talking about yellow fever at the moment. Nipah virus is due to consumption of fruits. Nipah virus is due to consumption of fruits which are contaminated with the saliva, yes, and the fecal droppings of the fruit bat. Can you tell me the scientific name of the fruit bat, please? This is consumption of fruits which are contaminated with saliva or fecal droppings of the fruit bat. Yes, guys. Can you tell me the scientific name of the fruit bat, please? Pteropus. The scientific name of the fruit bat is Pteropus. The Siliguri wala episode hua, that was due to consumption of date palm sap. The Siliguri incidents occurred because of consumption of date palm sap, which is again contaminated with the same thing, that is saliva and fecal droppings of the fruit bat. The case fatality ratio in this particular case would be 40 to 75%. Can you tell me the cause of death in Nipah virus? What is the cause of death in Nipah virus? Yes, guys, waiting for your answers here. Leading cause of death with respect to Nipah virus. Encephalitis, exactly. The topic we are studying is encephalitis only, na brain fever. The cause of death is brain fever. It causes micro infarctions in the brain. No, not encephalopathy. Not, it is encephalitis. The word is not encephalopathy, was also there in the options. It is not encephalopathy, it is encephalitis. The virus causes micro hemorrhages in the brain. So the brain tissue is damaged. Causes micro hemorrhages in the brain. So the brain tissue is affected, which is the leading cause for encephalitis in a patient. Again, we don't have any treatment for it, but vaccine has been made. Like last time when COVID occurred, then we were late in making the vaccine, almost 5-6 months and even longer went by. So that is the reason why so many people died. But now the National Institute of Virology has already made a vaccine and the serum for it. So if it spreads in India, luckily due to contamination issues, luckily due to lockdown issues in Siliguri and prior to that in Kozhikode in Kerala, they've been able to control it. But the the virus is still lurking, and if it spreads in India, then to handle it, the serum is available and the vaccine is available. So these are like the causes of viral encephalitis that I've discussed before you at the moment. Additional question to everybody here is viral meningitis. Can you tell me the virus responsible for meningitis? Viral meningitis. RBCs in the CSF. No microhemorrhages are in the brain. No RBCs in the CSF. RBCs in the CSF are present in only are present only in the first case that we discussed. That is herpes simplex. What is the leading cause of viral meningitis? Adults, children, both. Same. Can I have the answer, please? The leading cause of viral meningitis in children and adults is Enterococcus. It is no viral meningitis is enterococcus, not Nipah virus and all those things. यहाँ पे सिम्टम क्या दिए होंगे? फीवर, हेडेक, न्यूकल रिजिडिटी. The question will say lumbar puncture of the patient was done. The CSF of the patient is showing presence of lymphocytes. The sugar of the CSF will be normal. This is what I will explain to you on my next slide in detail. Sugar will be normal because viruses don't consume sugar. And the proteins in the patient would be elevated. The leading cause of यार क्रिप्टोकोकस तो फंगल होता है ना, तो वो तो एड्स में आएगा ना. That cryptococcus will be occurring in AIDS patients in immunocompromised. For viral meningitis, the organism to be remembered is Enterococcus. It will cause fever, headache, nuchal rigidity. What will be written in the question is oft repeated question FMG exam, lymphocytes present in the CSF and the sugar will be perfectly normal. The moment you read the statement sugar is normal, you know it can't be bacterial because bacteria will consume the sugar. Viruses don't consume sugar. Viruses don't use sugar for their metabolism. So it would be enterovirus, in fact, not enterococcus. Yeah. Enterovirus. Got it. Not enterococcus. It is enterovirus that would be responsible. Enteroviruses would be like Coxsackie. I get my point. I got your point. Enterovirus would be like Coxsackie B virus. Enterovirus would be like Coxsackie B virus. Yeah. The main part in this particular question is viral meningitis. And there would be fever, headache, nuchal rigidity. The main word is lymphocytosis and the sugar will be normal. Why sugar is normal is primarily because like the viruses do not consume sugar in this particular patient. So it is viral meningitis versus viral encephalitis. This is pure microbiology revisited at the moment. That is pyogenic meningitis versus viral encephalitis versus viral meningitis in a patient. Never do lumbar puncture in a patient of raised ICP. If you do lumbar puncture in a patient or raised ICP, what can happen, please? Why will the cardiorespiratory arrest occur in a patient? Yeah, proteins are elevated due to antibodies. Never do lumbar puncture in a patient or raised ICP. Can I have the answer, please? Yeah, viruses don't eat sugar, na? They utilize only, like, they don't utilize sugar for metabolism. Yeah, brain herniation. Lumbar puncture is always contraindicated in raised ICP. If a doctor by mistake will be doing lumbar puncture in a patient of brain herniation, then there is always the risk of tonsillar herniation or foraminal herniation. What I mean by tonsillar herniation is that the cerebellar tonsils will go down and they will crush the brainstem and the person will go to respiratory arrest. This happened to one of the FMG students. I think it was very close to Almaty. I think all of you are aware this happened last year in Kazakhstan. Near to Almaty, one medical student had the worst headache of his life. He actually was having berry aneurysm and this actually had burst and he suffered from very severe headache. So he went to that local Kazakh hospital. Now there they did a mistake that they did a lumbar puncture. So he was saying no also, the medical student who went with him also, he was also saying no, please don't do this. And no, your headache is very bad. If you want to get cured, they should have done a CT scan and endovascular coiling, but they didn't have that facility there. Small hospital. So, I mean, like, you are traveling internationally, you must take medical insurance. The boy did not have medical insurance. He went to that hospital, they did a lumbar puncture. The doctor by mistake, he put a lumbar puncture. He was having raised ICP because he had bled. Immediately, the moment the CSF came out, the boy who was at this along with him, he says the moment they did a LP, he went into a respiratory arrest. And after that, that he was on a ventilator and this protest was started and like nobody was helping. In fact, the contractor who had sent the student abroad, he switched off his phone. Not available. Now, they take so much money. They switched off the phone and did not even respond. And then finally they contacted him. He said, I'm in Dubai, some treatment going on. So it was very unfortunate. Finally, the government, like they sent a private jet, but you understand 50-60 lakh rupees is required for transportation. No airline will be ready to transfer. If you ever go by flight, whether business class or anything, if you are sick, they will deboard you, sir. They will just deboard you, irrespective of whether you are able to manage your own or not. Really sorry to hear that. I mean, it was very bad, guys. So the poor fellow was then airlifted. They brought him to Jaipur here, SMS Jaipur, and then unfortunately the boy died. So I'm not blaming that Kazakh hospital or I'm not blaming that resident. I'm blaming the system that if they're taking money from students, they should not be doing this. It would have cost a few $100,000 initially if they would have transported immediately if he was sick. Then things went south. So learning for you guys is at this particular moment is that if you are having any patient of raise ICP, don't put in a needle, man. Never put in a needle. The person will immediately go into a brain herniation. Lumbar puncture is absolutely contraindicated in a patient of raise ICP. There is a huge risk of tonsillar herniation. These former Soviet Union hospitals are good for spine surgery because वो gymnastics बहुत अच्छे करते थे ना पुराने वाले रशियंस, तो उनको orthopedic surgery बहुत अच्छी आती है. न्यूरो सर्जरी में there some centers are good, but medicine part is not good. They come to India for treatment. So I want to tell you, and I'm not blaming the doctor there. I mean, he would have made a mistake. He might have been a first year resident, but this can happen with any doctor. When you're suspecting a raised ICP, guys, don't put the needle. Give mannitol, give stabilization to the patient, use elective hyperventilation. I will teach you methods to control the raised ICP, but no and never put in the needle. That's the learning point at this particular point of time. Okay, chalo ji, let's move on to the next one. Let's look at what are the findings that would be present there. They charge $100. मुझे पता है why the anger is coming up. गाली क्यों लिख रहे हो? Because they charge $100, sir. 100 क्या? They are charging $500, $1,000 from students on the name of medical insurance. $1,000, $500, depending on the university. I mean, it's so bad, right? That at least कोई बीमार हो गया यार, उसके साथ नहीं करना चाहिए ऐसे, right? I mean, बाकी सब ठीक है यार. I understand everybody is into business and everybody wants to make money, but then if somebody is sick, then assistance should come. चलो, crazy. Findings of lumbar puncture in this particular case is normal. That would be like the normal CSF findings are 0 to 5 lymphocytes. Sorry, I got carried away. थोड़ा सा हो ही जाता है यार. मतलब इंडियंस के साथ में ना एक्चुअली होता है, इंडियन का दुश्मन इंडियन है. वेदर यू आर इन इंडिया, वेदर यू आर अब्रॉड, इंडियन डॉक्टर का और खासकर डॉक्टर का और मेडिकल स्टूडेंट का दुश्मन इंडियन है. आप इंडिया में देख लो, राइट, हर डॉक्टर दूसरे डॉक्टर को गाली देता है. दैट इज वाई द पेशेंट्स आर टेकिंग एडवांटेज. अरे यार, ये तो एमबीबीएस है, ये तो फलाना है, ये तो फलाना है. अरे मतलब यू हैव यू एवर सीन अ उबर ड्राइवर क्रिटिसाइजिंग एन अदर उबर ड्राइवर? You cancel a Uber ride, the next Uber ride, suppose you are going to the airport, it was 1,000 rupees, you cancel that ride, the next ride will be 1,200. You cancel that, it will be 1,500. It's an organized racket going on. If you refuse one auto rickshaw driver, no auto rickshaw driver will take you. Whether it is electrician, whether it is an auto rickshaw driver, they have so much of unity that you refuse work to one of them, 10 other people will refuse you. And here we have doctors, उससे अरे कहाँ चले गए, किसके पास इलाज कराने चले गए, एक दूसरे को क्रिटिसाइज करते रहते. इट इज सो बैड सर, इट इज सो बैड. ओके, चलो लेट्स बी मूविंग ऑन. 0 to 5 lymphocytes is the normal scenario that is present. As far as the sugar in the CSF is concerned, it would be 2/3 of the value of the blood sugar. Like if the blood sugar is 100 at the moment, then your CSF sugar will be 66. 66. नहीं यार, यूनाइटेड तो मैं क्या नहीं रहा, गाली तो मत दो यार ओपन एक दूसरे के सामने. दैट्स द पॉइंट. डोंट क्रिटिसाइज वन डॉक्टर इन फ्रंट ऑफ द अदर. दैट इज व्हाट इज हैपनिंग. I understand everybody has an ego, everybody thinks he's a superman, he's the best doctor, not a problem, but at least don't go on social media, criticize doctors. And chalo, coming back, sugar is 2/3 of the blood sugar, protein is 15 to 45 milligram. Why I'm telling you these values is because they will give you a question, 1 to 2 questions, whether FMG or NEET PG always come on the lumbar puncture findings of various types of CNS infections in a patient. Then the point is 15 to 45 milligram per deciliter. The opening pressure, you guys should speak here. Okay, please comment. What is the normal CSF pressure in the brain? What is the normal pressure in the brain? When do you say raise ICP, guys? What is the opening pressure? Na? A manometer लगाए ना पीछे. When you put in a manometer, you have to evaluate what is the normal pressure. Yep, 10 to 20. Normal pressure is 10 to 20 millimeters of mercury. The color will be totally clear. In some MCQs, the units will be written as 15 to 180. 50 to 180 millimeters of water. Not centimeter of water, millimeter of water. I think I've been able to explain to you normal pressure in the brain is 10 to 20. Anything more than 20 is raised ICP. Anything more than 180 is raised ICP, and the color will be clear. This is normal findings. Now we will compare these findings with that of acute bacterial meningitis, which is also called as pyogenic meningitis, which is caused by strep pneumonia in adults and children, and for newborn babies it is agalactia. In this condition, more than 1000 neutrophils per cubic millimeter can be present. The bacteria will consume the sugar, so sugar will become low. And because the bacteria will produce antibodies, because antibodies will be produced, so therefore the proteins values will begin to rise, and also the pressure in the brain will begin to rise, because anyway, like there would be inhibition of absorption of CSF by the pus. The pus in meningitis is very thick. So the thick pus in meningitis, it blocks the reabsorption of the CSF, and that's the reason why the pressure is relatively more. Now I will compare this with tubercular meningitis. In tubercular meningitis, he will begin by describing AIDS positive patient, or he might say that this is a malnourished patient, PEM grade 4. Immunity is less. The number of cells which are present here will be usually more than 100 going up to 1000. But this time he will say lymphocytes that are present. He will always say the word lymphocytes that are present, because TB is a chronic infection. So it will not be polymorphonuclear cells. It will be lymphocytes that would be present. And because it is a bacteria, so it will consume the sugar. Proteins will be elevated. The proteins may be elevated very, very significantly. In some questions, it was NEET PG that they had given a CSF sample. I will show you that NEET PG question report also. They had given a sample in which the protein plug was visible in the lower part of the tube. This is NEET PG 2023. There was an image given of a protein plug that was present in the tube. We call it cobweb coagulum. This cobweb coagulum is the protein plug that is present because of the high concentration of proteins that are present. And anyway, in TB meningitis also, the protein values would be elevated. Don't rely on color. You will notice here also did not say anything. Turbid, cloudy, clear straw. Colors are never ever reliable. Guys, colors are never ever reliable for evaluating any kind of CSF findings. So don't even waste your time checking out the color. What you are supposed to figure out is what is happening to the cells, sugar and the protein. Sugar will be less in both of them. Proteins will be elevated, more elevated in TBM if they give you protein value of more than 1 gram. Always think in gram, right? If they give you a protein value which is in grams, then always think in terms of tubercular meningitis. Substantially, outrageously high proteins are seen in only one, that is tubercular meningitis. For pyogenic meningitis, you will give 2 antibiotics, ceftriaxone, vancomycin. For TBM, obviously, you will give anti-tubercular treatment for this patient. For pyogenic meningitis, antibiotics we have discussed already, na? Antibiotic name फिर से लिख देता हूँ यहाँ पे. The antibiotic that we give for this particular case is ceftriaxone. Along with that is vancomycin. And suppose if I add the word alcoholic to this patient, or I add less immunity due to steroids, due to transplantation, whatever, then the third antibiotic that will be given is to give coverage for listeria, that is ampicillin. Already explained to you, empirical treatment should be started even before the culture report will come. TBM, obviously, ATT has to be given even before the TB-NAT report will come. You can still start the treatment. You can still start the treatment even before the report is pending. Then is viral meningitis. The report of viral meningitis and report of viral encephalitis is the same. The report of viral meningitis and the report of viral encephalitis is the same. The number of lymphocytes here will be in the ratio 25 to 100. The number of lymphocytes will be 25 to 100. Don't rely on number, it is lymphocytes. Now the query of students is कि sir आपने बोला था 100 are present in TB and 100 are present in viral meningitis. How in the paper will we differentiate? The differentiation will be based on not the number of lymphocytes but on the sugar value. I have already sensitized you guys to this fact. I have already highlighted this fact that viruses do not use sugar for their metabolism. It is bacteria that utilize sugar for their metabolism. So the sugar values will always be normal. A very standard question off and on that is repeated. Sugar is normal with 100 lymphocytes. The learning at this point of time, if I hold the discussion for a few seconds, is that in an Indian exam, if they will give you lymphocytes, it can either be TB, it can either be viral meningitis or encephalitis. Don't rely only on lymphocytes. Check out the sugar. If it is low with outrageously high proteins, it's TB. If it is gonna be normal with slight elevation of the proteins, then we will say viral meningoencephalitis or viral meningitis. And because here also exudate is present, the exudate will basically interrupt the absorption. The exudate will interrupt the absorption of the CSF from the subaqueous granulations. So therefore, even in this condition, the protein values would be elevated. So as such, protein elevation is a uniform thing. Protein values are elevated in all of them, but then the main thing is the normal sugar value that I explained, and even the pressure will go elevated in this patient. So let me just use appropriate font sizes there. Yep. What you have noticed is that the report of TBM and the report of viral meningitis can be causing errors in the mind of students because lymphocyte is written in both of them. So I try to introduce differentials. And another thing I want to say is what I have also said is that duration of history can be different because in TB it will be a long-standing illness like 3-4 weeks of weight loss, evening rise or temperature like that. And viral meningitis will be 2-3 days illness. So one here I can okay, let me write here the history will be spanning over weeks. And in viral meningitis or encephalitis, the history will be spanning over a couple of days. So this is a quick table where I mentioned regarding the cell, sugar, protein, opening pressure and color. And at least one question on the 3 is always asked. They keep on changing, sometimes ABM, sometimes TBM, sometimes viral meningitis. So I would rate this as a super important table for today from the pure medicine perspective, because prior to this what I've said is taught in other subjects also. Now I will be discussing that NEET PG question that came. He said 7-year-old child has been sick for 4 weeks. You can see 4 weeks with persistent fever, headache, irritability, vomiting, headache and neck stiffness. So a lot of things were given, especially the fact that there is a fever, there is a headache and nuchal stiffness. That tells me that the triad of meningitis is getting satisfied. The mother is saying for 1 day the child is in altered sensorium and is not recognizing the mother. वो बच्चे को जोर जोर से हिला रही है, कह रही देखो डॉक्टर साहब, the child is not opening his eyes. You are noticing the pressure in the brain is elevated, the proteins are elevated, glucose is low. The normal CSF glucose values, will always be in a range of more than 0.6. कोई health issues तो नहीं है ना? Which standing? Guys, just give me a second, just urgent. Hello? Okay guys, sorry for the interruption. This was crazy. Okay, getting back to focus on. So normal CSF glucose values are always more than 0.6. In this MCQs, the values are 35 divided by 100. Like the patient's sugar value is 35 and the total value of the 100 value is 100. So I can say the CSF glucose ratio of this particular patient is about 0.3. Let me repeat this once again. Normal CSF glucose of a patient is equal to or more than 0.6. Like I was saying, 2/3 of the blood sugar, that is 66%. So 0.6 is the normal value. Here it was 0.3. The lymphocytes were elevated, and obviously, like since I've already sensitized, you see, because it is a PYQ, it looks very, very simple. But when this question came first time, guys were like totally zapped. Ki sir, CSF was clear. but the protein plug was at the bottom, and then obviously you can see the Zn stain where you can see the red bacilli which are present. So I know that you know the answer to this question is very simple, that is tubercular meningitis. Because it is a PYQ, it is looking simple, but yeah, I think at that point of time people were having difficulty in being able to identify this. So I have a question for you guys now, that for this particular patient, what will be the investigational choice? Obviously, we will be doing a lumbar puncture, we will be doing a CSF examination of the patient. What is the investigation choice for this patient? The investigation choice would be CSF CBNAT. That is cartridge-based nucleic acid amplification technology. It is CSF CBNAT for Mycobacterium tuberculosis that would be done in this patient. The report will be coming in the next 24 hours. We can also be doing is a CSF culture for this patient. For the CSF culture, he has asked the name of the liquid culture that we are using. The solid culture that we use for this condition, we anyway know the solid culture is Zn stain. So he asked specifically what is the liquid culture that we will use for this patient, that is called as Middlebrooks medium. The liquid culture that we will be using for this patient is Middlebrooks media. The report will take at least 48 hours to come. You can see that we will always select one where like the report will come early. So CSF CBNAT for Mycobacterium tuberculosis is what is recommended, and otherwise like the Middlebrooks media is another approach that we are having for identification of this condition as well. And once the diagnosis is made, we will start anti-tubercular treatment. You can hit the comment button. Will you give ATT for 6 months or will you give for 1 year? I would expect you to hit the comment button immediately. This is a case of extra pulmonary TB. Yesterday I taught you tubercular pericarditis, extra pulmonary TB, 1 year. Here also we will give ATT to the patient, but will the duration be 6 months or 1 year? I have already discussed with you, it will be 12 months. And along with this, we will also give steroids. We will also give steroids. The steroids that we will be using is Dexona, that is dexamethasone. These steroids will be given, however, for only 6 weeks. The steroids in this patient will be given for only 6 weeks, and then we will taper the dose of steroids. We will be giving steroids. Why? Because they will reduce the swelling in the brain. In patients who are having tubercular meningitis, there is a very significant risk of development of seizures because there is a swelling due to inflammation. It's a long-standing inflammation. So if he asks you what is the reason why the doctor will be giving Dexona to the patient, then the Dexona will be given because we want to reduce the vasogenic cerebral edema. It is the local swelling. TB is a chronic slow infection, so the brain tissues will swell up, and that increases the risk of it increases the risk of seizures also. So the reason why we give steroids, because this is where like the normal medical college teaching is don't give steroids in infection. The normal medical teaching is don't give steroids in infection. But in this case, you will be giving steroids. Why will you be giving steroids? Because you want to go bypass the medical knowledge information, routine medical college information, not for like an ego, but because you want to reduce the vasogenic cerebral edema. That is why dexamethasone is given. It will reduce the local swelling. Now comes couple of examination findings which are to be evaluated because patients are in altered sensorium. So nuchal rigidity lots of time may not be elicited. Like nuchal rigidity, you will ask the patient, please flex your neck like this so that I can please flex your neck like this so that your neck touches the chest. So if this kind of an activity I'm talking about, that is like, this is voluntary activity. If somebody is unconscious, somebody is altered sensorium, they can't do this activity. So what you will do in the patient is, the doctor in this particular case is doing extension of the knee joint of the patient. Like he's keeping one hand on the knee, one hand under the ankle, and you are extending the knee and you are causing stretching of the hamstring muscle, which is already in spasm due to meningitis. In this particular patient, though I have already had answers from all the students, all of you are right, there is an extension of the knee joint that is being done. When you will be doing extension of the knee joint of the patient, you are causing stretching of the hamstring muscle, and the hamstring muscle is already in spasm. When you stretch the hamstring muscle in spasm, it will cause a change in the facial expression in the patient. The patient will wince with pain. The patient will wince in pain, though the patient is unconscious. Person will not open his eyes and say, oh, it's hurting. He will just wince with pain. So the change in the facial expression is what the doctor is noticing. You can see eyes of the doctor are fixated on the face of the patient. The doctor is doing an extension of the knee joint, and this is what is technically called as Kernig sign. In Kernig sign, K and E alphabet are to be remembered. K would be the knee joint and E is the extension. If you just pick up the two alphabets here, knee joint extension being done, this is sorted. You don't need to remember the whole thing. You don't need to remember the whole thing. Just remember Kernig sign is extension of the knee joint that will cause the patient to wince with pain. The eyes of the patient will be fixated. The eyes of the doctor will be fixated on the face of the patient to check for that facial expression. Now we come to the right hand side. Here what the doctor is doing is he is doing assisted neck flexion. She is doing a assisted neck flexion, like she is keeping her hand behind the neck. गर्दन के पीछे हाथ रख के उसका गर्दन ऐसे आगे कर रही है. So there is a assisted neck flexion, and when you are doing assisted neck flexion, it is causing a involuntary. When you are doing assisted neck flexion, it is causing a involuntary hip joint as well as a involuntary knee joint flexion. HJ stands for hip joint, KJ stands for the knee joint. It is an involuntary hip joint and a knee joint flexion that is happening. Check out the body of the patient. It's like totally suddenly hips flex away. So that's gonna be called as Brudzinski sign. So I don't think so that they will ask Brudzinski also, because here you can see everything is flexion, flexion, flexion. There is a assisted neck flexion. This is causing an involuntary hip joint and a knee joint flexion. So the moment you read this word Brudzinski sign, it tells you the fact that there is a meningitis aspect which you are suspecting in a patient. So there are two images that are given. Image number A is called as Kernig sign. How to remember? KE alphabet. Kernig sign, knee joint extension, as you can see. In Brudzinski, it is flexion, flexion, flexion. Assisted neck flexion causing hip flexion as well as knee joint flexion. So there are two images which are shown here. These are specially reliable for those patients who cannot communicate. You know, in nuchal rigidity, you have to say flex your neck so that your chin touches the chest. So conscious patient can tell, but unconscious patient will not be able to do. So yep, like neck wala and the knee joint wala. So it's pretty easy to identify. Both of them that I've explained to you, are signs of meningeal irritation. Today I have taught you three signs of meningeal irritation. The three signs of meningeal irritation. The three signs of meningeal irritation that I have currently explained to you. Three signs of meningeal irritation that I have currently explained to you are: one is Kernig sign, second is Brudzinski sign, and one is the nuchal rigidity component. Nuchal rigidity requires cooperation on the part of the patient. So the description that has been given here is for tubercular meningitis. And now we come to obviously the standard question, which is cryptococcal meningitis. HIV positive truck driver comes with fever and headache for past 3 days. There's photophobia, cannot drive. There's a nuchal rigidity with fundus examination, and then he's given a lot of photographs here that I'll discuss with you one by one. Question for everybody, whether you are an FMG student, whether you are NEET PG question student, tell me the investigation choice for cryptococcal meningitis. Yes, guys. Waiting for your answers here. I would like everybody to participate because this is taught very extensively in microbiology as well as in pathology. What is the investigation choice? And if I give options, then obviously it will become relatively easier for you. So I'm waiting for your answers. Okay, CT head. Very good. More people, please. ELISA coming up. MRI coming up. Okay, India Inc coming up. Okay, CSF negative staining, India Inc. CT head, contrast. More people, please. India Inc is not the best way. India Inc is not the best way. Sir, India Inc is not reliable. India Inc method is a background stain. You have to check out the quality of the stain. The technician who has used the staining, if it is of ghatia quality, you will not be having a proper slide. So you will report it as negative though the infection is present. Yes, you have to go for CSF ELISA in a patient. The technical answer, which I think nobody has answered at the moment. So I'll wait another few. Yes, Sairaj was the first one. Dr. Sairaj Mane was the first one to comment on that. CSF lateral flow assay. The main investigation for diagnosis of this condition is it's a ELISA format only that we're doing. It's not that CSF ELISA is wrong. Go with you are right. But the technical word is Sairaj Mane has answered it very rightly. It is a CSF lateral flow assay, which is the best test for diagnosis of this condition. If the patient is not ready for lumbar puncture, you can be doing the lateral flow assay on the urine sample also in the NEET PG. When this question came, CSF was not in the options. If CSF is not in the options, your next answer is urine. The point is there is a dissemination of infection in the body. Guys, it's a infection that is disseminated because the immunity is lesser. So lateral flow assay is the gold standard is the main investigation that should be done for this patient. I can call it a gold standard investigation recommended. And because the because the fungus has disseminated all over, so that is why, like even in the urine, because it is present in the blood, from blood it went in the brain and it will come in the urine also. So either CSF or urine can be present. So especially when you're doing multiple choice questions, don't be surprised if there is no LP and the answer is urine. When you do questions, don't be shocked when the answer is urine, because there is a dissemination, sir. There is a hematogenous dissemination of the organism. So that's the main thing that is to be remembered. If he says, what is the first investigation to be done? Question open to everybody, especially NEET PG aspirants. What is the first investigation to be done? Read the question carefully. Immunocompromised patient, there is a papilledema. What is the first investigation to be done in this patient? The answer is not lumbar puncture, not a India ink preparation. Most students को पैथो के क्लास अटेंड करने के बाद में ऐसा लगता है कि इंडिया इंक मेथड इज द बेस्ट वे फॉर डायग्नोसिस ऑफ दिस कंडीशन. इट इज द लीस्ट वे accurate way of diagnosis of this patient. Sir, the first investigation is neuro imaging. अगर पैपिलोडेमा प्रेजेंट है तो आगे आपको न्यूरो इमेजिंग करके डेमोन्स्ट्रेट करना है ना. एमआरआई कर सकते हैं, सीटी स्कैन कर सकते हैं. सो व्हाट आई वांट टू से एट दिस मोमेंट इज, आई विल मूव बैक इन द स्लाइड. यू डोंट नीड टू, डोंट चेंज योर स्लाइड. keep your eyes on the board. keep your eyes on the board. I want you to remember pin fan. अभी आप देखते रहो, बाद में मैं नोट करा दूंगा. I want you to at the moment listen to my words here. The words at the moment are pin fan, PINFAN. सारा तो याद हो नहीं सकता, पर पिन तो याद कर लेना चाहिए. अगर पैपिलोडेमा लिखा है सवाल में, इम्यूनो कॉम्प्रोमाइज स्टेट लिखा है सवाल में, न्यू ऑनसेट सीजर्स लिखा है, पिन. पैपिलोडेमा कॉम्प्रोमाइज स्टेट, न्यू ऑनसेट सीजर्स. फिर because there is physical damage like TB can cause damage, so focal neurological deficit, altered sensorium or cancer. फैन अगर आज के लिए नहीं भी याद हुआ चलेगा, but what you not supposed to forget for your paper is, if you read a question that specifically mentions PIN, papilledema, immunocompromised state, new onset seizures in a person who's having suspected CNS infection, don't answer lumbar puncture. You will immediately have a brain herniation. यू कैन डू सीटी, यू कैन डू एमआरआई, जिसकी भी सुविधा हो. जैसे सीटी स्कैन बहुत फास्ट होता है, एमआरआई करने में टाइम लगता है. द पॉइंट इज द निमोनिक टू बी रिमेंबर्ड. पूरे 6 अल्फाबेट एक साथ मत याद करना. फॉर टुडे रिमेंबर PIN, and then maybe tomorrow when you read it, please turn back the page, please come to page number 51, please come to page number 51 everybody, and do this marking at the moment, pin fan. For today the pin word is to be remembered, papilledema, immunocompromised state, new onset seizures in a patient. If any one of these is positive, इसके आगे लिखना, if any one positive, what are you supposed to do? Lumbar puncture is not to be done. Patient will develop coning of the brain as we casually cause. We get a transtentorial, we can get a tonsillar herniation and the patient will die. The perform neuroimaging is the first answer if any one of the following is present. Papilledema, immunocompromised and new onset seizures. I would also like to reiterate the statement that after attending a patho in a micro class, because obviously पैथोलॉजिस्ट को और माइक्रोबायोलॉजी को तो स्टेन्स के बारे में बताना होता है, तो स्टूडेंट्स को इंप्रेशन ये जाता है कि इंडिया इंक लिखा है तो मतलब क्रिप्टोकोकस है. भाई इंडिया इंक प्रिपरेशन कैन बी इवन न्यूमोकोकस. So it is not India ink stain that will help in diagnosis. Going back to the original place, this is why in this patient first I did a MRI, क्योंकि अगर ventricles dilated है ना तो मैं पहले इसको मैनिटॉल दे दूंगा. I will decrease the pressure in the brain, and MRI head की finding भी लिख लेते हैं, which you can seen at this patient. The MRI finding is also called as soap bubble appearance. So there are two things I want to check out. One is the soap bubble appearance, and second I can see dilated ventricles, because हम ventricle का size तो measure कर सकते हैं ना MRI से. अगर pressure बढ़ा हुआ है तो raise ICP है तो आप needle डालते gush of CSF. What happened with that boy? Same thing, that sudden gush of CSF will cause a brain herniation in this patient. Yes, that's what I'm saying बेटा. वही तभी मैं highlight कर रहा हूँ कि इंडिया इंक स्टेन इतना दिमाग में बैठ जाता है कि लगता है बस क्रिप्टोकोकस की सारी दुनिया जो है ना इंडिया इंक के पीछे चलती है, जबकि एक्चुअल हु इज द गाय हु इज रनिंग द शो, लैटरल फ्लो ऐसे. इंडिया इंक इज द इंप्रेशन दैट वी गेट. अब एक और क्वेश्चन पूछता हूँ स्टेन वाला. ये पर्पल वाला स्टेन है, इसमें वो क्रिप्टोकोकस दिखाई दे रहा है, पर पिंक स्टेन है जो कि कैप्सूल को स्टेन करता है, कैप्सूल को स्टेन करता है ऑफ क्रिप्टोकोकस. कई जगह पर अच्छा स्टेन हुआ तो पर्पल दिखाई दे रहा है, वरना लाइट पर्पल दिखाई दे रहा है. सो कैन यू टेल मी द नेम ऑफ द स्टेन? या giant cell tumor. Pranav, you have a good point. So bubble appearance also in aneurysmal bone cyst and giant cell tumor. Specific answer, giant cell tumor. Yes guys, tell me the stain for the capsule. This is not a positive stain for the capsule. Very good. Mucicarmine. So what I want to say is कि जैसे mucicarmine से ना most doctors को apathy सी होती है. Like mucicarmine, everybody remembers, but you tend to have subconsciously an apathy. अच्छा हाँ ठीक है होता होगा. A negative stain, everybody has a very soft feeling for it. अरे नहीं इंडिया इंक लिखा है. So what I'm trying to say is the kind of apathy that you have mucicarmine, they exhibit the same apathy now from now onwards to India Inc. and develop that wow factor for lateral flow assay. That's the main game thing that they're trying to ask in the question. क्योंकि उसको पता है कि हम किस चीज की तरफ बायस हो जाएंगे. नाम इतना करेक्टरिस्टिक है ना, काले रंग की स्लाइड दिखाई दे रही है, कैप्सूलेटेड ऑर्गेनिज्म दिखाई दे रहा है, नेगेटिव स्टेन है, तो लाइक अवर आईज टेंड टू फोकस ऑन द फर्स्ट इमेज ओनली. तो इट इज lateral flow assay that is to be used, and then we will do a guarded lumbar puncture with CSF cytology. In CSF cytology, what will be present here? So the findings will be like this. Here also lymphocytes will be present. तो मुझे पूरा लिखने की जरूरत नहीं है. Lymphocytes plus plus. This is the third time that the lymphocytes have been told to be elevated. First was TB, second was viral, and now is fungal. But then in this patient, it is sugar that will become relatively lesser. It is the sugar that will become lesser. Sugar was normal in viral meningitis, but sugar will be reduced. Now we will check out the proteins. The proteins in this case would be elevated. I hope you will agree with me that if I just say this much of report to you, lymphocytes, sugar low and protein elevated, this can be seen in TB also. If you check out this report, this can be seen in TB also, but the history will be a giveaway because here it will be a short duration. HIV positive patient में तो TB meningitis भी होता है, but the history will be giveaway. It is simply like the presentation of tuberculosis, but at the same time in this case it would be a shorter history, like 3 days का history लिखा हुआ होगा. So when you read the lumbar puncture report, that will again be a distraction in the question. Just like India Inc was a distraction, similarly here it is past 3 days, and then comes the ore issue, like what is the blood work that we are doing, that is urine or blood lateral flow assay for antigenic detection. We can check it on any body fluid. CSF is preferred, then can be urine, we can do it on the blood. And the treatment for this condition was asked in last time's FMG exam, that is amphotericin B with 5-flucytosine would be given to these patients. This would be intravenously for 2 weeks. On discharge in this patient, we will be giving oral fluconazole. Oral fluconazole is being given for, please comment in the chat box, NEET PG aspirants, please tell me. For how long should fluconazole be given? Prophylaxis, secondary prophylaxis. This is a NEET PG question. Secondary prophylaxis because already उसको cryptococcus हो चुका है ना एक बार. For secondary prophylaxis of cryptococcal meningitis, oral fluconazole will be given for how long? Your answer according to the NACO and Harrison guidelines are oral fluconazole will be given for 12 months, 1 year. Second, he has asked CD4 count should be more than how much? Then it should be more than 100 cells. The third point to be remembered is PCR needs to be done for HIV RNA. The PCR HIV RNA should be less than 500 copies per cubic millimeter. If you are an FMG aspirant, इस सवाल को छोड़ देना. This was a NEET PG question. Oral fluconazole secondary prophylaxis is given till, answer is 1 year with CD4 count more than 100. मतलब एक साल तक अगर CD4 count 100 के ऊपर रहे, for 1 year, if the CD4 count of the patient remains or more than 100 and the copies are less than 500, then you will say that this is where I will stop. The older guidelines were, यहाँ पे आपको ध्यान हो, अगर आपने मेरा रूटीन वीडियो देखा हो तो उसमें मैंने जो पुराने गाइडलाइंस बोले हैं उसमें मैंने बोला है 10 weeks. इसको मैं लिख के हटा रहा हूँ. In the older guidelines I've said 10 weeks. No, it is not any one of them, man. Older guidelines are 10 weeks, 12 weeks लिखा होता था. Now it is 12 months. एक साल खिलाना है, because दोबारा से हो जाता है. So secondary prophylaxis is, it is not whichever is later out of the 3. All ना एक साल के लिए if CD4 count is constantly, otherwise I will continue indefinitely. CD4 count, ART therapy needs to be continued in the patient. No, it will be started after at least 6 to 8 weeks because there can be risk of iris. अभी चलो iris लिख दूंगा अभी. No, don't give ART at this particular phase. No, you will not give ART at this point of time. At least first few weeks I will not give ART. At least 4 weeks के बाद में, 1 महीने के बाद में, वरना iris हो जाएगा. So antiretroviral therapy would be given in the patient. Agree to that. But continue the prophylaxis when CD4 count is continuously more than 100 for 12 months and PCR HIV RNA copies are less than 500 per cubic millimeter. Yes. 12 months देना है और साथ में CD4 count कम होना चाहिए. Right? This is to prevent reinfection in the patient. Liposomal amphotericin in FMJ एग्जाम को सिंपल पूछा, व्हाट इज द इनिशियल ट्रीटमेंट इन योर FMJ एग्जाम गाइस. आप इसका वरी नहीं करो, आपको सिर्फ सिंपल सा पूछा व्हाट इज द इनिशियल ट्रीटमेंट फॉर दिस पेशेंट, खत्म. और वहां पे उसको पता है कि यार ये तो पढ़ लिया, कंपटीशन है ना यार, वहां तो वो सीट दे रहा है ना भाई आपको, तो कंपटीशन क्रिएट करेगा ना, तो कह रहा है भाई ठीक है यार सीट चाहिए तो थोड़ा टेक्निकल और बता दो सारा वाला. तो फॉर द सेकेंडरी प्रोफिलैक्सिस इन दिस पर्सन it would be like for 1 year that we are aggressively managing the patient and we need to ensure a low CD4 count in this patient. So the treatment is fairly long and then is obviously the aspect of route of acquiring the infection. HIV का नहीं पूछ रहा कि उसे कैसे हुआ हो, तो सेक्सुअल कॉन्टैक्ट ब्लड ट्रांसफ्यूजन होगा. हाउ डिड ही एक्वायर दिस इन्फेक्शन देन. यस गाइस, यशिका रिपीट विच वन. अच्छा मैं बोल देता हूँ, चलो अगला सवाल का आंसर भी लिखना फिर, ठीक है. हाउ डिड ही गेट दिस इन्फेक्शन, आयरिस बोल दूंगा. ओरल फ्लूकोनाजोल 1 साल के लिए देना है. राइट, द रीजन वाई वी आर डूइंग दिस इज प्राइमरली बिकॉज ऑफ द फैक्ट दैट there's a high risk of reinfection. So for 1 year, and for 1 year like you need to document every year, every month we'll get CD4 count done. So CD4 count should show an increasing trend ना, because CD4 count जैसे जैसे कम होता जाता है वैसे opportunistic infection होते हैं. So if the CD4 count in the patient is more than 100 and PCR RNA copies are less than 500 for 1 year, we'll stop the treatment. Yes, पहले 2 हफ्ते के लिए एडमिट करके देंगे. बस पहले 2 हफ्ते के लिए आप पेशेंट को भर्ती कर लो और भर्ती करके IV उसको एंटीबायोटिक दे दिए, एम्फोटेरिसिन B, 5-flucytosine. On discharge, oral fluconazole is given. How long will you continue the fluconazole? At least for 1 year, and then would be CD4 count साथ में मॉनिटर करते रहेंगे, PCR HIV RNA करते रहेंगे. हाँ जी. Yes guys, NEET PG aspirants, can I have a better answer than pigeon droppings जो आपसे पूछा है माइक्रोबायोलॉजी. पिजन ड्रॉपिंग्स इनहेलेशन तो बहुत पुराना क्वेश्चन हो गया ना यार, वो तो सबने आंसर कर लिया था. अभी रिसेंटली जो उसने पूछा था उसमें क्या पूछा था उसने, एक ट्री का जो बार्क होता है जिसमें ये फंगस मिल रहा होता है, ट्री बार्क, यूकेलिप्टस. पॉइंट नंबर 2 इज अगेन फॉर दोज नीट पीजी इनिसेंट एस्पिरेंट्स. क्रिप्टोकोकस जो है ना भाई, उसको अच्छे से पढ़ना है माइक्रोबायोलॉजी से, फिर पैथो से, और फिर मेरे वाले पॉइंट्स को समराइज करना. इनमें से अगर एक भी क्वेश्चन तुम्हारा, एक भी पॉइंट जो मैंने बोला ना, आप बोलते हो कि सर मेरे को ना थोड़ा सा ना डाउट हो रहा था ना, जैसे सोप बबल वगैरह में तो दिक्कत नहीं. इफ यू से कि सर मैं आई वाज नॉट अवेयर ऑफ द फैक्ट दैट लैटरल फ्लो ऐसे इज द आंसर टू बी गिवन, आई वाज थिंकिंग इंडिया, मैं एग्जांपल बोल रहा हूँ, हो सकता है यू वर राइट. लाइक इसमें अगर एक में भी आपको लग रहा था ना, तो आपने क्या करना है, refresh the data first of micro then of patho and then come back and listen to the data that I highlighted here before you. क्योंकि क्रिप्टोकोकस में ना वो आपके मतलब लिटरली कहते हैं ना जान निचोड़ रहा है. इफ यूर नीट पीजी एस्पिरेंट तो इस पे क्वेश्चन आना ही आना है. और अब वो क्या करेगा, क्योंकि रूटीन तो सबने पढ़ लिया, तो रेयर से फैक्ट्स पढ़ रहा है. सो इफ यू आर अ सीरियस, when do we start CD? Sir, we do it regularly in AIDS positive patients. Any patient with opportunistic infection in AIDS, you have to do CD4 count, sir. This is an opportunistic infection, na? So when he will come, I will do CD4 count in the patient. I'll keep on monitoring it. They should be more than 100 to prevent the recurrence in a patient. I need to demonstrate for 1 year that the value is more than this. Okay जी, तो खिचड़ी तो बनती है यार हमारे दिमाग में. Secondary prophylaxis, okay. So what we need to do in this patient is, guys, we need to okay, so what we need to do in this particular patient is, and like I can say that tubercular meningitis and cryptococcal meningitis are like the favorites, right? They are the favorites. So give me a second. Yeah. So I'll repeat the treatment once again. हम क्या करते हैं, CD4 काउंट एडमिशन पे कर लिया, डिस्चार्ज पे भी कर लिया. अब पेशेंट आया, कह रहे सर कब स्टॉप करना है, से इन हिंदी फर्स्ट. पेशेंट सेइंग सर व्हेन विल इट बी स्टॉप्ड. अल्सर अभी तो खाता रहे और हर महीने या हर 3 महीने पे आता रही हो, CD4 काउंट चेक करते रहेंगे. अगर ये सारी चीजें डॉक्यूमेंट हो गई, 1 ईयर तक दवाई खा रहा है, CD4 count all the 1 year more than 100 and PCR count is less than 500, then we will discontinue, other way we will continue the treatment in this patient. So that's the statement. मैं इसमें ना हैरिसन का स्नैपशॉट भी ऐड कर दूंगा so that you can refer to it subsequently. Okay जी. Cryptococcus infection is spread by eucalyptus tree. हाँ जी हाँ जी हाँ जी. Irrespective of the CD4 count, we will give fluconazole. No man, it's a combination. I mean, एक मिनट. Let's do this again. Do you mean that CD4 count will be normal and you will have opportunistic infection? CD4 count तो less होगा ना. When patient came, CD4 count would have been less than 100. तभी तो ये opportunistic infection होता है. Equal to 100 या less than 100 पे this infection comes. So you have to ensure that the value will be more. When patient came, CD4 count normal थोड़ी ना था, कोई 500 थोड़ी ना था, 600 थोड़ी ना था. If it was normal, then you can't have cryptococcus. He came to you with a low infection. Second thing which was came up, CD4 count would have been low ना, तभी तो हुआ होगा. चलो, क्योंकि आंसर्स थोड़े से वेवर्ड थे. CD4 काउंट लेस देन, भूल गए हो. CD4 काउंट इज लेस देन 500 तो टीबी होने की संभावना होती है. अगर 200 से कम होता है तो जीरो वेसी होता है. ऑल एफएमजी एस्पिरेंट्स असेंबल. CD4 काउंट लेस देन 100 होता है तो 2 इन्फेक्शंस कैन अकर. वन इज क्रिप्टोकोकल मेनिंजाइटिस विच आई हैव एक्सप्लेन टू यू. सो जब ये वैल्यू कम होती है तभी तो पेशेंट को क्रिप्टोकोकस होता है. ऐसे थोड़ी ना बैठे बैठे क्रिप्टोकोकस इन्फेक्शन हो जाएगा. तो जब वो आएगा तो उसका काउंट 50 में है, 100 में. आप जब उसको दवाई दोगे तो काउंट अपने आप से बढ़ना शुरू हो जाएगा बिकॉज यू किलिंग द फंगस. तो धीरे धीरे वो बढ़ जाएगा. तो 1 साल के लिए डॉक्यूमेंटेड अगर वो मोर देन 100 रहता है तब स्टॉप करेंगे. Yeah, Kaposi at less than 500. That was an FMG exam question. Good, आपने बोल दिया. Yes, all FMG Avengers, have you assembled? I have a question for you. All FMG assemblers, I hope you have assembled. I have a question for you. Question comes now. Begins with a C. Which, ध्यान से सुनना, which CNS infection in AIDS patients causes seizures? Cryptococcus neoformans does not cause seizures, it causes meningitis. Which CNS infection begins with a C would contribute to development of seizures in a AIDS positive patient? Hit the comment button. बेटा CMV रेटिन, आप खुद लिख रहे हो CMV रेटिनाइटिस, तो उससे सीजर होंगे क्या? See, this is the mind game. This is the mind game. मैंने सी बोला तो आपने बोल दिया CMV रेटिनाइटिस, और फिर आप खुद ही बोल रहे हो कि सर रेटिनाइटिस है. मैंने तो नहीं बोला ना रेटिनाइटिस, तुम खुद ही टाइप कर रहे हो रेटिनाइटिस. दिस इज परफेक्ट एग्जांपल ऑफ हाउ द ब्रेन विल शट डाउन इन द पेपर. तुम्हें लगता है अरे कूल मैन हम तो फोड़ देंगे, वो तुम्हें हिंट भी देगा ना, फिर भी गलत हो जाता है. दैट इज द रीजन व्हाई यू आर अटेंडिंग द लाइव क्लासेस देयर. दैट इज द पॉइंट ऑफ अटेंडिंग दिस क्लासेस. दैट इज द पॉइंट वी आर कंडक्टिंग दिस क्लासेस बिकॉज वी वांट टू टेल यू दैट वेयर द ब्रेन शट डाउन. Because when I tell you in real time, तुम्हें याद होगा. Yes, a lot of guys have got it correct. It is cerebral toxoplasmosis, and the moment I will say this, everybody will say, अरे सर ये तो आता था, गलत हो गया. Shit man, right? ऐसे नहीं होता. वो तो ठीक है गलत हो गया, but next time नहीं गलत होगा. Cerebral toxoplasmosis is the next entry here, guys. Cerebral toxoplasmosis again is seen, and why cerebral toxoplasmosis is famous is because उसने बोला कि patient को seizures develop हो गए. The seizures have occurred in a patient. So when you attempting these questions, you have to remember these facts that are currently highlighted. Very good Tabriz, very good Tarun. I think a lot of you have got this. बाद में सही हो गया. वो पहले वो साइटोमेगालो वायरस वाला चल गया था, right? So it's okay, man. Life is not a bed of roses. Summary क्या है? Life is not a bed of roses, right? It will keep on giving us challenges on a daily basis. पूरा स्टेटमेंट भाई जान ले यार तू मेरी. CD4 काउंट लेस देन 500 पे ट्यूबरक्लोसिस एंड कापोसी सार्कोमा होता है. 200 पे न्यूमोसिस्टिस जिरोवेसी निमोनिया होता है. If it is gonna be less than 100, So it is Cryptococcus neoformis meningitis. I asked you a question. The guy is having a seizure, and if it is less than 50, then it is cytomegalovirus retinitis in a patient. It is cerebral toxoplasmosis जो कि दौरे करवाता है. This table is I'll rate this slide as one of the most controversial slides for today, right? We have had maximum errors in this particular slide, तो कोई बात नहीं, right? चलता रहता है. All these aspects are to be remembered. चलो आगे चलते हैं. ओके किसी ने आयरिस का भी पूछा था, दैट आई एड्रेस यू. थोड़ा आगे बात करते हैं ना, आयरिस इम्यून रिकॉन्स. इतना तो सबको क्लियर है ना सर, इतना तो सबको क्लियर है ना कि भाई टीबी का पेशेंट होगा तो पहले एड्स का ट्रीटमेंट देंगे, पहले टीबी का ट्रीटमेंट देंगे, तो पहले टीबी का ट्रीटमेंट देंगे, है ना. इफ एनी पेशेंट इज हैविंग टीबी विद एड्स, देन यू फर्स्ट गिव टीबी ट्रीटमेंट टू किल द बैक्टीरिया, and then you will be giving AIDS ka treatment to the patient. First you will kill the TB bacteria, then you give AIDS treatment. You don't do the opposite in the patient, because opposite के साथ में फिर वो iris हो जाता है, जिसको immune reconstitution inflammatory syndrome बोलते हैं. So I'll come to that iris part also subsequently. Let's do lumbar puncture here. The preferred site for performing a lumbar puncture is L3 L4. The preferred site for performing a lumbar puncture is L3 L4. The needles that can be used for this is needle number A is very very pointed, so it is called as Quincke's needle. जो थोड़ा सा relatively side on वाला है, जो थोड़ा side on वाला needle है, this is, yes guys, one is Quincke's. L3 L4 is a specific answer. The second one is first one is Quincke's needle, the pointed tip edge. Second one, this is called as Whitaker. और एक तीसरी होती है, नो वो सी, यही तो आप देखा ना, आपके माइंड में स्प्रॉटे था तो आपको स्प्रॉटे ही दिखाई दे रहा था. स्प्रॉटे विल बी हैविंग ब्लंट एड. इसका जो टिप है वो जो ब्लंट है, दैट इज गोना बी पॉइंटेड, राइट. सो इट इज गोना बी क्विंकेज नीडल, देन इज गोना बी स्प्रॉटेज नीडल, sorry, Quincke's, then Whitaker, and then is gonna be the third one, that is Sprotte's needle. So at this moment, it is the three needles that are used for performance of lumbar puncture in a patient. Rizatriptan nasal spray जिंदाबाद, है ना. एग्जाम से पहले लेकर जाना, रिजाट्रिप्टन नेजल स्प्रे सेंटर में घुसने से पहले ले लेना. चलो, the next point to be understood is how do you do planning of lumbar puncture. So this is the iliac crest. This is the iliac crest. You will select the highest point of the iliac crest. When lumbar puncture is to be done, you will be selecting the highest point of the iliac crest. After selecting the highest point of the iliac crest, you will be joining the two highest points. This will cut through the spinous vertebra L3 L4. You will do lumbar puncture usually below this side. This is the L3 spinous process. When you will be doing lumbar puncture, what you will do is that you will use a ballpoint pen and you will do marking so that you are able to identify this. The highest point of the iliac crest of the left and the right is joined. It transects the L3 spinous process. You do the procedure below this, that is L3 L4. You can do it above also. It is L3 L4 is the side through which you will be putting the needle, and this line is what Yash, Nida, everybody has answered rightly. इस line को हम Tuffier's line बोलते हैं. This Tuffier's line is that anatomical landmark. Tuffier's line is the anatomical landmark which would help you identify the surface marking. So first time when you're doing a lumbar puncture in these patients, right, what you are going to do is that you are supposed to do ballpoint pen marking, because otherwise you will poke the wrong thing. Don't do counting physically at 1 2 3 4 ऐसे vertebra ऐसे लोग count करते हैं. You make mistakes. Check out the highest point of the iliac crest, bisect the L3 spinous process, and then you have to put the needle inferior to this, that is the L3 L4 side. That is like the best logical way not to mess up from the anatomical aspect. Great, very good, very good, great. Okay, contraindications to raise ICP are standard. Raise ICP already explained to you. Local site infection, pyoderma, Then can be kyphoscoliosis, deformities in the spine. You will not be doing a lumbar puncture in a patient. Yeah, kyphoscoliosis में नहीं करेंगे ना. It's all deviated spine, so there could be a risk of trauma present. So raise ICP, local site infection, kyphoscoliosis are like, matlab, these are like contraindications lumbar puncture which we are not supposed to not perform. And the first one is obviously a must know fact. You guys can help me for the fourth one. So need PG Avengers assemble. Tell me the fourth contraindication to lumbar puncture. Yes. If the person is having bleeding diathesis, if person is having bleeding diathesis and the international normal is ratio of the patient is elevated, usually the value taken is 1.7 or higher, but the point is even 1.5 is a good answer, which you have given here. Bleeding diathesis is one of the most neglected points with respect to no, platelet count is less, we can still do, sir. Platelet count is less, we can still do, but INR elevated, there would be a long time issues that would be present. Okay, LHMC. Fine. Highest point of iliac crest joins to form that cuts through, right? It cuts through not L4, it cuts through L3. So just modify this, guys. Modify it slightly. This cuts through L3, L4 intersection hoga. Spinous process alone likha hoga. If he says the word spinous process alone, it cuts through L3 spinous process. Let's clarify. It cuts through the L3 spinous process. The highest point of the iliac crest are joined to form a Tufier's line, as I've explained to you. That will cut through the L3 spinous process. In some MCQ, it's a range like L3, L4 interspace. So that is okay. But the specific word that I'm highlighting is the L3 spinous process at the moment. The most common complication lumbar puncture is headache. Everybody to comment what is the most common, which is the best drug for management of post lumbar puncture headache. Post dural puncture headache के लिए क्या दवाई देते हैं? Post dural puncture headache के लिए, post lumbar puncture headache के लिए, what is the drug that would be used? Your answer would be IV, or it can be oral caffeine that can be used in the patient. Drug of choice for post-dural puncture headache is, opioids are avoided now because they cause constipation. We usually avoid opioids because they cause constipation. Constipation will cause then more stressing, and like he will strain during defecation, and that will cause more leakage of the CSF. So oral or IV caffeine is recommended for PDPH, that is post-dural puncture headache. That's happening the overall most complication that will occur. Then I will make you practice what are the pierced layers which are pierced during performance of a lumbar puncture. So obviously the first layer that will be pierced will be the skin and the subcutaneous tissue. But we have to go beyond this, the skin and the subcutaneous tissue. So what are the layers pierced are the ligaments that you can see. The first ligament is what I'm highlighting in pink. This ligament that I've highlighted in pink at the moment is what is called as the supraspinous ligament. This is the first ligament that will be breached. So obviously you have to go as slow as possible. Then your needle will be going through this particular area which I'm highlighting in yellow. This will obliterate the diagram, but it is okay. The yellow area marking that I've done at the moment, this point number 3, that the area marking that I've done, this is gonna be the intraspinous ligament. So first is supraspinous, never rush into the procedure. It is supraspinous followed by intraspinous ligament, and then you will hit the green layer, which somebody had commented also. This is called as flavum. The next layer which is played is ligamentum flavum. In the MCQ it was written denticulatum. So it is the flavum that would be pierced here, and then we reach what we want to actually approach, that is the dura. और ड्यूरा के पीछे जो चिपका हुआ होता है वो होता है arachnoid matter. It is the dura and the arachnoid matter, and behind the arachnoid matter will be the CSF of the patient. So there are total of 6 layers that you will be basically piercing. Resistance is felt mainly in 2, 3, 4. जो ड्यूरा मैटर होता है वो तो बहुत easily pop हो जाता है. Like I've shown a diagram like this, so you can see that this is the dura matter. And on the back side of this, there would be the arachnoid matter that is chipka hua, and behind that would be the precious fluid that we want to obtain. So CSF is the one that we basically need to obtain in this patient. These are the layers from outside to inside that they've usually asked. So just get a mental orientation right कि flavum अंदर है green वाला, intraspinous is between the two spinous processes, and the outermost is the supraspinous ligament, and then you can achieve and get the CSF of the patient. How many samples of CSF should be taken? So you can take total of 4 samples. When you're doing lumbar puncture in a patient, how much CSF can you take? You can take total of 4 samples. Like I have taken few ml of CSF in the 4 tubes. I will label them and send them to the laboratory. Like these are the 4 tubes that I've taken for lumbar puncture. Like maybe 5 ml, 5 ml in each one of them. Max is what we can remove is 20 ml because 20 ml is produced per hour. We can take lesser than that also. The first tube is labeled by the intern and is sent to the lab. The first tube will be labeled for. Then your answer will be proteins and sugar. We do biochemistry. The second tube will be labeled for. Then it is cytology. The third tube is sent to the microbiology department for culture. And the fourth tube is stored in the refrigerator at 4 degrees Celsius and is used for special studies. Special study would be like PCR, it could be like a India Ink preparation, it could be CB-NAT in a patient. So if I want to do special study like CB-NAT, PCR, India Ink, then it is the fourth test tube which is stored in the refrigerator is the one that would be used. So it is like micropath biochem. बस उल्टा हो गया, माइक्रो वाला पहला नहीं है बिकॉज उसमें कल्चर जो फॉल्स पॉजिटिव हो जाएगा. माइक्रो वाला पहला नहीं है. फर्स्ट इज द बायोकेमिस्ट्री वन, देन इज पैथो एंड देन इज द माइक्रो. इट इज बायोकेमिस्ट्री फर्स्ट ईयर का सब्जेक्ट, then is patho, and then is microbiology that would be used, and not ulta because then there would be false contamination that would be occurring. We want to basically maximize our yield, and the third tube is used for culture and for gram stain, and we are able to manage our patient effectively. Empirical antibiotic treatment would be started. Let's do one more infection for today. This next infection that I'm dealing before you, autologous blood patch, that is like a rare thing. No? If the patient is having post lumbar puncture headache which is not refractory to medicines, only then that low volume blood patch is given. So that's just a statement that might be a filler option in the question, that autologous low volume blood patch is used for. It is a post lumbar puncture headache that is not responding to conventional treatment. We first give painkillers, we give bed rest. After that we go for caffeine, and then we use opioids. So there are 4 things I said, but in spite of opioids, if there is no improvement, then autologous blood patch for lumbar puncture headache, as I've explained in the main videos, can be done in the patient. Okay, so next we'll talk about NCC, one more CNS infection today, that is NCC, neurocysticercosis on the agenda. Neurocysticercosis in the house today. Okay, for neurocysticercosis, first is obviously how the infection is transmitted. So we'll do it till 8 o'clock. The neurocysticercosis is due to ingestion of proglottids containing the eggs of Taenia solium. Eating pork will not result in development of neurocysticercosis. Question for everybody: if a person is having a calcified lesion, needles, यार वो needle pointed थी ना, इसलिए नाम बेटेकर कर दिया उसका. अगर इसका टिप पॉइंटेड नहीं होता जैसे कि नीचे वाली, तब मैं उसको स्प्रोटे बोल देता. फर्स्ट इज द टिप, नो डबल एज ब्लेड प्रेजेंट होता है ये वाला. सो दैट नीडल इज, what is the first one that I described? That is quincus. Second is Whittaker, and the third one is the Sprotes needle that is present. Okay. Moving ahead, neurocysticercosis and tuberculoma are 2 common lesions that would be present. So therefore, there can be like issues present. No, like we would be having difficulty in identifying. So like if he says neurocysticercosis versus a tuberculoma, neurocysticercosis versus a tuberculoma, what is the best way for differentiation? Then our answer is MR spectroscopy. MR spectroscopy can differentiate between the 2 lesions, either it is NCC or it is tuberculoma. The MCQ will use the word lipid peak, or he might use the word amino acid peak. If he specifies the word lipid peak, then it is obviously going in favor of TB. If he says amino acid peak, then it is neurocysticercosis. So that was a neat PG question that I just covered here, that how would you differentiate whether the calcified in the calcification in the brain is either of the 2. It is MR spectroscopy report that will help differentiation. To see that you read the table and to see your background knowledge, I would like to put up a question to you here also. Like this particular patient, who has come to me is having extensive calcification, multiple, like these lesions. This is the report that is given to you, multiple calcified lesions. If person is having so many, calcified lesions present all over the brain parenchyma, like the Stariska appearance that you are identifying, then what is the first drug that will be introduced for management of this patient? Remember, this is like a dead parasite. What is the first drug that you will be using for management of this patient? Options are, would you first give albendazole, will you first give steroids, or would you be first giving dexamethasone? Would you first give albendazole, would you first give steroids, or one we can say is valporate for this particular patient? The parasite is dead, it is calcified, and like there is no surviving parasite which is present here. Would you first be giving steroids, would you first be giving albendazole, or would you be giving sodium valproate for this patient? I'm waiting for your answers, guys. I would there's so many doctors who are listening to this. If you are like a real at the fag end of the discussion, hit the comment button. What are you gonna do to take care of this calcification epileptogenic focus? The question said patient is having multiple calcified lesions, the parasite is dead. Most of the people have answered steroids for this condition, which is wrong, because steroids are given not for the dead larva, they are given for the alive larva. If I gave you this image and I said patient is having vasogenic cerebral edema and you answered steroids, it is understandable. Steroids inflammation कम कर देंगे, calcification थोड़ी ना ठीक कर देंगे. This is the image. If I gave to you and you say कि सर इसमें वेजोजेनिक सेरेब्रल एडिमा होता है, तो मैं मानता हूं कि आप स्टेरॉइड देते हैं पहले, फिर एल्बेंडाजोल देते हैं. मैंने तो आपसे पूछा ही नहीं ना कि दिस इज लाइव वार्वा. आई सेड इट अगेन एंड अगेन एंड अगेन. इट इज द calcified lesions that are present. I also deliberately said the word dead larva. The body has killed them. Then you will only give valporate to a patient. That is the first line that I taught you today. Most common cause of acquired epilepsy in India and America. Even America. The most common cause of acquired epilepsy is neurocysticercosis, and we will be giving sodium valproate for the patient. Though it was written in the notes only, but like you would have noticed that sometimes we tend to develop a selective amnesia for or selective blindness for certain words. So oral valproate for minimum at least 2 years should be given to these patients. If it is calcified lesions which are given in the question, your answer is only valproate. If he mentions hypointense lesions with or without Scolex, that is the stages that you were asking me कि ऐसे black holes दिखाई देंगे. उन black holes के अंदर में you will be able to see the eccentric Scolex. If this was the description I was asking you, that patient is having Scolex, and then what will you do? Because इसके आसपास cerebral edema होगा. Like if I show this image again, you can see this is the calcification, lot of calcification present. And then you can notice the larva is beginning to die. And there is also presence of vasogenic cerebral edema. What I imply by cerebral edema in the chap is that this is fight between the security system and the bacteria. If this is the stage that is given to you, then your answer is obviously perfectly fine. And most of the time the questions revolve around these 2 points only. Either they will give you an image of hypointense lesions with or without Scolex. There the answer is dexamethasone. We have to reduce the vasogenic cerebral edema. And once I treat the edema, then I can give albendazole and then I can give valproate to the patient. But if we will specify the word calcified lesions alone, then it is sodium valproate for 2 consecutive years that will be given to this patient. Valproate here also will be given for 2 years only. Valproate here also will be given for 2 years only. Yeah, calcification acts like, no, it can act like a space occupying lesion. Better आपने question पूछा, Dr. Sahu, does calcification act like a space occupying lesion? My answer is calcification acts like a epileptogenic focus. दौरा करवाता है. My answer is the calcified lesion acts like a epileptogenic foci. If it will act like a epileptogenic foci, it will cause an issue. But yeah, calcified lesion, if it will occur in the aqueduct or Luschka, if the calcified lesion will occur in, let me say, the foramen of Monroe, then it will cause raised ICP also. So I don't have an issue here. Yes, there was one question which mentioned continue antiepileptic only. That's what I'm trying to highlight. If it's only calcified lesion, epileptogenic foci, it is only valproate. If it is hypointense lesions with or without Scolex, then we give steroids followed by albendazole and valproate. These are 3 main questions on this topic. You keep on reading about this multiple times. So obviously I'll mention the standard information of rice grain calcification. that rice grain calcification is indicative of cysticercosis. The rice grain calcification is indicative of cysticercosis. When patients come to us late, then they will be having this presentation, which is given in the middle. If they come to us early, then it is either the first image or the fourth image where you will notice that you will notice the scolex. You will be noticing that there are certain black areas. Like if I just put different color markers, I can call this as a black hole because there is no white here. But in the second one, the purple one that I've shown is the hypointense lesion with the scolex that I tried to show. So you can see it's like an ongoing infection. Most of this is like a recent infection acquired in a patient where it is hypointense lesions, and then the white dot basically indicates that this is the scolex that is developing in this case. So the differentiation between the early and the late manifestation is what the examiner is trying to identify. The larva of Taenia solium को हम cysticercosis cellulose बोलते हैं. आई होप इट इज क्लियर टू एवरीबडी. आई डोंट नीड टू राइट कि अगर कोई आदमी पोर्क खाता है तो उसे न्यूरोसिस्टिसर्कोसिस नहीं होता है. पोर्क खाने से न्यूरोसिस्टिसर्कोसिस नहीं होता है, उससे सिर्फ अडल्ट टेप फॉर्म्स की लाइफ स्पैन खत्म होती है. दिस वाज अ माइक्रोबायोलॉजी क्वेश्चन ऑफ योर एग्जाम कि पोर्क खाने से क्या होगा. तो पोर्क खाने से इट इज द अडल्ट टेप फॉर्म्स, इट विल ओनली कंप्लीट द लाइफ साइकिल. हु विल बी डेवलपिंग न्यूरोसिस्टिसर्कोसिस इज जिस पर्सन ने फीकली कंटेमिनेटेड वेजिटेबल्स को कंज्यूम किया. Who's the person who would be developing neurocysticercosis? Will be the person who had consumed unwashed vegetables like raw salad that is containing vegetables like lettuce or cabbage etc. Fecally contaminated soil पे जो grown vegetables होती हैं. Most of the time in India, because of this problem of open air defecation, though Modi government has made like so many efforts to like make these toilets, but if you even in your OPD, today if you talk to patients, from village and you ask them कि भाई why do you go for open air defecation, तो they say कि खुला खुला लगता है ना, अंदर तो बंद बंद सा लगता है. And you are like, I mean, कोई प्राइवेसी का तो शर्म वाली तो बात है नहीं. It's like खुली हवा में जाना अच्छा लगता है. I mean, they consider that is like, it's my birthright to spoil other people's lives, and they go in the fields. If you ever been to rural India, you will notice what I'm talking about. And what if a pork had a gravid tapeworm? Pork had a gravid tapeworm. Yeah, if all tapeworms are gravid only, all gravid, सब में proglottids होते हैं, सब में अंडे होते हैं, सब में अंडे होता है. तो the point is raw tapeworm तो मतलब it is like unlikely, right? So it is like the point what I'm trying to say is that the larva is present. That will not be able to cross the intestinal barrier, right? So the main point that I wanted to understand is that अगर कोई पोर्क खाएगा ना तो उसमें तो लार्वा प्रेजेंट होता है, उसके अंदर में like the proglottids or the eggs would not be present. Okay, fine. I think we are sorted at the moment for like what is the manifestations at the हाँ ठीक है I got it. चलो, let's do one more, guys. विनोद वाला सीरियल, आई रिमेम्बर, पंचायत वाला. वेजोजेनिक सेरेब्रल एडिमा 2 बार मैंने बताया. वन इज गोना बी ट्यूबरकुलोमेनिंजाइटिस एंड सेकंड टाइम आई हैव डिस्क्राइब्ड दिस फॉर दिस न्यूरोसिस्टिसर्कोसिस. चलो जी, let's do one more topic and then we call it quits for today. So the topic that we're discussing is subarachnoid hemorrhage. कौन सा वाला डायग्राम? ये वाला. Okay. If you can notice the black areas, that is the early phase of the worm. Then subsequently there would be, चलो ये वाला देखते हैं. ये this is better, right? In majority of questions that they give to you, उसमें black hole होगा. Of a black hole के अंदर में you will be able to notice that there would be a white dot that is the scolex that is developing. इसको हमेशा बोलते हैं eccentric scolex. It will be in the periphery. And then the body is killing the parasite. You can see ये जो white dot मैंने दिखाया, this white dot is basically the scolex. The worm is beginning to die. And जो मैंने अभी दिखाया ना ये वाला, this is not visible on a plain MRI. इसके लिए आपको contrast enhanced MRI करना पड़ेगा. But this vasogenic cerebral edema is that hidden element which is responsible for the problem in the patient. That is why the pathology part in this patient is what is called as a ring enhancing lesion. Then it is called as ring enhancing. In pathology, the word used for this would be called as a ring enhancing lesion. That's the point which I wanted to bring to your attention. Ring enhancing lesion would be present. Mainly it is the lipid peak. जैसे इस वाले में तो it's not the lipids that are more, no? The lipid part is very less. LIP is the lipid. It is choline, creatinine, succinylcholinate, NAA. The amino acids are elevated. So if the lipids are spiking, then we say TB. If it is not, if lipids are low and the remaining parts, choline, creatinine, like all those other components are elevated, then your answer would be given as that this is neurocysticercosis. That's the topic of interest, no? So that's why I gave you a graph in which the lipid part would be relatively reduced. Okay. Next, we'll talk about subarachnoid hemorrhage with the worst headache of my life. Yes, the buzzword, so thunderclap headache that is present. But thunderclap headache is like third wale mein live larva hoga. Third wale mein. No, this will not have a larva. This is dead. Late na. This is dead larva. This is calcification. जब खत्म हो जाएगा तो dead calcified दिखाई देगा. First and fourth images are having the live one. The third one does not have a live larva. Thunderclap headache से question solve मत करना. Thunderclap headache से question solve नहीं करना because of the fact that there is hydrocephalus, because it can be seen in hypertensive crisis. It can be seen in a pituitary bleeding. It can be seen with cerebral venous thrombosis, hydrocephalus. So like I was saying, pulsus paradoxus से question solve नहीं कर रहे हैं. Same spirit, don't solve the question on the basis of thunderclap headache. What will you look for in the question? What you need to look for is not even the word worst headache. Just focus on the word headache, and along with that question में क्या चीज होनी चाहिए? It is nuchal rigidity. There are two things that will always be solving the question for you. It is headache and nuchal rigidity in the patient. Subarachnoid hemorrhage questions should not be solved with thunderclap headache, worst headache of my life. Okay. Can you tell me what is the definition of the word thunderclap headache? Thunderclap headache is जैसे मैं आपसे अभी बात कर रहा हूँ and suddenly I hold my head and say कि भाई अब नहीं बोल सकता, मेरा सिर फट रहा है. तो if the intensity of the headache is achieved in 1 minute, peak intensity of the headache is achieved in 1 minute, then we call it thunderclap headache in a person. And most of the time the question, okay, this is for NEET PG students. Please comment in the chat box. And FMG students, be alert. अगला क्वेश्चन आपको आने वाला है. What is the next best investigation after CT head? NEET PG 2024 या 25 में से है. He said CT scan has been done. It shows the star of death. I'll show you the star of death again also. But what is the next best investigation that is done if the CT scan is normal? Next best investigation to be done after CT head, which is showing subarachnoid hemorrhage evidence. Like there is a SAH evidence in a patient. SAH evidence can be in the form of blood in the sylvian fissure, or he can say instead of blood in the sylvian fissure, there is star of death present. So what is the next investigation? Yes, your answer would be given as cerebral angiography. Now, the next question came in INISET exam. उसने बोला what is the next best investigation to be done if the CT head is normal? That is where the answer is lumbar puncture. If the CT head is normal, that is when we will do guarded lumbar puncture. These are the two commonest mistakes which people are able to, like, which people are like answering ulta sometimes. So a lot of guys have done a great job answering this, that the next best investigation after subarachnoid hemorrhage evidence is cerebral angiography, because you want to do endovascular coiling. But if the CT head is normal, then you don't know it is a hemorrhage or not. So first demonstrate the RBCs in the CSF, and most of the time, by the time the patient will come, the RBCs will break down. That is why in the upper part of the slide, you can notice the yellow tinge of the CSF. The yellow tinge of the CSF is what is called as xanthochromic CSF, which will identify that the person is having a delayed presentation where the RBCs would be destroyed. I repeat the statement. The two questions that I have discussed at the moment are NEET PG and INISET. I'll repeat the INISET once again. If CT head is normal, then it is lumbar puncture. If there is a SH evidence in a patient, like he did not mention the word even SH evidence, he said what is the next best investigation, then your answer is cerebral angiography. If CT scan is normal, it is gonna be guarded lumbar puncture in the patient. The leading cause of subarachnoid hemorrhage. Now is an FMG exam question. What is the leading cause of subarachnoid hemorrhage? Yes, guys. Is it rupture of the aneurysm or is it trauma? I would like all FMG students to quickly comment in the chat box. What is the number one cause of subarachnoid hemorrhage? No, the pressure in the brain will be elevated. So again, we are doing a guarded lumbar puncture in a patient. But if CT head is normal, that means it is a chotu sa berry, na? So pressure will be normal there. If CT is normal and there is no ventricular dilation, that means pressure will be normal, na? Why pressure is normal is because it's a chotu sa blade posterior location. Yes, the most common cause for this is trauma. The most common cause of this is trauma followed by rupture of berry aneurysm. So one what I have highlighted before you are the core aspects जो गलत होते हैं. अब तो आगे वाले तो खैर आसान हो ही जाएंगे. So what we are gonna do this is first of all work out what is the first investigation to be done in anybody who's having headache. This headache का जो duration होगा वो few hours का होगा. Along with that, to waste my time, he will obviously mention vomiting. He will mention the word nuchal rigidity. That is what you need to pick up. In इनीसेट एग्जाम उसने अभी जो पीछे वाला इनीसेट था लास्ट मई वाला उसमें उसने ब्रोडजिंकी साइन लिख दिया था विद द सीटी स्कैन नॉर्मल दैट आई एक्सप्लेन्ड इज अ गार्डेड लंबर पंक्चर बट लाइक meningeal signs will be given in the question and what you will do is you will do a non-contrast CT head and this can show any of the two findings which are now right before you. Don't rely on the star of don't rely on the star of death. That is a very classical finding. That is a very classical finding that will only be noticed by you. That star of death finding will only be noticed by you if it's a very big substantial amount of bleed. Otherwise, the usual mention would be blood in the Sylvian fissure. So I'm just writing star of death for the sake of completion. Otherwise, it is blood in the Sylvian fissure which will do the job for you. Next best investigation after CT head is being practiced once again. I've already said it. I have deliberately kept the data multiple times so that I can emphasize the importance of it. That I will do a angiography because I need to put a coil in the aneurysm and that endovascular coiling will treat the patient. Yes, Sylvian fissure. Yes, F stands for fissure. What to do if the CT head is normal in a patient? That means that there is no significant increase in pressure in the brain. There is probably a posterior fossa because CT scan is not good for posterior location of the brain. A guarded lumbar puncture will do the job. The findings would be RBC in CSF or a xanthochromic CSF. The findings of guarded lumbar puncture, again practicing, either he will say field full of RBCs. Or instead of a delayed presentation after a couple of hours, he will say xanthochromia, that is a lemon yellow tint of the CSF. Instead of writing the word xanthochromic, the word written will be lemon yellow tint of the CSF. That's again indicating the same thing. Bilirubin का जो color होता है ना यार, RBC टूटेगा तो bilirubin बनेगा. So it would be a lemon yellow tint that is present. In this question, deliberately BP will be given to be elevated. He will say a BP of 180. Maybe he will say blood pressure of 200. Don't try to lower the BP. You will rather be having a brain infarction. Don't try to aggressively lower the BP of this patient. You can rather ensure brain infarction in this patient. So what is the treatment of choice for this particular patient? The treatment of choice is endovascular coiling. In the same sitting of cerebral angiography, when it will be done, we will be able to know where the berry is located and we will be going, no, the treatment of choice answer is not nimodipine. It is endovascular coiling which is the main treatment. If it is a very large multiple aneurysms present, then sometimes we might have to do a craniotomy and do a aneurysmal clipping. But on a comparison basis, if both of them are given, I will show you both the approaches here. The A approach in this case is endovascular coiling. And the B approach in this patient that you can see is the aneurysmal clip that I'm talking about. If aneurysmal clip is put in the patient, then future में कभी MRI head नहीं हो सकता है. This is a radiology question that you guys are already aware of. MRI head is contraindicated if the clip is in place because this is a ferromagnetic device. This is a ferromagnetic device. This will get dislodged from its original position. The ferromagnetic device can get dislodged from its original position, and as a result of it, like the berry can burst also. So MRI cannot be done in patients who are having a ferromagnetic aneurysmal clip present. And anyway, I can say that the hospital stay with endovascular coiling will be shorter. With the aneurysmal clip craniotomy कर दिया तो वैसे ही पेशेंट का जो स्टे होता है वो रिलेटिवली हो जाता है, रिलेटिवली लॉन्गर हो जाता है. Now we will focus on the drug of choice for this condition. The drug of choice for this condition is nimodipine. Why is nimodipine given? Nimodipine is not going to treat the bleeding. It is going to be given to prevent vasospasm because जहाँ पे भी bleeding होता है वहाँ पे जो feeder vessels होती हैं वो feeder vessel spasm में चली जाती है. So to prevent the protective vasospasm, we are giving nimodipine to this patient. Yes, delayed cerebral ischemia is the technical word for it. If he says what is the first step in the management of patient of subarachnoid hemorrhage? If he says what is the first step? Yes. If he says what is the first step in the management of this patient? Yes, can you guys quickly comment on this one, please? First step in the management. मोर पीपल टू कमेंट है। पहले क्या करेंगे, पहले कॉइलिंग करेंगे, पहले निमोडिपिन दे देंगे। जो ब्लड रिलीज हो गया उसको तो कुछ नहीं कर सकते यार। अब देयर इज ब्लीडिंग इन द ब्रेन, यू कांट डू एनीथिंग अबाउट इट। इसको निकाल लेंगे थोड़ी ना, वो तो अपने आप से वहां पे क्लॉट हो जाएगा और उसके बाद में रीअब्सॉर्ब हो जाएगा। बट इट इज जस्ट द फैक्ट दैट जो और रीब्लीडिंग का रिस्क कम करना है आपको। हाँ जी, सबसे पहले क्या करेंगे, तो पहले निमोडिपिन ही दे देंगे। Obviously, we will be giving nimodipine to the patient to prevent the vasospasm of the patient. So if he says first step, it is still nimodipine in a patient. And nimodipine के बाद में we can straight away take the patient in for cerebral angio. And after cerebral angio in the patient, then we can go for, क्योंकि यार coiling करने में तो टाइम लगेगा ना। ऐसा तो है नहीं है कि अभी पेशेंट आया, आप सोचो अभी अभी पेशेंट आया सबरेकल हेमरेज का कैजुअलिटी में, तो क्या उसका सीधा कोइलिंग कर लोगे? ऐसा तो नहीं होता ना भाई। पेशेंट आएगा, आपको लगा, डायग्नोसिस करवाया आपने, तो यू विल डू गिव निमोडिपिन फॉर दिस पेशेंट, बिकॉज व्हेन ही विल कम आई विल फर्स्ट डू अ सीटी स्कैन। इनफैक्ट आई एम हैविंग अ सीटी स्कैन एविडेंस, तभी तो मैं ये एल्गोरिथम फॉलो करूंगा दैट आई विल गिव निमोडिपिन, आई विल डू सेरेब्रल एंजियो, देन आई विल डू एंडोवास्कुलर कॉइलिंग। इफ द पेशेंट केम राइट नाउ, nimodipine also causes a decrease in blood pressure. No, Yashika, it acts on the cerebral blood vessels. It primarily has action on, it has been shown to have a specific action on entry of calcium in the blood vessels related to ACOM and PCOM. That is why this is a cerebroselective calcium channel blocker. अदरवाइज तो इसको हम हाइपरटेंशन में यूज करते होते। अगर निमोडिपिन ब्लड प्रेशर को कम करता होता तो हम एम्लोडिपिन के पीछे क्यों भागते? आपके पास इतने सारे कैल्शियम चैनल ब्लॉकर्स हैं, आप सब में निमोडिपिन कहाँ लिखते हो? यू राइट सो मेनी डिफरेंट सीसीबीज ना। निफेडिपिन देते हो, एम्लोडिपिन देते हो, क्योंकि ये सेरिब्रो सिलेक्टिव है। इट इज एक्शन ऑन द ब्रेन। द मोस्ट कॉमन लोकेशन ऑफ बेरी एनेरिज्म इज ACOM. But if he says what is the most common location prone to rupture, hit the comment button, guys. If he says what is the most common location which is prone to rupture, then it is PCOM. जो PCOM होती है ना, उसके साथ से ऑक्यूलोमोटर नर्व जारी होती है। जो PCOM होती है उसके साथ से ऑक्यूलोमोटर नर्व जारी होती है, वो दब जाती है। लाइक दिस इज ऑक्यूलोमोटर नर्व. It is going adjacent to the PCOM. The berry will squeeze the third nerve in the patient. So if he says what is the most common cranial nerve involved in a ruptured or unruptured berryism, it is third nerve palsy. Because the cranial nerve third will get paralyzed in this patient, therefore you would be having ptosis in this patient, and pupillary reflexes would also be lost. So it's a third nerve palsy with, in majority of cases, with pupillary involvement. If I change my question, NEET PG students, NEET PG Avengers, third nerve palsy with pupillary sparing. I would like you to hit the comment button in the next 10 seconds. Third nerve palsy with pupillary sparing. Pupillary sparing is a feature that can be seen with lateral rectus and third nerve palsy with pupillary sparing. यहाँ पे भी like okay, third nerve palsy तो है, pupillary involvement can also be present. Any endocrine disorder where we get it, it is diabetes mellitus. Third nerve palsy with pupillary sparing is a feature. Yep, diabetes mellitus is the main answer that is given in this patient. इसको मैं अभी सिंप्लीफाई कर देता हूँ. आई फोकस ऑन दिस फैक्ट लेटर ऑल्सो. अभी आप ऐसे नोट करना, क्योंकि अभी वो प्यूपिल वाले में मैं नहीं जाना चाहूंगा. सो आप सिंपल याद रखो, वेदर ही सेज, अभी क्या याद करना है, वेदर ही सेज द वर्ड ruptured berry or he says the word unruptured berry, the answer is third nerve palsy. Pupillary sparing word is given, then you have to think in terms of diabetes mellitus. So I would like you to modify the data and remember कि आपने याद क्या करना है अभी के लिए, that इस टाइम पे क्योंकि हम CNS पढ़ रहे हैं ना, तो I'll focus currently on rupture and non-ruptured में the cranial nerve remains the same, because impression of students is कि सर rupture कर जाएगी तो raised ICP होगा, तो sixth answer करेंगे. No, if unruptured is pressing on the third, then rupture will also press on the third one. If unruptured is pressing on the third, then the ruptured will also press on the third one. And then comes the leading cause of death in this patient. ये तो most लोगों ने आंसर कर ही दिया है, that the leading cause of death in those patients, who are having subarachnoid hemorrhage is delayed cerebral ischemia. That is a fancy term for vasospasm. It's called as DCI in a patient for which nimodipine has been given. Then we can have hydrocephalus, we can have bleeding, we can have a rebleeding, and we can have electrolyte imbalance. Everybody listening to me, hit the comment button. Which electrolyte imbalance is seen in patients of subarachnoid hemorrhage? what type or which electrolyte imbalance is seen? Yes, it is hyponatremia due to release of B-type natriuretic peptide that will cause natriuresis. And this natriuresis can cause a drop in the sodium values in the patient. And if sodium will go less than 125, then there's a possibility of seizures. So when you're attempting these questions, I mean, do be careful that he may not only mention headache and nuchal rigidity and fever, headache. There's no mention of fever, headache, and nuchal rigidity, but he can mention possibility of seizures in the patient also. The reason for this seizures in this patient, the reason for development of seizures in this patient is cerebral salt wasting syndrome. That's the word I want you to remember. Cerebral salt wasting syndrome is the main thing that I want you to remember in this patient, and therefore urinary sodium की ना report artificial से create कर देगा. Urinary sodium in this case will be high. Serum sodium in this particular person, serum sodium in this patient will be low, but urinary sodium of this patient will be high. And any sodium, I mean, I'll discuss one day separately electrolytes before you also, but then sodium normal is 135 to 145. Irrespective of whichever exam you're sitting for, they always ask you hyponatremia. Can you comment in the chat box which variety of hyponatremia has been described here? Euvolemic, hypovolemic, hypervolemic. Hit the comment button. Euvolemic, hypervolemic, and hypovolemic. Cerebral salt wasting syndrome causes which variety of hypovolemia? Hyponatremia. Euvolemic 1, yes, hypovolemic. क्योंकि पानी भी तो निकलेगा ना यार साथ में. Salt अकेला तो निकलता नहीं है. It's not that salt is gonna be lost just like that. Along that, water will also be lost. So if salt and water are lost together, then we call it hypovolemic hyponatremia. So most of the time in the question, like they want to hear regarding नहीं बच्चे यूवोलेमिक हम आगे पढ़ेंगे. आई वांटेड यू टू लाइक अभी के लिए, क्योंकि आगे एंडोक्राइन में भी आएगा. यूवोलेमिक हाइपोनाट्रीमिया में इट इज ऑलवेज SIADH, एंड हाइपरवोलेमिक में इट विल ऑलवेज बी एल्डोस्टेरोन. इन हाइपरवोलेमिक is always gonna be aldosterone. In euvolemic it will always be SIADH in a patient. That is syndrome of inappropriate ADH secretion in the patient. Okay जी, चलो कोई बात नहीं, एक और स्लाइड कर लेते हैं. लास्ट स्लाइड फॉर टुडे, देन विल कॉल इट अ डे. लास्ट स्लाइड. लास्ट CT scan. I want answers for this one. Diabetic patient fell in the bathroom and lucid interval was noted. Lucid interval. The lady is becoming very, very drowsy. She has a headache, trouble speaking, recollecting events on day 3. So the question is saying कि भाई, like there is a bleed present, right? Very good. This lady has fallen on the left side, so it will just take maybe 2-3 minutes to do this topic. So stay with me, and then I will ask you the question. Like at the moment, your interpretations are right. She is having a subperiosteal bleed on the left, and you can see a concavo-convex bleed on the right. So the interpretation of this patient is this patient is having right-sided. Then I can also notice that in this particular patient, I'm using the word acute. The reason for why I'm using the word acute is because one patient has come by day 3, and second reason is because the bleed is white in color, hyperdensity is present, so I'm calling it acute. And the third one is बेटा इडली शेपेड नहीं है ये, है ना. इडली शेपेड जो होता है वो एक्स्ट्राड्यूरल हेमरेज का होता है ना. दिस इज सिकल शेपेड, दिस इज सिकल शेपेड, दिस इज राइट साइडेड acute, and because of the shape that is present, we will say this is subdural hemorrhage, because when you check out the shape here, it is not idli, it is that sickle, or it is concavo convex. Like if you check out the bleed present here, it is concavo convex. So this is a right-sided acute subdural hemorrhage in a patient. Yeah, you call it banana also, or like a sickle-shaped subdural hemorrhage is sickle. You can call it concavo convex, but it means the same. This is the most frequent CT scan that comes in any paper in the exam in India, and that is why I made you sit here. I will give first right of answering this to FMG students. Please tell me what is the treatment of choice for this condition. Options are burr surgery, mannitol. I am writing the options also. This is how the manifestations were given. He said what is the best treatment for this patient. first line management for this patient. So would you like to give mannitol? Would you like to go for Burhole? Would you like to take up the patient in the OT and do a craniotomy? Would you like to do a decompressive hemicraniectomy? So I think I can wait and check out the answers at the moment. It is mannitol, Burhole, craniotomy, and decompressive hemicraniectomy for these patients. What is the main treatment? Yes, yes, yes. First line management. I'll also write the word first line management. This is one of the most frequently asked question that is asked in both INISET as well as in FMG exam. So first I've given opportunity to like FMG students at the moment. Now NEET PG aspirants, Avengers from FMG have answered. Now it's your turn. So hit the comment button, guys. What is the first line treatment to be done for any patient who's having a subdural hemorrhage? Patient is not in her senses, like she cannot recollect it. There's a neurological deficit that is present. So I'm giving opportunity to a lot of others also. Yes, guys, I want you to, whatever you feel like, give me correct answers here. Okay. Okay. I'll wait for a few more seconds before I close the poll. And I think this is not a question where I think you should shy from answering. So I expected that more people would be answering there. Yep. Okay, my turn at the moment. We do not give mannitol in this particular patient. Though some platforms have answered, like in the recall session, mannitol, active CNS bleeding में mannitol का कोई role नहीं रहता है. Yeah. Do we get a lucid interval in subdural hemorrhage? Yes. Lucid interval is a wrong way. Forensic teacher will always say lucid interval is a feature of extradural hemorrhage. No, lucid interval is seen in both of them. Lucid interval पढ़ के I deliberately first underlined the word because I wanted you to realize that lucid interval is seen in extradural hemorrhage. It is also seen in acute subdural hemorrhage. That is the first point clarity. So good question there, man. ADH में भी होता है और acute SDH में भी होता है. A lot of guys have issues with respect to this. So the answer is yes. Now क्या करेंगे? तो भाई अगर मैनिटॉल दोगे तो पेशेंट ठीक हो जाएगा क्या? क्या वो दोबारा से बोलना शुरू कर देगा? क्या वो रिलैक्ट कर जाएगा? नहीं ना. बर होल सर्जरी कहाँ करते हैं? बर होल सर्जरी करते हैं क्रॉनिक सबड्यूरल हेमरेज के केस में, जहां पे प्रोग्नोसिस बैड होता है. सर इसका आंसर बर होल सर्जरी नहीं है. द ट्रीटमेंट ऑफ चॉइस फॉर एक्यूट सबड्यूरल हेमरेज इन अ पेशेंट इज क्रेनियोटमी. वी नीड टू डू ओपन अप द स्कल. द ब्लीडिंग इज बिलो द ड्यूरा मैटर. तो काला काला खून निकलेगा. दैट इज गोना बी irrigated and the clot which is pressing on the brain parenchyma is gonna be the when you incise the dura matter, जब ड्यूरा मैटर को खोलते हैं तो उसके नीचे क्लॉट है, तो हम इरिगेशन करके क्लॉट को निकाल देंगे. एंड दैट क्लॉट व्हेन इट इरिगेटेड द प्रेशर ऑन द ब्रेन विल गो अवे एंड दैट इज व्हेन द पेशेंट विल सब्सिक्वेंटली होपफुली रिकवर. नाउ व्हेन डू यू डू अ डीकंप्रेसिव हेमिक्रेनेक्टमी? व्हेन डू यू डू अ डीकंप्रेसिव हेमिक्रेनेक्टमी? बात एक ही तो है, क्रेनियोटमी कर लो या डीकंप्रेसिव हेमिक्रेनेक्टमी कर लो. डिफरेंस क्या है? इन क्रेनियोटमी यू विल ओपन द स्कल and after the surgery you will put back the crap and therefore you will close the skull. If you open the skull, remove the clot and then put it back on, that is craniotomy. Now I will give you scenario. अभी पीछे क्या हुआ कि वो कई डॉक्टर्स रेडिकलाइज हो गए, उन्होंने लाल किला पे बॉम्ब ब्लास्ट किया है ना. आजकल तो लोग डॉक्टर्स का मजाक उड़ा रहे हैं, डॉक्टर्स बॉम्ब ब्लास्ट कर रहे हैं. So these guys were being tailed by RAW. They panicked and they pressed the button and the bomb went off. So people who were close to the bomb, they obviously died. But even today, there are some people who might have recovered from that, who are still in intensive care unit because they had lot of swelling in the brain. So they might not have recovered immediately. तो जहाँ पे swelling in the brain is there, ब्रेन में सूजन आ गई, तो कैन यू पुट द बैक ऑन? जस्ट थिंक लॉजिकली. देयर इज अ स्वेलिंग इन द ब्रेन सूज गया है. Can you close the skull? No. You will close the skull after 2 weeks, 3 weeks, 4 weeks, because when the swelling will come down, that is when the skull would be closed. That is decompressive hemicraniectomy. Sad. I'll give another example. A couple of years ago, this Turkey, they created that war, right? The Turkish planes landed in Pakistan. We had this issue. Turkey was the main country responsible for the growth of ISIS. They suddenly controlled so much of territory from Syria to Iran to Iraq. ISIS had placed a suitcase containing a bomb at the Brussels airport. I'm talking about 2018, I think, 2017-18. When that bomb went off, this girl from Mumbai, she was checking in passengers' luggage. When the bomb went off, this jet airways attendant was like couple of 100 meters away from the bomb zone. If she was close, her body would have been destroyed by the shrapnel. But the shock wave of the bomb caused her to develop CNS swelling, brain swelling, and therefore the Brussels hospital admitted her. They did a decompressive hemicraniectomy. They opened her skull and the brain was all swollen because of the swelling, so they could not pick the cap back on. They waited for almost 1 month. After 1 month, when in this girl the swelling in the brain come down, they put the cap back on, and obviously then subsequently, like she recovered also, she flew back to India. She joined Jet Airways. You can read this on internet. This girl from Mumbai, she underwent a decompressive hemicraniectomy in a EU hospital. This was a Brussels. Just type word Brussels bomb blast. You'll start finding about bits about it. Decompressive hemicraniectomy में जो स्कल होता है उसको तुरंत बंद नहीं करते हैं क्योंकि देर इज अ प्रेजेंस ऑफ अ malignant cerebral edema. सो आई वांट टू टेल यू एट दिस पर्टिकुलर मोमेंट decompressive hemicraniectomy कहाँ पे करते हैं. तो decompressive hemicraniectomy का मतलब होता है कि you will open the skull and not close immediately because the swelling will refuse to die down. So it is done in malignant cerebral edema. This malignant cerebral edema is seen in patients of hemorrhagic stroke from the medicine perspective that I'll be touching upon, and obviously it is seen in even bomb blast victims. Bomb zone में देखो, if somebody is in the bomb zone, the guy's body will be thrown to bits because the metal fragment डालते हैं ना उसमें, तो metal के fragments will go through and through the body. But like the shock wave, the bomb can result in the brain swelling in a patient. So malignant cerebral edema is where the decompressive hemicraniectomy is called. And now my question to you guys, if you will open the skull, तो वो skull का जो cap है उसको कहाँ रखेंगे? You removed the skull of the patient. What will you do with that skull? Will you give it to the relatives कि घर पे रख लो फ्रिज में? Or will you give it to the nurse and say कि तुम रख लो फ्रिज में? Or you will put in formalin? Yes, Vaishnavi answered beautifully. You put it in the abdomen. You put that skull in the abdomen, and sometimes due to blast, the skull might be broken also. Fragments will be broken. So we can put the fragments on for bone grafting. And if it will not properly close the skull, then we can put titanium plate also. The person will become Iron Man at the moment. Then person will become Iron Man, right? लोहे का आना आपने टाइटेनियम लगा दिया. What I've tried to take care of this at this moment is like what is the intervention that is to be done. Guys, the first line management for this particular patient is that we need to treat the patient by managing the patient with craniotomy. In fact, at this moment I want to highlight, I will just modify slightly by saying कि first line तो ठीक है, इसका main इलाज भी यही है. It's not that this is like just only the first line treatment. This is how you will save the life of the patient, that you will go in for craniotomy in this patient for patients of acute subdural hemorrhage. पर होल कहाँ पे आंसर करना होता है? इट इज गिवन फॉर क्रॉनिक सबड्यूरल हेमरेज जो ऋतिक रोशन को हुआ. Hrithik Roshan was shooting for this movie Krish when his head hit the side of a swimming pool. These actors who do their own stunts, they are the ones who can develop chronic subdural hemorrhage. So if the same patient, no sir, in the hospital, how can we allow infection from occurring? Obviously, infection can occur at any point of time, man. What is nursing care for? What is reverse barrier nursing? We are there to prevent that from happening, man. Yep. If in a person they give you image which is black, क्योंकि अब खून जो है, the blood has beginning to, the blood in this patient at the moment जो है, अब blood is getting reabsorbed. In this particular situation, this is left, this is right. What you have to note down is the patient is having a right. Then you will write chronic. Why chronic? Because it is black. Black in medical knowledge is called as hypodensity. Hypodensity. And then you will say that because it is concavo-convex, that is a chronic subdural hemorrhage. So what I wanted to solve for you is like what is the main treatment that will be done in this particular patient. Sir, mannitol to de hi sakte hain in any bleed in a patient, but it's not the main treatment. Will it control the bleeding? No, you have to rush the patient to the OT. And therefore, what you will do in this patient is that you will be in a chronic subdural hemorrhage. You can see diabetic patient fell in the washroom. Head slams against the wall. Over the 3 weeks, his son is saying, my dad has become forgetful, he's lethargic most of the time. So यहाँ पे एक, because the prognosis is bad, हम butthole surgery करते हैं. Surgeon will not operate on bad prognosis. Surgeon will operate on good prognosis, because if you are having a bad prognosis, तो क्या करेंगे? Decompression कर दो ना, then it is butthole that would be done in this patient. One of the commonest mistakes that people make is उल्टा आंसर करते हैं कि अक्यूट का आंसर बरहोल करते हैं, क्रॉनिक का आंसर जो होता है वो हम कर देते हैं, लाइक द पीपल टेंड टू आंसर क्रॉनिक का जो आंसर है दैट इज गिवन एज उल्टा. वेयरएज मैं तो टेक्स्ट बुक का रेफरेंस डाल दिया यार. In an acutely deteriorating question, this is textbook Harrison, he says in acute deteriorating question where the person is having large subdural hematoma which is venous, we would like to go for emergency craniotomy in a patient. So tomorrow when I meet you, I'm going to teach you regarding Arthik, that's a good one. So when I meet you tomorrow, I will talk about extradural hemorrhage. We'll also talk about when to give mannitol, when again to do butthole surgery in a patient. But I hope it is very clear what is the main treatment that you're gonna do in these patients. It is ulta, it is butthole for chronic, and it is a craniotomy for the acute subdural hemorrhage. This is like always. सर शेव करते हैं डॉक्टर साहब, कम ऑन, यू नो एनी न्यूरो सर्जरी से पहले बाल थोड़ी ना डाल देंगे. इफ यू डू न्यूरो सर्जरी वी डू प्रॉपर शेविंग मैन, यू कट द स्किन, ऐसे थोड़ी ना काट के ऐसे डाल है ना. यू शेव द स्किन, यू कट द स्किन, यू कट एपोन्यूरोसिस. स्कैल्प के लेयर होते हैं सर, स्किन, सबक्यूटेनियस टिश्यू, एपोन्यूरोसिस, लूज एल्वेओलर टिश्यू, पेरिओस्टियम, you cut through that, then you reach the skull, and that's the outer and the inner table of the skull that is deployed, obviously not the skin and everything else. Yes, yes. Peritoneal cavity, not abdominal cavity, no, peritoneal cavity. Okay, ji, guys. So we are sorted for today, and I'll see you again tomorrow. So same time, 12 o'clock is when we're gonna discuss many more technical aspects like this tomorrow. So I hope this session is a eye-opener session, that you realize that that you have studied, but at the same time, I have tried to teach you कि हाउ टू यूटिलाइज दोज ड्रग्स, कैसे इस्तेमाल करना है, किसको पहले यूज करना है, किसको बाद करना है, कौन से इन्वेस्टिगेशंस जो होते हैं वो ज़्यादा जरूरी होते हैं. तो यू नो द ओनली एजेंडा टू 12 o'clock, 12 o'clock ही करेंगे, 12 o'clock to 8 o'clock ऑप्टिमल टाइम. 11 to 7 रहने देना यार, तो वी आर गोना टेक अ स्ट्रेसफुल हो जाएगा यार, 12 to 8 ही रखते हैं, ठीक है. चलो, सी यू गाइस टुमारो, गॉड ब्लेस यू, एंड chill, enjoy, do questions, थोड़ा सो लेना अच्छे से, get good sleep, you need that. 8 घंटे सोया करो, 16 घंटे पढ़ाई करा करो. चलो, टेक केयर, गॉड ब्लेस यू, बाय बाय. चेंज कर दिया भाई, है ना. चलो, टेक केयर, गॉड ब्लेस यू, बाय बाय. 12 to 8 is the time.